in clinical trials: cystic fibrosis, DMD, sickle cell anemia, Huntington's disease. I would like to add here the eye disorders, Leber's congenital amaurosis. Actually, there is a trial going on for that. And all these occur because of mutations in single gene. There is one gene, I know the gene, I know the change in the gene that is causing the disease. That is the only way I can use CRISPR. I need to have this basic information before CRISPR can be used. Now, when I'm editing a gene, I can edit a gene in the somatic cells, that is in the tissues. And we know that anything that is changed in the tissue is a change for that person. It is not inherited. However, I can also change something in a germline. I can change it in the ova. I can change it in the sperm. I can change it in the embryo. These are heritable. The individual is affected and the offspring of that individual is affected. So we're going to touch a little bit about both these gene editing. The first, somatic gene editing, is actually, I'm going to take sickle cell disease as an illustrative example because one patient in the US has already been treated for sickle cell disease by CRISPR-Cas9. This is a big problem, we know. This and other hemoglobinopathies in India as well as in Africa and other parts of the world. What happens in sickle cell disease? The normal this is the sickle, this is the hemoglobin gene, the HBB gene. And in sickle cell anemia, there is a change of A to T. Because this A, one alphabet, has changed to another alphabet, it changes the protein that is formed because of the change in this codon. Okay, GTG now codes for valine, whereas CAC used to code for glutamic acid. So instead of glutamic acid being in the protein structure, we now have valine in the protein structure. And because of this, there is formation of hemoglobin sickle, which aggregates, which precipitates in the cell. And because it precipitates in the cell, it leads to this sickle-shaped RBC and sickle cell anemia. Now, when we are going to do a change in the gene, we can do it inside the body, we can do it outside the body. Now, this is an example because blood is freely available, it's there. We can take out the cells. So this is an ex vivo gene therapy. So the target cell here is removed and it is edited in the laboratory and then it is returned to the patient. So this is very easy for hematological disorders because you can take the hematopoietic stem cell and edit it to create a normal red blood cell. Okay. So what does the CRISPR-Cas9 here do? The CRISPR-Cas9 will edit the T. It will change that nucleotide back to A. And this is what is happening. So this is the abnormality. I told you the A is changed to T. We get the CRISPR-Cas9. It comes here, it finds this abnormality and it changes this T back to A. And when it changes this T back to A, it forms the healthy hemoglobin and the RBC is normal. Okay, and this then edited stem cell is transplanted back into the patient and the progeny of that stem cell will produce healthy red blood cells. This is one mechanism and it's easy for sickle cell because all patients with sickle cell have this one mutation. There are also other mechanisms of doing it. We have certain other enhancers. We also know that if we increase the production of hemoglobin F, we can decrease the phenotype of sickling. And there are other mechanisms, for example, if they suppress this gene, which usually decreases the formation of hemoglobin F, we suppress this gene, we get high levels of hemoglobin F and a healthy red blood cells because we have healthy hemoglobin that is now being formed. Now we have other disorders like Duchenne muscular dystrophy. Okay. Now these disorders that are disorders of the muscle occur because of changes again in the gene. The commonest ones are deletions or duplications in the DMD gene. Now it is not possible for us to take out all the myocytes or the cells to do an ex vivo gene therapy. So here we have to deliver the gene therapy into the muscle. How do we do that? We know in this case, there are 79 exons in the gene that occur one after the other. And you can see that exon 50 is missing. Because exon 50 is missing, the frame of this is disturbed. And because the frame of this is disturbed, it causes the disease phenotype. If I remove exon 51, 49 can pair well with 52. Okay? So if I skip exon 51, the frame is restored and I get a good protein. So again, we can use CRISPR-Cas9 to remove or edit out this exon 51. It has to be done in situ, and we have to find ways of delivering that CRISPR-Cas9 to the disease site. Now, we also had this first trial using a CRISPR agent inside the body, and this was done for an eye disease which is seen in children. It's called Leber's congenital amaurosis, which occurs because of this gene CEP290, and this is the one mutation that they targeted. Because of this gene mutation, the protein is not formed, and the children lose their vision by about 4 to 5 years of age. Here, what CRISPR does, it makes 2 cuts in the defective gene. It is injected into the retina. See, it's easily accessible. And we also know that we don't have to edit the entire gene. If we get 10% of the gene that is functional, it will restore some amount of the sight. But how do we get that CRISPR-Cas9 into the cells of the eye in the retina? To make the gene functional, we have to use vectors like we do for gene therapy, and they have used the adeno-associated virus vector. And within this is our CRISPR-Cas9 assembly, which goes to the retina, identifies the gene where this mutation is, and it clips it and then repairs it to now allow that gene to make a correct protein. What are the other uses beyond treatment of genetic disorders? It has also been used for treatment of infectious diseases like HIV. And this was a review that was written by one of our students, Dr. Sapna, who really understood this technology and was able to write it in a very simple manner in this journal. So here they had a patient who had HIV and also had ALL. So they did an allogenic stem cell transplant to treat the ALL. But within that, it was also identified that this specific gene is important for HIV. Okay. Now they edited this gene in the donor stem cell because they were doing a stem cell transplantation. The gene editing was done with CRISPR-Cas9. And this stem cell now was then given to the patient. So this was a double-edged sword. They were treating ALL and they were also trying to give resistance to the HIV virus to that individual. So though this was successful, it showed that this was feasible for infectious diseases. In this specific individual, the number of edited cells were too low and he still needed to have the antiretroviral therapy. But what was important was it was a proof of principle that it is possible and that there were no adverse events that happened as a result of this gene editing. The other clinical conditions where CRISPR-Cas9 is used is treatment of malignancies. Hematological malignancies, you would have heard of CAR T cells, where they are modifying the cells with the T receptor antigens. It is also used for solid cancers, primary immune deficiency. I've already alluded to pluripotent stem cells earlier. In other areas which are really not of direct concern to us as doctors, but yes, we are involved in these aspects, is they even talk about public health, where you alter the mosquito population to decrease the incidence of dengue and chikungunya, etc. And also in agriculture, there they are making tomatoes. The tomatoes are fine, but the number of tomatoes per plant is much higher. So it's a larger crop. And so we have modified plants. The thing that is not so good about CRISPR is the fact that, well, actually, I wouldn't say it's not so good about CRISPR. Long back, it was identified that they could do the same editing in the germline. And if you edit it in the germline, obviously it is inherited by the offspring, and this is a permanent change. The editing is always a permanent change. If we do it in the somatic cells, it's only for that individual. If we do it in the germline, it is for that individual as well as the offsprings of that individual. But CRISPR really came into disuse because of its misuse in clinical practice, where one scientist used embryo editing, and there was birth, and this was really to protect them from HIV infection, and it gave birth to twin girl babies, and this was in the late 2018, and there was an uproar in 2019 because this was two girls who are born with edited genome. And there was now a lot of global attention on the application of genome editing. And they realized that rigorous regulations were required to prevent changes like this. We are nowhere in a situation of making designer babies, and I'll come to that a little later. So we have ethical issues like it's a very powerful technology and it's a simple technology. So it's really a double-edged sword. There is a role of research at the embryo level because it guides us about the biology of malformation for various lethal forms of disorders, which we could never understand otherwise without the use of this technology. However, it is illegal and inappropriate to do germline editing that actually culminates in a human pregnancy. We are not in a stage of making designer babies because the human body is not so simple, and it's not as if we understand everything that goes into the formation of a designer baby. So I think, and it is there in literature, that we are far from this. But yes, we cannot alter human species. And we need a lot of regulations in place for this technology. There are limitations. We have edited the gene, but how are we going to deliver that gene to the correct cell, especially in vivo? We have viral and non-viral delivery methods, but then these need to be refined and modified more in the near future. Can we have off-target effects of this editing? I want to have a change in A, but by mistake, my CRISPR goes to point B and causes a change that can cause problems. And then because this is mutation oriented, we would have to customize it for different mutations. So to wrap up, it is transformative technology. There's no doubt about that. And it's a powerful toolbox in this era of precision medicine. And if we combine DNA sequencing and our knowledge of mutations in every individual that is responsible for the disease, and side by side, we have this genomic engineering, we can change a lot. And we can alter the DNA sequences. It's really powerful, but it's equally important to control the use of this technology, and that is a key. And my last slide this is Stockholm in Sweden, where the Nobel Prize winners are decided upon. This is the building which is called the Nobel Forum. This is the room where who gets the Nobel Prize is discussed and voted. And this is the poll box. And we know that this year we had the Nobel Prize in chemistry. It was shared by Emanuela Charpentier from Germany and Jennifer Doudna from the US for their work and identification of CRISPR. Thank you so much.
Thank you, Dr. Ratna ma'am, for an excellent presentation. We are extremely grateful to you for having made this presentation and opened up a whole avenue of discussions. We have got a couple of questions in the chat box, which I'll be asking, and then it will be an open forum for others to ask as time permits. So our president, Dr. Khirwadkar, has asked that how far has the CRISPR technology advanced in India? and what are the legal and ethical implications? You have been touching on these parts in between, but if you could just elaborate on it further.
So in India, we don't have any clinical trial which is ongoing with CRISPR, but yes, there are many groups, especially IGIB, who is working on CRISPR. And it's not a very difficult technology. We know that recently a kit, in fact, I should have mentioned that in my talk, a kit was made in India using for COVID-19 testing by the CRISPR method. So it's not a difficult tool to use. Yes, ethics is a big way to go. We have a lot of ethical guidelines for use of genetic technologies, tools, and disorders. And I'm sure with the use of CRISPR-Cas9, we will have local regulations also. There are worldwide regulations and those from the WHO, especially after that embryo editing was done last year.
Yes, ma'am. And thank you so much. And as you correctly said, we are not out to make designer babies. So one of our professors, Dr. Bang, has also commented that we should not be meddling with God's creations and God's methods. And I mean, it's a highly ethical issue. How far should we
Yes.
go in
Yeah.
nature?
There are places where they have discussions about even the research use of germline editing. It is predominantly a research use, but it's definitely not in clinical use. That is universal.
Yes, ma'am. Could you please elaborate on starting the treatment, like the CRISPR technology implementation in the fetal life itself? You did touch upon it
So in
briefly.
fetal, yeah. So there are some anomalies, there are some disorders that are lethal in fetal life. And because we are not able to identify the course in postnatal life, we don't understand the biology of those disorders. We don't understand why it happened, how can we prevent it. So that is the research use of this tool for lethal malformations and lethal genetic disorders.
So that emphasizes on our choice of the disorders which should be selected for implementation of this technology.
Yeah.
I open the forum for other members. Any questions from the delegates?
I think, ma'am, there are none in the chat box.
Yeah, they are not there.
Right. So move on, Lena.
If there are no questions, Shubda ma'am, should we be
move ahead? Yeah.
Okay.
Thank you very much. Thank you so much.
Yes, ma'am. Puri ma'am, we are
so
highly
much.
grateful to you for your excellent presentation. And we wish that we have more interactions with you on various fora and gain from your knowledge and experience.
Thank you. Thank you so much, Dr. Lina.
Thank you so much, ma'am. Thank you.
Thank you, Puri madam. Thank you, Dande ma'am. And thank you, Tiwari sir. With the due permission, I'd like to move to the next session. I would like to call upon the chairperson for the next talk, Dr. Ravin Belonde sir. He's an experienced pediatrician. He's the ex-president of Academy of Pediatrics, Nagpur. He's the executive member of Maharashtra IAP. Welcome, sir. I'd like to invite Dr. Vijay Dote, sir, to chair the session. He's the president-elect of Academy of Pediatrics, Nagpur 2021. He's a senior pediatrician at Saune, has been delivering his services since 1989. He's the associate professor previously at PDMC Amravati. Welcome, sir.
Good afternoon, everybody. I am audible?
Yes, sir.
So good afternoon, everybody. Welcome, Dr. Kuldeep, and welcome to NAPCON 2020. Today, the guest lecture is of Dr. Kuldeep Sukhdeve. He is a renowned consultant pediatrician, intensivist, and critical care consultant at Kingsway Hospital. He is a professor of pediatrics and head of the department at Chandrika Mege Medical College. He is guide to the various students and is CPS guide also. Today he'll be delivering a lecture on management of acute hepatic failure. The Dr. Sukhdev doesn't need any uh, introduction because he is known to everybody. He is a very good speaker and very good women being. So I request Dr. Kuldeep to start with the oration.
Thank you, sir. Thank you, Chairman Dr. Ravindra Belonde and Dr. Vijay Dote. Thank you, Madam Shubhada Thiruvadkar. Thank you, Secretary, my teachers, my colleagues, my friends, and my students. Uneasy lies on our head when we talk about acute hepatic failure, in a sense that all of those who are treating critical children have almost failed in surviving these children. And this is a fact. There are very few pediatricians who can say that they have that skill in their hand where they can save children with acute hepatic failure. Let us get into the discussion for next 10-15 minutes, and we hope that this comes up with latest information as to what we can do and where we fail, especially in Nagpur and central India. Hope it works, yeah. So let's begin with a very typical case all of us must have come across. An 8-month-old infant has a progressive jaundice for 6 weeks, has progressive irritability, poor appetite. When you examined child had liver of 5 centimeters, you thought he was probably in encephalopathy. While being investigated, his condition deteriorated. He was hospitalized in the ICU. 2 weeks later, he expires with acute hepatic failure and related complications. This kind of story is going on with me and my friends for last many years, and we haven't probably gone beyond it. So let us come down to what must be the right approach to handling an ICU management of acute hepatic failure. So which child should we say has acute hepatic failure? Somebody who has got an acute liver dysfunction, INR of 1.5 with hepatic encephalopathy. We know that in children with acute hepatic failure, we don't need to have hepatic encephalopathy. In that case, the INR has to be more than 2. And there shouldn't be any evidence of a chronic liver disease or a liver disease of some other variety from the past. What are the causes which leads to children with acute hepatic failure landing in the ICU? There are many causes, but most of the time, once we start to investigate in the ICU, because the time frame which we have with us is very small, we don't get a diagnosis. This is
मी म्हणत होते टायमिंग नीट बघा का, कारण आपल्याला खूप मोठा प्रोग्राम आहे.
This is true in
बिलकुल तुम्ही खूप छान केलं.
This is true in India, and this is true elsewhere also. And thus the specific therapy eludes the patient. The causes could be prenatal. For example, what we call as GALD or tyrosinemia and so on and so forth. There could be a lot of infections. They say that probably in India, there are more viral hepatitis leading to acute hepatic failure than any other reason. There are some patients of autoimmune hepatitis. There are lots of metabolic disease. Every pediatrician worth his salt has handled many cases of Wilson disease by this time. And we know that the final outcome had always been very discouraging. There are drug-induced liver injury. We know at least one drug which causes that, and that is sodium valproate. Some of our patients specifically being treated, INH. Some of those were being treated for tuberculosis, or those with acute or with seizure disorders probably land up with an acute drug-induced liver injury. The major chunk of diagnosis which we make is almost always idiopathic, probably because we have not been able to reach to a diagnosis. All of us know clinical manifestations. Manifestations are protean. It may just start with some of those symptoms of not eating well and vomiting and pain, and then rapidly landing on to develop hepatic encephalopathy. With one ominous sign to know, if there is a rapid decrease in liver size, be very careful. Hepatic encephalopathy, not every child were to have hepatic encephalopathy, but we know that the manifestations, at least to begin with, are so subtle that we may fail to diagnose it. But later on, as the time passes by, they can land up in stage 4 coma. You can get a West Haven criteria, which can absolutely tell you how the child, the infant or a child, has progressed in his hepatic failure. What are the reasons for which they probably get hospitalized in the ICU? Most commonly, a deepening jaundice. Second commonest is hypoglycemia, a GI tract bleed, seizures, hepatic encephalopathy. And what are the reasons for which they come come to the hospital, and what management does the critical care team offers? They offer team management for hepatorenal syndrome, encephalopathy, brain edema, intracranial hypertension, so on and so forth. And there most of the time, we say in India at least 99% of the time, we are only offering supportive management. We rarely come with a specific diagnosis, but at least in the coming slides, I can tell you at least what we shouldn't be doing, even though all of us know what are the steps to manage or a supportive management of hepatic failure. So why are we keeping in the hospital if the outlook has been so dismal? Or why are we managing? Possibly because if we can allow some time, probably some of the liver function is likely to recover. And as the time passes by, here in Maharashtra, as we see, at least in Mumbai, there are many centers for liver transplant. In Nagpur, we are now probably in a year or so create a liver transplant program for children. We can at least minimize complication and put them into a liver transplant program. As more and more hospitals have this transplant program, the expenditure is going to reduce. Why do we transfer, or when do we transfer into the ICU? So you have a clinical evidence of encephalopathy or an EEG evidence of encephalopathy. Factor V activity has become less than 50%. Prothrombin index has become less than 50%, or now there is an organ dysfunction. What are the general supportive cares we offer? The general supportive care which we offer mostly is for cerebral edema management. It has to be extremely aggressive, and the tactics is to minimize precipitating situation, which would probably then aggravate hyperammonemia. Hyperammonemia aggravates cerebral edema. And the plan is to give less nitrogen or the less protein to the child, to as much as less than 0.5 gram per kg per day. So it means in a 10 kg child, not more than 5 grams in a day. Plan. So now this is something which all of us have been doing. This is something which is fairly eye-opening for us, is while we are handling acute hepatic failure, avoid fresh frozen plasma. Giving fresh frozen plasma actually offers more nitrogen. Another one is administration of oral and rectal lactulose. If there is no need, there is no severe constipation, don't use it. Don't use medicines like neomycin and rifampicin. Possibly, rather than using any of this, send the child to a dialysis team and start with hemofiltration. So your nephrology team is likely to help you more in this hepatic care. Another one is, while we keep in the ICU, minimize neurosensory and painful stimulation. So quieten the room, darken the room, have less nasopharyngeal aspiration, and so on. How do we treat? If we have evidences of intracranial hypertension, offer mannitol. And just for the sake of it, that is likely to develop intracranial hypertension, don't start offering mannitol because it has its own set of problems. What about hyperventilation? We talk about hyperventilation. Yes, it does work. It can quickly lower the ICP, but we must be very careful that while the temporary ventilation is very useful for the intracranial hypertension management, if we continue to hyperventilate the child and continue to ventilate the child, they're likely to have lesser chance of survival. There are a few more drugs which we can probably offer. One is hypertonic sodium chloride and thiopental. And in many pediatric ICUs, they have started handling these patients with moderate hypothermia. Another one complication or the problem which comes up with acute hepatic failure is hemorrhage and digestive tract bleeding. So once they start to bleed, we start to offer fresh frozen plasma. But we know that in case we just keep on offering fresh frozen plasma, it may actually worsen the situation. They might actually do well on vitamin K supplementation, platelets if there is a need, and some fibrinogen using FFP and cryoprecipitate. Another situation which we need to handle is because of hepatic failure is a renal failure, that is because of hepatorenal syndrome. They must be very aggressively put into dialysis program. Do not offer acetylcysteine, and no absolute advantage by offering terlipressin. And every effort should be made to see that we don't keep on offering intravenous drugs which are later happens to be nephrotoxic uh, in nature. Another problem for which we are likely to be facing is cardiopulmonary failure. And if we have that thing, see to it that we give fluids, but continue to have a repeated echoes by pulmonary artery pressures, preload conditions, and contractility, because we never know from hypovolemia how fast we can actually land up with hypervolemia, and we can come in deep soup. The very important thing is when we see that they are not breathing well. Nowadays, most of the ICUs are putting children on BiPAP. See that we absolutely avoid BiPAP, because the moment we put them in BiPAP, these children are mostly having grade 3 or grade 4 encephalopathy, and they tend to aspirate again and again. The metabolic problems which come in, the most common is hypoglycemia. We know that there are many reasons for it. See that we are monitoring glucose and offering glucose as needed. There are many further metabolic problems which can come in. Most of these drugs which I was talking about can lead to hyponatremia. Be very specific, because hyponatremia itself can lead to intracranial hypertension. About the nutrition, see that the protein intake is very less, and many ICUs offer branched chain amino acids, which actually doesn't work. Now I was talking about whether there are few therapies which can be targeted, and we can have a much better outcome. So there are few of them. At least we know that in autoimmune hepatitis we can give prednisolone, in herpetic hepatitis we can give acyclovir. The list is very small in India, not very large. But we must know that there is no therapy in this world which can reverse the hepatocyte injury or promote hepatic regeneration. Coming down to this is where the cutting edge technology is likely to help us. That if we have a child with liver problem or a hepatic failure, and if we can push him to liver transplant, these are possible 4 things which can keep him alive till he can land up with a liver transplant. One is hemodiaphyte filtration, high volume plasma exchange, albumin dialysis, and something called MARS. Okay, these are the details of MARS. But before I end the topic, because the time given was very small, let me come out with a take-home message. It's a multi-organ dysfunction, and that's why multiple problems you'd be facing. All children do not show evidences of hepatic encephalopathy. There are various etiologies, and many times we can't reach to it. And early identification is likely to offer some specific therapy, and that is why whoever is handling the child with hepatitis or hepatic failure should be very aggressive on finding out what led to it. And last but not the least is no point offering a lot of FFP and N-acetylcysteine. It doesn't work at all. Thank you very much. If there are questions, please.
Thank you, Dr. Kuldeep, for such a nice and apt description.
Very fast.
Of management of acute hepatic failure in such a short time.
Yeah, it was very fast.
As you have aptly pointed out, one of the cause of acute hepatic failure in a child is irrational use of multiple drugs for simple clinical problems. We should be cautious and use minimum necessary drugs for treating pediatric diseases. Now there are 3 questions in this work. So I shall. One question is, how common is lymphoreticular malignancy as a cause of acute liver failure in an infant?
It's very uncommon, sir. People might have come across these malignancies, leading to such problem, but the diagnosis itself is very, very uncommon. And thus acute hepatic failure, it doesn't come into top 10 or 20 or 30 possible causes of acute hepatic failure.
Thanks, Kuldeep. Second question is, suggestion on restricting protein intake for a 2-month-old baby who is on exclusive breastfeeding?
I guess if he is exclusively being breastfed, he probably is not landed into 3 or 4 hepatic encephalopathy. You can allow him to breastfeed.
Okay, thank you. And last question is, when to refer for liver transplant? The question is by Dr. Nitin Manwani.
If you have a child with acute hepatic failure and there is no sign of recovery, it should immediately tell you in your mind that this is a child for acute hepatic for liver transplant or LT. Or rather, I would say other way, that if you have any child with acute hepatic failure, you must talk to your LT team. Like Bombay, you got Global Hospital, you could talk to them that I have a child with hepatic failure, he may land in, because it's all about getting a liver also. It all takes time. So if you have a child with acute hepatic failure, it should trigger in your mind, and every patient then becomes a potential patient of LT.
Thanks, Kuldeep. And thanks all the delegates for their sincere listening. Thank you.
Thank you.
Thank you, madam. I have a query, sir.
Yes, Anju, madam, bola.
Sir, in case the child is bleeding, so you said there's no, you would like to avoid FFP. In that situation, do you prefer cryo along with vitamin K?
Let me come down to this thing. The whole gamut of the whole world of acute hepatic failure was finished in 9.5 minutes. So I'm coming down to it. Does it mean that fresh frozen plasma is contraindicated? No. But what happens is, you have a child with acute hepatic failure. He is in grade 1, grade 2, grade 3 encephalopathy, and you know that the liver dysfunction is there. So what happens is, the consultant comes and says, "Do FFP subah lagao, do FFP raat ko lagao." This is what I'm talking is, stop it. No point in doing it. And there's a wonderful slide. I don't want to waste everybody's time. Why we don't give FFP? While we are saying that both coagulants and anticoagulants come down. So the risk of bleed actually reduces. And there's no point in offering this FFP. And are you offering more and more nitrogen, creating hyperammonemia, and then heading for hemofiltration, asking your nephrology team to get into the picture? We ourselves are complicating it. But the patient has failed. Your INR has gone up above 2. You think now this is a time for offering FFP. As far as fibrinogen is concerned, now there are multiple labs in Nagpur which do fibrinogen levels. So if you feel that fibrinogen is low, it has gone below some 70, 80 or something like that, you offer cryoprecipitate oblique the FFP. There's no point. There's no problem. But unnecessary, unregulated, unrestricted use of FFP, number one, has to stop. That's number one. Very, very important. हर पेशेंट जिसको जॉन्डिस है सीरियस हो गया तो एक N-acetylcysteine का इंजेक्शन चालू करो. That has to stop. Very importantly. Now these two very important.
Thank you, Kuldeep. Thank you very much.
Thank you. Thank you, everybody.
Thank you so much, sir, for such a crisp talk after the crisp hour.
Thank you.
Thank you.
I'd like to thank the chairperson. With this, I'd like to move on to the next session. I would like to call upon Dr. Vinky Rugwani, sir, who's very well known to all of us. He's the president of Maharashtra Medical Council. He's the president of Central India Thalassemia and Sickle Cell Society. And he's been a member of State Blood Transfusion Council as well as Maharashtra State Pharmacy Council. Welcome, sir. I'd like to also invite Dr. Ashish Chandak. He's a well-known practicing pediatrician at Saune, and he owns a hospital named Deep Bal Rugnalaya. Since last 12 years, he's been offering his services at Saune. Welcome, sir.
Thank you. Good afternoon. The next speaker is none other than our own Dr. Shilpa Hazare. She actually doesn't need any introduction because almost everybody knows her, but then I will have to say something about her. She is a chief intensivist and pulmonologist in Getwell Hospital and Research Institute, Nagpur, practicing intensive care since last 15 years. She is a chairperson of PISCC Nagpur, former vice president, member of IAP, so local national faculty and university teacher. So there are many other things she is having. Today's topic is very important one, that is on sickle cell disease, and especially the lung involvement in sickle cell disease. We all know that sickle cell disease is very prevalent. It's very common in our part, in central part of India, and lung involvement is really responsible for morbidities and mortalities in sickle cell disease. So I'm sure that Dr. Shilpa will enlighten all of us. She will be telling about the acute involvement of lung as well as the chronic of sickle cell disease on the lung. So Dr. Shilpa Hazare, please. Dr. Shilpa, mic, your mic, you just unmute your mic. You are not audible. Just now, it's okay.
Okay. So basically, sickle cell disease is very, very prevalent in our region, and we know that lung bears the burden of that. There are many pulmonary complications which can be acute or chronic, and they ultimately are responsible for significant morbidity and mortality in these patients. Acute manifestations like acute chest syndrome and LRTI are common, and there is a significant chronic lung disease in these children. We all know about acute pulmonary complications because we are managing day to day. So I am going to be brief as far as acute manifestations are concerned, but we need to pay some attention to chronic pulmonary complications in these children, so that we give a reasonably good kids handover to the adult speciality, and ultimately have a better outcome of these children as an adult. So basically, acute pulmonary complications are the most frequent cause of death in children, but chronic pulmonary complications, which we see less but we can do quite a lot for that, they are the cause for reduced exercise tolerance, poor quality of life, and ultimately the most important is reduced lifespan in these children. Acute chest syndrome, as we all know, that it is caused by either an infection or vaso-occlusion or fat embolism. There are a lot of associated comorbid conditions in this sickle cell patient, which increase ultimately the problems in this patient. So basically, immunodeficiency secondary to functional asplenia in these children, even the neutrophil component has a problem. 20 to 50% of the sickle cell disease children do have asthma associated. Sometimes it may be the association, or sometimes because there is a lung, whatever the lung lesions are there, they ultimately heal by fibrosis, and then once the fibrosis sets in, you have a wheezing. So it's a there are two mechanisms by which bronchial hyperresponsiveness is seen in sickle cell disease patients. Other thing is obstructive sleep apnea and atopy, which these all are associated comorbidities which increase the morbidity in these children. So we'll just be brief about acute chest syndrome. So this is a clinical criteria. So we have to have pulmonary infiltrates on the chest x-ray, which should involve at least one complete lung segment, and there should not be that should not be the atelectasis, and one of the following signs or symptoms, so either a cough or a respiratory distress or a chest pain or wheezing or crepitations, fever and hypoxia. So this is basically a clinical criteria. Let's see on a flow chart that if these symptoms are there, and but clinically if you examine the child and there are no crepitations or no reduced breath sounds, or on percussion also there is no dullness, but these symptoms are there, uh, uh, if these are not there, then you need to do a chest x-ray, and if they are there, you straight away can start acute chest syndrome therapy. But if these are not there, then you do a radio x-ray. If x-ray has infiltrates, then again you have acute chest syndrome. But if the symptoms are there, but clinically, and you have clinical signs also, but chest x-ray does not show chest infiltrates, then you need to monitor the clinical course of these children. You need to have saturation monitoring of these patients, and accordingly, whether they may land up in acute chest syndrome, or you may just optimize analgesia and other treatment in these children. Now once you know that they are fitting into the clinical criteria, and they are acute chest syndrome patients and they are hospitalized for further management, in those children you need to do a set of investigations like CRP, CBC, ESR, ABGs. You need to see what is the reticulocyte count, because that tells you the indirectly that how much sickling is happening, and other markers of hemolysis like LDH, bilirubin and haptoglobin, other things like electrolytes, creatinine, blood culture, sputum culture, urine culture, and of course we need to be checking their doing their pulse oximetry, monitoring their ECG, and other clinical repeated recurrent clinical examination has to be done. Now what treatment has to be given, that we actually all know that IV fluids, oxygen, antibiotics, there is a preferably it should be a third generation cephalosporin, or one can use ampicillin plus beta lactamase inhibitor, and we have to add macrolide to that. If MRSA is suspected, or if MRSA is there on the in the culture, then you need to add vancomycin also. Inhalation of beta 2 sympathomimetics if there is a need, and balanced IV hydration and analgesia as per the comfort of the child. Physiotherapy, and most important is incentive spirometry in these children, because that is going to help them quite a lot. So when should we transfuse these kids? We all know that the hemoglobin, when it drops less than 2 gram of the baseline, that is a time when we need to transfuse. If it's very late and if the child becomes very severe, then probably transfusion doesn't help much, or so it should be much early in the course, but it should be not too early also and not too late also. And if the PaO2 is decreasing, then obviously we need to ventilate that child. In very sick kids, you may need exchange transfusion also, and if the facilities are existing, ECMO also. So very brief we have covered. So I just want to cover more on chronic lung disease in children. Now chronic lung disease in children, it occurs secondary to fibrotic remodeling of the lung, and ultimately it occurs due to changes in the structure and function of the endothelium, and of course metabolism of nitric oxide, so free radical injury is also significantly there. These chronic respiratory complications, they do involve pulmonary vasculature, parenchyma as well as the airways. They alter parenchyma as well as the airways, and 30% of the children of sickle cell disease do have abnormal lung function after 6 years of age. So that tells that there is a significant proportion of chronic lung disease in sickle cell children. Basically, small airways are compressed by congested peripheral pulmonary vessels, and that can cause obstructive pathology in the initial stages. Because of the compression, there is a airflow limitation. If airflow limitation is there for a longer time, then ultimately it leads to lung volume loss. Later, fibrosis sets in, and once the fibrosis sets in, restrictive pathology starts and progresses. The third thing is it can also have obstructive sleep apnea. The restrictive lung disease along with obstructive sleep apnea both will ultimately cause left ventricular diastolic dysfunction, and then that ultimately progresses to pulmonary hypertension and cor pulmonale. So as far as pediatricians are concerned, we rarely see pulmonary hypertension and cor pulmonale in children. That's a manifestation mostly after the second decade, but till that time we have to take care so that these complications, if they have to occur, they should occur very very late and not early. So we are we play a crucial role in increasing the lifespan of sickle cell disease children. So if we look at how are the lung functions in these sickle cell disease children, if in first decade, if we see, it's generally a obstructive pattern, and we do see that they mostly come with wheezing episodes, or even the acute chest syndrome, it comes with a wheezing episode. And if there is a secondary bacterial infection or LRTI, there are crepitations also along with that. In second decade, the restrictive part slowly increases, and you may have a mixed pattern initially, and later on towards the end of second decade, the restrictive pathology is set in, and in the third decade you have decreased total lung capacity and the diffusion capacity also, and ultimately they land up with interstitial lung disease. The most important point which I want to tell is that decreased FEV1 is associated with earlier mortality, and that is very very important, and that tells us that we need to monitor lung function in these children, especially after the age of 6 years. So if we see the flow chart, you always check for FEV1 by FVC ratio, and if that is normal, then you just check what is FVC. If FVC is normal, then you label it as a normal lung function, so no need to worry about these children. But if the FVC is low, then you check for total lung capacity. If that is normal, again you need not worry about these children, it's a non-specific thing. But if total lung capacity is low, that tells us that there is a restrictive pathology. And if FEV1 and FVC is low, then again you need to check what is FVC in that ratio. Now, if the FVC is normal, that is obstructive pattern, which is mostly seen in first decade after 6 years. So from 6 to 10 years, this will be the path they will follow. And if the FVC is low, then again we need to check total lung capacity. If that is normal, then again it's an obstructive pattern. But if that is low, then it's a mixed pattern. So this is how you interpret the lung function test of these children. The second comorbid condition, which actually we completely ignore, especially in this part of country, is obstructive sleep apnea, and that increases the risk of intracranial arteriopathy and CNS events in sickle cell disease children. So screening of OSA is very very important, and it should be done in all children with abnormal overnight saturation. So it need not be persistently low saturation, but if there are intermittent dips, they need to be checked for OSA. Also in children with abnormal lung function, and in children with enuresis, because enuresis is known to be associated with OSA. Now, these are the factors which are associated with poor cardiorespiratory fitness, and these are degree of anemia, low HbF level, restrictive lung disease, in short, multiple episodes of, in fact, acute chest syndrome, which ultimately leads to restrictive lung disease, left ventricular diastolic dysfunction, and exercise-induced bronchospasm, or otherwise also asthma. So what kind of radiological changes we see? So basically, if we see plain radiographs, there are segmental or subsegmental atelectasis or consolidation, and there is a predilection for the lower lobe involvement in sickle cell disease. You may see pleural effusion also, or sequelae such as bone infarcts or rib enlargement or cardiomegaly secondary to anemia. So just this is like here also the haziness is seen, and it's mostly in the lower lobe. Here again it is in the left middle and left lower lobe. So again you can see that there is a predilection for lower lobes. Sometimes they can present with the round pneumonia like thing, and here actually otherwise there is a diffuse increased bronchovascular marking, but you can see sometimes you do see avascular necrosis or bone infarct in the chest x-ray also. Even ultrasound is a very good method, which is actually radiation free and can be used many times. That can show alveolar consolidation, that can show air bronchograms or pleural thickening and loss of lung sliding. Or the picture which is shown is, it is showing lung rockets, and that tells that there is a significant interstitial syndrome. And if this is there, and if this is there on persistent basis, these are the children who are likely to have ultimately thickening of interstitium and the restrictive pattern, and they can also show pleural effusion. So if you do a CT, and especially if there is lot of interstitial fluid or pleural effusion, you may see a mosaic pattern. So here actually there is no pleural effusion, but there is a interstitial fluid, and so you see a mosaic pattern in on CT chest. And this is again, CT can show consolidation. Again here posterior basal consolidation is seen, so predilection to dependent parts of the lung. And my take home message is that one should be, so what can we do? So there are certain things which pediatricians can do, which can improve their quality of life as a adolescent also, and ultimately then later on as an adult also. So we should be vaccinating these children against Hib, pneumococci, Neisseria meningitidis, influenza A, and now ultimately even the COVID at a young age, so that the recurrent infections should be avoided, because those will be ultimately causing fibrosis in the lung, or will have a sequelae in those children. So if we vaccinate them early, we can reduce their morbidity. Early intervention to prevent disease progression if pain or fever occurs, because every episode of acute chest syndrome is going to have sequelae, and if there are multiple acute chest syndrome, they are equivalent to ultimately restrictive lung disease. Aggressive management of asthma, atopy, and obstructive sleep apnea is very, very essential, as I already showed you that how they ultimately affect the left ventricular ejection diastolic function, and ultimately have a problem. At least one 2D echo has to be done before the age of 18 years, and their basal left ventricular diastolic function has to be documented, as well as tricuspid regurgitation velocity has to be documented before the age of 18 years. And after, because if we detect problem earlier, you can do some interventions in them. And after the age of 6 years, we should be annually checking their spirometry. Annually should nocturnal oximetry should be done, and if there is a problem in nocturnal oximetry, you may confirm it with polysomnography and the treatment of OSA as per their requirement. And we need to help these children so that we can do something for heralding the chronic lung disease. we all know that hydroxyurea helps them significantly for many things, and the same way there are a lot of studies which have shown that the early introduction of hydroxyurea, it does reduce the annual rate of decline in FEV1, and ultimately if FEV1 is going to get not reduced for a long time, we ultimately are increasing their lifespan. Encourage a regular moderate exercise program as it improves lung function, overall inflammation and oxidative stress. But high intensity exercises and contact sports, or any sport where the temperature is going to fluctuate significantly, like in cricket, if they are standing in the ground for a very long time, that should be avoided because that can cause sickling in these children. But moderate regular exercise is going to help these children. Thank you.
Hello. Thank you, madam.
Any questions?
Any questions? Thank you, madam, for this very elaborative talk. And we all know the acute lung, acute chest syndrome in the this sickle cell disease. Mostly we see work in this Vidarbha area. The peoples are this is the most common cause of mortality. But as the healthcare facilities are increasing, the acute chest syndromes and other mortalities we are tackling whereof we must see, and the age mortalities are decreasing. We must see the chronic lung diseases in sickle cell disease. That's a very new topic to me. That's a very good, helpful. Thank you for the topic. There are some questions from the audiences. There are questions from audiences there. Yes,
Shilpa, I want to just want to ask you, one of the slides shown that in sicklers, asthma prevalence is almost from 20 to 50%.
Yes.
But I think practically don't see asthma so much in sickle cell disease. So I don't know from where this figure.
Sir, many times what is seen is basically that's what I told you, that the pure asthma, like they are presenting with asthma without any acute chest syndrome, and the ultimately because of multiple acute chest syndromes or because of multiple acute lung injury, they ultimately develop lung fibrosis, and once the lung fibrosis is set in the earlier stage, they are going to wheeze. So if you do a pulmonary function test in that stage, they are going to have obstructive pattern. So many times the mild variety of these children we are missing, because every time we consider that it's a viral infection and we do nebulize them. Our patients also many times feel that okay, they are fine, but when you do their pulmonary function test, it is found that, because there are a lot of studies which have shown that there is a significant proportion of obstructive pattern seen. And even this is basically that even if they are not very badly symptomatic, they should be given inhalation therapy in these children so that the morbidity decreases. This is just to increase, because if we give a structured program to them, that if we are investigating them properly, or if we are treating them in a very mild pathology, they can live up to sixth decade. Otherwise, we don't see any sickle patients living up to sixth decade in our region. If we have so many sickle cell children, so we need to. So this is just, in fact, I thought that that is why I wanted to talk more on chronic lung disease. That is, it is very, very essential that we give a good quality care to them, and ultimately, as an adult, we should be giving them good lifespan. So even if they are not very symptomatic, if their pattern is obstructive, they should be treated. So that asthma is not just asthma, it is also the disease process which is causing bronchial hyperresponsiveness.
True, madam. True. Okay. Thank you very much, madam. As there are some questions from the audiences, they say that Yes, there is a macrolide indicated in all children with acute chest syndrome.
See, that is what is recommendation, because whether you use a third generation cephalosporin or you use a amoxicillin with beta lactamase inhibitor, macrolide has to be added, because there is no in these children you can't take like you can't wait for a long time, because they may deteriorate, and by and large after 6 years or once they are school going, the mycoplasma has a significant role, because apart from capsulated organism, mycoplasma is one thing which is very commonly seen in these children. So as per recommendation, that has to be added.
Thank you, madam. As there is no, we are out of the time. Thank you for madam for the very good topic, very elaborative, and it's a very eye opener
Yes.
to us. Thank you for the all delegates are listening.
Yeah, thank you, Shubda madam. Thank you, Rugwani sir. Thank you, Dr. Chandak, and all the team IAP for giving me this opportunity. Thank you.
Thank you very much.
Thank you.
Thank you, ma'am. Thank the chairpersons for the session and Shilpa ma'am for sparing the valuable time. With this, we'd like to move on to our next session. I'd like to invite Dr. Archana Jaiswal, madam, who will be coordinating the session. Over to you, madam.
Thank you, Anju. So after these mind-blowing sessions and CRISPR sessions, we move forward in the academic feast, and we have this vaccine session, which is very important. To start with this, our speaker, Dr. Rajendra Khadke, for an update on hexavalent vaccine, and the chairman for this session are Dr. Chetan Shende, who is consultant neonatologist and pediatrician, and also director of Colors Children Hospital and ex-secretary of AOP Nagpur. I welcome you, sir. And to join him, we have Dr. Anil Jaiswal. He is a senior pediatrician and neonatologist of Nagpur since last 30 years. And he is director and owner of NeoCare Children Hospital and Jaiswal Children Hospital. And he is also past president of our AOP Nagpur. I welcome you, sir, and over to the chairpersons. Hello.
Hello.
Yeah, over to chairperson, sir.
Yeah, am I audible?
Yes, sir, you are audible.
Okay. Good afternoon, friends. Chetan? Yeah. Good afternoon, friends. Archana?
Sir. Sir.
You are audible, Dr. Jaiswal. Please continue. Dr. Jaiswal?
Dr. Chetan Shende and Dr. Anil Jaiswal. Dr. Chetan Shende, sir. He's joined, but he's not hearing.
Dr. Chetan? Okay. I think we have Dr. Khadke with us. You can continue. Archana?
Dr. Jaiswal, sir, you start the session, sir.
Ask Chetan to unmute his mic. He has not unmuted his... Chetan Shende not unmuted.
Dr. Chetan Shende, Dr. Anil Jaiswal, please take over.
Yeah, madam. Am I audible?
Yes, sir. Yes. Go on.
Good afternoon, friends. Yeah, thank you. Good afternoon, friends. At the outset, I want to congratulate Dr. Shubda Kirvatkar, our president of Nagpur IIP, and Dr. Mustafa, secretary IIP, for bringing this NAPCON, which is a very prestigious function for our Nagpur IIP on virtual platform. Today, we have a brilliant speaker amongst us, Dr. Rajendra Khadke, who is a renowned pediatrician from Aurangabad, practicing since last 23 years. He is a owner and director of the Varad Medical Foundation, Aurangabad. He is one of the pioneers in pediatric critical care in Marathwada region. And he has been faculty in many pedicons. He is a national faculty in immunization schedule also. And he has many feathers to his cap. Today, he will be guiding us with an update on hexavalent vaccine. So, it's instead of wasting much time, I hand over the mic to Ms. Dr. Khadke for his presentation.
Yes, Dr. Khadke.
Dr. Khadke, sir? Ma'am, he was inside. He is left or what?
Okay, we move on to the next speaker.
Okay, ma'am. So the next speaker for today is Dr. Rajiv Mohta, sir, and the session is for all about flu. And for this session, I invite.
Yeah, Dr. Khadke is here.
Okay.
Dr. Khadke is here. Sir, please take over. Dr. Khadke.
Yes, ma'am.
Yeah, sir, please take over.
At the outset, let me thank organizers of NAPCON for giving me an opportunity to talk in front of such a elite audience of Vidarbha and Marathwada. I bring greetings from Aurangabad. What I'm supposed to talk today is updates on hexavalent vaccine. As far as the history of hexavalent vaccine goes, we know that we have a trivalent vaccine right from 1948 and acellular pertussis vaccines in 1990. The quadrivalent was basically addition of Hib. Later on, pentavalent was added, and hexavalent is there in global market for last 20 years. The wholesale pertussis containing hexavalent vaccine is just recently added to the basket of Indian market in 2017. Now, all of us know that there are different advantages of combination vaccines because we are protecting all these children against those 6 deadly illnesses like diphtheria, pertussis, tetanus, hepatitis B, and Hib. In addition to that, IPV is also given, which is very important for protection against the polio. So obviously, the advantages are there are minimal number of visits and minimal number of breaks, and there is increased compliance because of number of visits which are reduced by the parents. And the coverage is very good. So because the coverage is very good, we are likely to get over all these 6 deadly illnesses in a very short duration of time if we use combination vaccines. It also increases reduce the risk of needle stick injury because of now less number of pricks to the health volunteers.
Sorry to interfere, sir. Do you want to share your screen?
Madam, I am sharing my screen.
No, we can't see it, sir.
Oh. Sorry, madam. I was thinking that I'm.
We will share the screen from our side.
No,
Can we share it from our side?
No, sir.
If there are challenges?
No, madam. Just give me a minute.
Yeah, okay. Yes. Yes, we
Am
can
I
see
audible
it.
and visible?
Yes. Please go ahead.
So nice of you to give me such a bonus time. So, should I start right from the beginning? So, history of hexavalent vaccine goes from trivalent vaccine. We had come to quadrivalent vaccine, then we had come to pentavalent vaccine, and now we have hexavalent vaccine in our basket. 2 acellular hexavalent vaccine has been there for quite a long time, and a wholesale pertussis containing hexavalent vaccine has been recently added in 2017 in Indian market. All of us know that the combination vaccine works better than a solo vaccine because number of pricks as well as number of visits to the hospital are reduced, and there is increased compliance and increased coverage. Because of that, we will be able to have a less incidence of all these vaccine preventable diseases which are covered in the hexavalent vaccine. It also causes reduce in risk of needle stick injury to the health worker which is providing this vaccination. So there are challenges for vaccination in combination. It is not simple that we are creating some antigens from different parts and making a solution and giving it as a hexavalent vaccine. The solo antigen, which was causing a good response as far as the antigenicity as well as the seroprotection, has to be preserved in combination vaccine. So all these vaccines antigens need to be harvested as a solo antigen, and they should perform equally well when you are combining it in an hexavalent vaccine. Now, extra dose of some antigen is inevitable. As we see in hexavalent vaccine, we have hepatitis B as well as HIV, which is given as an extra dose and which has to be accepted because it doesn't damp the antibody response of other antigens. So it's a long process and a quality control is necessary, consistency is necessary, and reproducibility of this vaccine antigen is necessary. So it is more expensive. The only point which is against all this is if you have anaphylaxis with hexavalent vaccine, then the candidate is not titled or entitled for all these antigens to be used in next prick because we don't know which antigen has caused allergy to this child. So the development of this hexavalent vaccine literally takes around 10 to 12 years, right from the preclinical stage to the marketing stage and packaging stage. And if you will be surprised to see that the 70% of the time which is spent is on quality control and reproducibility rather than only production of vaccine. Now, when we are talking about this hexavalent vaccine, now what is the role of IPV in current scenario? All of us know that India is a polio-free country from 2014, and the switch from TOPV to BOPV has occurred in April 2016. Now, before the switch, we were supposed to prime these children with IPV because we are removing type 2 polio from this TOPV and creating only BOPV available for the market. So unfortunately, because of the global switch from TOPV to BOP, there was an acute shortage of IPV standalone. So we had no option but to use only hexavalent vaccine in private practice. Government has tied over this crisis partly by using intradermal fractional IPV in their national immunization schedule. And this fractional IPV is given with the first dose of pentavalent vaccine and a third dose of pentavalent vaccine. Whether really it is useful or not, let us see with this study which has been there in India as well as Bangladesh. Bangladesh used a micron jet injector for intradermal vaccination, while India is using only needle for the intradermal vaccination. So if you see the seroprotection, which is against type 2, which is really a priority, though we are not seeing any type 2 polio in globally for last 20 years, the population which has born after switch needs to be protected from this type 2, and the protection which is offered by intradermal is only 70 to 81%, which also says that we need to have a standalone IPV to be used in immunization schedule so as to prime these children from polio. So what is the schedule of hexavalent vaccine? All of us know that we are using this hexavalent vaccine at 1.5 months, 2.5 months, and 3.5 months as a primary series, and we are boosting them at the age of 16 to 18 months and 4 to 5 years of age. Let me clear at this moment that there has to be a booster has to be after 6 months of the last dose of primary series, and maximum number of doses we can give is only 6 because of the side effects and reactogenicity of the vaccine, and it cannot be given more than 7 years of age. Contraindication for all these hexavalent vaccines, whether they contain wholesale pertussis or acellular pertussis, the hypersensitivity and encephalopathy after vaccination within 7 days is the only contraindications, while precautions are severe acute illnesses and progressive neurological illnesses. So as such also, we do not vaccinate anybody who is coming to your OPD with severe acute illnesses because the onus would go on a vaccination rather than the disease which the child is harboring. What are the differences between these wholesale pertussis and acellular pertussis? The wholesale pertussis, all of us know that is highly reactogenic, while the acellular pertussis is less reactogenic. The efficacy data from the developing countries has been corrected, and there is a paper which says that there is a variable efficacy of wholesale pertussis across these developing countries, and it ranges from 36% to 96% and varies from batch to batch. While the efficacy of acellular pertussis has been consistent between 84 to 85%, and the side effects of wholesale pertussis like encephalopathy, febrile seizures, HHE response, and inconsolable cry more than 3 hours in first 48 hours of vaccination are 75% less in acellular pertussis vaccine than a wholesale pertussis vaccine. The only debatable thing which has been there is wholesale pertussis has a prolonged immune titers up to 3.5 to 7 years as compared to the acellular pertussis, which is at least for 5 years they would last as protective antibody titers. But this range of 3.5 years to 7 years is only because of the variable response of wholesale pertussis in developing countries. Now there are mechanisms which are always talked about. This is a baboon model and mouse model, which is very well known studies. They say that basically wholesale pertussis vaccine works through a response which is called as Th1 and Th17 response, which is necessary for a herd immunity because it decreases the transmission of Bordetella pertussis and have long protection because of stimulation of memory cells. So this mechanism through which Th1 and Th17 response makes a wholesale pertussis vaccine better than a cellular pertussis vaccine. That was what was the presumption previously when the cellular pertussis vaccine came with hexavalent IPV addition. So in addition of a hexavalent vaccine with IPV, which was ssRNA was a carrier protein which was used for IPV, which has an adjuvant effect on our innate immunity. As we know that the total toll-like receptors 7 and toll-like receptor are 8 are important for your Th1 and Th17 response, and so this cellular pertussis vaccine along with IPE works as equal or as good as wholesale pertussis as far as the longer protection as well as the herd immunity or decreasing the transmission of Bordetella pertussis. And this is the paper which is supporting it with the vaccine that is said that Th1 and Th17 response can be possible with a cellular pertussis containing vaccine, hexavalent vaccine, which has an IPV. Now, what is there in 2019? What is new? So it was there that there are a lot of resurgence of wholesale, lot of resurgence of pertussis which has occurred in wholesale pertussis using countries as well as a cellular pertussis country. So outbreak in 2020, which was there 1990 in USA, made this wholesale pertussis absolute in USA, and they started using acellular pertussis. But then the acellular pertussis switch was also associated with resurgence of pertussis in USA. So it was thought that probably the change of brand from wholesale pertussis to acellular pertussis is the reason for this resurgence. But because of the reactogenicity, the acceptability was not possible. So they did not shift from acellular pertussis to wholesale pertussis again back. So the increased reactogenicity was the major factor which was claimed to have resurgence, but still not shifting to the wholesale pertussis. Is it only that USA had this resurgence? No, it was seen in other countries also. And other countries also showed wholesale pertussis which are using in national immunization schedule also showed a lot of resurgence. The key update in 2018 has come in IAP, and where they say that DTAP or DTWP containing hexavalent vaccine can be used as a primary series because they have a similar protection as far as the seroconversion and seroprotection in first year of life. So this is a key update in 2018 where we can use our cellular pertussis or wholesale pertussis in primary series. So there are a few facts and myths which needs to be addressed. So all scientific forums, all conferences, all immunization dialogues, there are few things which are always coming with a lot of hues and cry. The resurgence of pertussis, whether it is only because of cellular pertussis or wholesale pertussis, what is the number of components in acellular pertussis which are more protective? So more effective components will be one component, two component, three component, or five component, or what is the duration of protection which is given by wholesale pertussis or acellular pertussis? So these are the 4 points on which all the debates of scientific debate is all going on. Let us see one by one. Now, if you see that in pertussis outbreak, when the USA was using wholesale pertussis, at least 10 outbreaks were recorded when they were using wholesale pertussis. Similar was observation after using acellular pertussis also. And then it was thought that basically Bordetella pertussis itself has a natural cycling mechanism of resurgence, and which is the cause of resurgence rather than only changing the brand of wholesale pertussis to acellular pertussis. Now, the resurgence has occurred in wholesale pertussis in Argentina, Brazil, Chile, and Poland for almost 46% or 3 to 4 fold times resurgence has seen in 2011 when they are using wholesale pertussis in their national immunization schedule. So the upsurge is not only because of change in the brand, the upsurge is because of many factors or multifactorial upsurgence has been predicted. The first is basically natural immunity of pertussis do not give rise to complete antibody protection for whole of life. So the antibodies which are formed after natural infection do not last in the body for whole of your life and do not give you protection. So how can we really expect antibody production which would save us from wholesale or cellular pertussis? That is one. Recycling of Bordetella pertussis resurgence has been seen for 4 to 5 years, every 4 to 5 years. That may be the cause. Then there is increased recognition of typical as well as atypical cases because of more sensitive PCR tests, and there is a better surveillance, and the weaning of immunity because of both the vaccines is occurring over a period of time. Now, this weaning of immunity has caused an epidemiological shift. So the pertussis which was seen in infantile age group or in early age group has now shifted to adolescent and adult. So there is a need of booster in adolescent age group. That is why we are giving second booster at 5 years of age. So surprisingly, there are a few countries where they are using cellular pertussis in their national immunization schedule, but there is no resurgence which has been recorded. Norway, Sweden, Finland, and Denmark, they never recorded a resurgence of they never recorded a resurgence of pertussis in spite of using cellular pertussis. Now coming to the components, there was a recommendation from ACVIP that more number of components will be more useful in protecting us from from a pertussis disease. Now let me tell you at this juncture that basically Bordetella pertussis has almost 3,000 components at their surface. So we don't have a direct standard of correlate of protection against any antigen to predict that which antibodies against which antigens are going to be more effective or more protective. So whatever surrogate markers which we have, like pertectin, then pertussis toxin, filamentous hemagglutinin, are used as surrogate markers, and antibody against these antigens are said to be protective as far as the pertussis in cellular pertussis goes. Then this WHO position paper in 2015 said that whether you have monocomponent, bicomponent, tricomponent, or a 5-component vaccine, the effectiveness of all these vaccines is similar, and that is what 2015 position paper is saying. Now, Denmark is the only country where monovalent cellular pertussis vaccine was used, and it was pertussis was well under control. But then there was an epidemiological shift, and there was resurgence of pertussis. What they did was just addition of one booster at 4 to 5 years made them to control this pertussis resurgence. Now coming to the 3 vaccines which are available in Indian market, when we have 3-component vaccine, we have 2-component vaccine, and we have a wholesale pertussis containing hexavalent vaccine. Now these 3-component vaccine is there in globally for last 18 to 20 years, and there has been significant safety studies. More than 16,000 infants has been tested for safety studies, while in 2-component only 4 to 5,000 are tested for safety studies. While in wholesale pertussis, only 284 individuals were tested for safety studies. There is a 7-year follow-up in this 3-component vaccine for all the antigens of hexavalent vaccine: diphtheria, pertussis, tetanus, HIV, hepatitis B, as well as polio. And this 7-year follow-up is having a good GMT titers in these individuals. Similarly, in special situations like premature babies, the data with the 3-component vaccine is more than 1,600 individuals, while the data with the 2-cell component is only 5,000 candidates which has been there. But the data with wholesale pertussis is not available. So at this moment on this slide, it appears that basically 3-component, 2-component, and wholesale component, 3-component holds better than 2-component and wholesale pertussis. But what IIP has to say that all these in clinical practice doesn't matter, and all these 3 in this paper is said that basically WHO page, all 3 things are equally good, and the wholesale pertussis is not well standardized as far as the developing countries which are using wholesale pertussis, they are not standardized for the consistency. Here is the paper which says that wholesale pertussis ranges in efficacy from 36% to 97%, while cellular pertussis has been consistent in 94 to 95% in almost all studies. So what matters basically when we are choosing a hexavalent vaccine? It has to have protection against all the key antigens which has been involved. There has to be a long-term impact of this, so long-lasting antibodies we should get, and we should be able to use it in premature babies and have good data. And what is the real world experience of using this vaccine for years? So there is a summary of review article which was there in Chitkara in 2019, and which says that all these 3 available Indian vaccines of hexavalent were tested and they were reviewed. And what was found? The evidence and experience varied widely with all these 3 component, 2 component as well as wholesale pertussis vaccine. But the WP had more reactogenicity. But summarizing that, it is confirming that acceptable immunogenicity and safety for all 3 is necessary, and we need to have a head-on trials of each to say that which is better than other. As we know that India is a developing country, so we have mixed markets of using people who are using wholesale pertussis, few people are using acellular pertussis. We have mixed markets. There are few people who are using primary vaccination, because which was also suggested by ACVIP that the primary vaccination should be done by wholesale pertussis, and you can use acellular pertussis vaccine for the boosting mechanisms. But now, in 2018, IAP has said that either of the 2, either wholesale pertussis or acellular pertussis, can be used in primary series. So
Excuse me, sir, last couple of minutes remaining.
Yes, sir. So the summary of this mixed market is you can use either of the 2 in primary series. No interchangeability data is available, and no sound interchangeability data for mixed schedule is there. So there is a scope for this type of studies of mixed data in our mixed market. So take-home message is basically there is unprecedented controversy about DTAP. So stop saying this child as a step child. USA outbreaks as are not universal phenomena. DTP alone is not the reason for resurgence, and wholesale pertussis vaccine containing vaccine is not the only gold standard vaccine which is available. The components in the acellular pertussis really do not matter, whether it is monocomponent, bicomponent, or a pentavalent component, and you can use any of the components in the vaccine which are available. The winning of the immunity occurs with wholesale as well as acellular pertussis. So it says that basically you need to have a booster for both the vaccines. And current data says that wholesale pertussis as well as acellular pertussis, at least in first year of life, would have a similar seroconversion and seroprotection as far as the protection goes with both the vaccines. So the resurgence of pertussis is not only with the brand, but the resurgence is multifactorial. That is the natural mechanism as well as the different things which I already stated. Thank you very much.
Thank you, sir, for the lucid presentation. There are certain few questions here. One question is by Dr. Nitin. Some Western countries give primary series of hexavalent vaccines at 2, 4, and 6 months. Your comments on that?
See, sir, basically, the immunization schedule is based on the incidence of vaccine preventable diseases in your country. And the amount of incidence in your country, it decides your immunization schedule. So few are practicing 2, 4, 6 months in other countries, but we are practicing at 1.5 months, 2.5 months, and 3.5 months. This is basically because of the incidence of the vaccine preventable diseases in these hexavalent combinations are all more in our Indian scenario. So we need to protect our children as early as possible.
Okay. The next question is by Dr. Smita Desai. At 5 years, which DPT vaccine should be preferred?
See, basically now we know that there is a global shortage of IPV, and most of the children who are born after the switch, they are not protected against IPV. So it would be better if you have a combination of DPT with IPV and as a second booster dose, which will be more rational, I think.
Okay. Sir, what is your experience in co-administration of acellular hexavalent vaccine and PCV13? There are certain reports of increased chances of convulsions.
No. These co-administration studies has been there with 3 component vaccine, and it has been very well studied that there is no dampening and there is no increase in the adverse effect of vaccine, adverse effect following vaccination.
Okay.
3 component vaccine has that study of co-administration.
So the next question is, can different brands of acellular hexavalent vaccines be used for completing the primary series if the same brand not available at second and third visit of the patient?
Primarily, whenever you are using different brands, ACVIP as well as for rationally all scientific purposes, you should not interchange the brand. That is one. But if at all it is not available, you may be able to change the brand. But there is no standalone papers for that, whether the change in the brand has made effectiveness same or different. Because the carrier proteins which are used for both are different. and the immune response depend upon the carrier protein, which has been there for these all antigens which are provided in the vaccine.
One last question by Dr. Nitin again. Any advantages of using wholesale vaccine for first dose followed by a cellular vaccine for next 2 doses in the primary series?
That is what I'm saying, that these developing countries like India, we have a mixed market where we are using wholesale pertussis as cellular pertussis in our own combinations. So there is no sound data at this moment of interchangeability of the brand or superiority. But what is said previously was priming with wholesale pertussis 3 doses and giving a cellular pertussis at booster dose has not changed the and dampen the antibody response which is given by the wholesale pertussis. That is what is there. That is definitely there. But we really do not know whether one dose of a wholesale pertussis vaccine and followed by a cellular pertussis vaccine, whether it has a good or bad effect. So we don't have sound data for that.
Okay, thank you very much, sir. Over to Dr. Archana Jaiswal, madam, for the further proceedings.
Thank you, Rajendra, and thank you, chairpersons. Now we move towards the next.
I really apologize for the delay which has caused because of some technical problems. Thank you.
That's okay, sir.
Thank you.
Thank you very much, sir.
Thank you.
There is a problem with our second session. Dr. Rajiv Mohta, sir, has requested to take after this session. So, Dr. Ganesh Kulkarni, can we take you right now? Dr. Ganesh Kulkarni?
Hello, good afternoon, ma'am.
You are there, na? Okay.
Yeah, I'm there. I can take it.
Yes, so our next session is on David and Goliath of DPT vaccination by Dr. Ganesh Kulkarni. And for this, I request Dr. Rishi Lodaya and Dr. Sachin Paude to chair this session. Dr. Rishi is a multifaceted person, practicing pediatrician and neonatologist. He has a lot of interest in community services and he holds many prestigious positions. And I also welcome Dr. Sachin, who is a senior pediatrician of the, he was from the Varga, and he's a founder president of Vaidyakiya Jana Jagruti Manch, Varda. He's also interested in lot of social services and is the recipient of award like Sakal Samna. We welcome both of you, sir, and over to chairpersons. Yeah. And I think we should be strict for the timing as we are running little late. Request from the madam.
Yeah, thank you, madam. First of all, the topic David and Goliath is somewhat unique topic, which used to refer to a situation in which a small person or organization defeats the larger one in a surprising way. This is the topic which has been taken by Dr. Ganesh Kulkarni, sir. I welcome Dr. Ganesh Kulkarni, sir, and Dr. Paude, sir.
Dr. Ganesh Kulkarni, sir, please start.
Yes. Very good afternoon to all of you. Thank you, Dr. Bodhankar, sir, and team Nagpur for giving me this chance. In fact, it is so difficult to talk after Dr. Khadke, sir, who's my mentor, who's my guru in vaccinology, who actually has taught me a lot in vaccinology. And when he has taken a stand about something and I have to talk something different from him, definitely is going to be a trouble for me. But let's hope I'll do justice with my topic. So coming to this topic, David and Goliath, we have heard this story long back, as the person has said, that yes, it is a David who is with his sling and stone fights against the monster who's a Goliath, who has been made so big by Western and developed countries. So here I symbolize David as my wholesale vaccine and Goliath as the cellular vaccine. Intention is not to create a confusion and not to create a total war against each other, but to give an overall insight into how they differ from each other. So, dear friends, when it comes to vaccination, no one is David and no other is Goliath. We just discuss what suits us more scientifically. So all vaccines are on the same platform. Nobody is better than the other. We need to vaccinate our kids. That's our prime aim and objective is. Now, what makes a vaccine a better vaccine? To me, there are three things that makes a vaccine a better vaccine. First is that vaccine has to have a better efficacy. The vaccine has to prove its gold standard going into community and prove its effectiveness. So that's one point. Now, second point is that immunity has to long last. So that means a long-term protection. That's the second attribute for being a better vaccine. And the third and most important attribute for being a better vaccine is whether it prevents transmission, whether it prevents colonization, whether it prevents pharyngeal carriage. So if these three things come together, I would call this particular vaccine as a better vaccine. Now let us hope and see whether my wholesale vaccine stands very well on it. This vaccinology is a very complex process. The more we know, more we get confused. And the question remains as it is since ages, which DPT vaccine do I use? I'll try to solve it for you. Coming to this DPT vaccines, I'm not really going to discuss much about diphtheria and tetanus part of these vaccines because they both have been a very cordial and very efficient and efficacy-wise better vaccines. They haven't created much controversy, except some diphtheria cases are coming up. Some diphtheria resurgence is being seen nowadays, but most often the problem has occurred with pertussis disease per se. Pertussis has been the most contagious part of disease caused by Bordetella pertussis. Pertussis is preventable with vaccination, and the vaccine first came into picture in 1914. So it's been 100 years back. Monovalent pertussis vaccine was there. Now, what do we offer for our kids right now? There are two different types of DPT vaccines. One is wholesale and other is a cellular vaccine. What is more important is almost 86% of our kids in the globe have been given 3 primary dosages of DTWP or DTAP, either of them. So the coverage has been really good. So let us just see what timeline is saying. Monovalent pertussis vaccine, which came in 1914, then came diphtheria, monovalent vaccine in 1926, then came tetanus vaccine in 1938. So these all were monovalent vaccines. Getting them all together, a trivalent vaccine came in 1948, that is DPT vaccine. Now, from 48 onwards till 1976, effectiveness of DPT vaccine was proven beyond doubt. Almost more than 90% cases were reduced. The disease burden has been reduced just by this wholesale DPT vaccine over these many years. Now, then the world was not thinking much about the mortality. And then world started thinking about a morbidity in the terms of reactogenicity. And that's where the cellular vaccine came into picture. That was in 1991. Now, DTAP replaced DTWP in 1997 in all developed countries. And then something started happening. Dear friends, something started happening, and that is what is called as resurgence. We would be able to see a lot of cases which are coming up. And then in 2020, we are still discussing which one we should use. Now let us understand this particular graph by, this is National Notifiable Disease Surveillance System of CDC. See, DPT, wholesale DPT, see, pre-DPT era, this was the burden of disease, pertussis burden of disease. Then came the DTWP. See the decline, it's almost flattened the curve to more than 90%. Then DTAP was introduced, and look at this particular graph now. This has started increasing. So this is what is called as resurgence. My friends always keep on saying that resurgence is not always because of a vaccine. Yes, I do understand that. Resurgence is not always because of that, but there are these outbreaks, and Dr. Khadke sir has very rightly said, there are countries where a cellular vaccine was used and there were resurgence. There were countries where wholesale was used and there were resurgence. There were countries where single component cellular pertussis was used and still there was no resurgence. So I won't blame only vaccine for resurgence, but we cannot underestimate this developed countries showing resurgence. So we need to take cognizance of this. Now, what are the factors other than vaccine? See, increased awareness. Khadke sir has very well elaborated on this particular aspect. The definition has been changed. Initially, the WHO has said more than 3 weeks of cough is pertussis. Now the definition has gone down to 2 weeks. So more number of cases were accommodated. Now awareness of the clinician was increased. Now we all are very well versed diagnosing pertussis. Vaccine failure. Now it's a social media game. Now a lot of vaccine hesitance people are coming up. Now there is something which is called as waning of immunity. Now the vaccine, even a natural infection does not give you a lifelong immunity. So as wholesale and cellular vaccines also do not give you a lifelong immunity. They have their own limitations. Unvaccinated population is increasing because we are losing on boosters. We are giving our primary vaccinations to the tune of 86 and 90%, but we are losing. If we know first booster coverage is almost has gone down to below 70%. And the most important is change in organism, the pathogen adaptability. So let us understand one by one. To make it more simplified, I have categorized it. Resurgence is either because of vaccine related or non-vaccine related. Vaccine related is either it is wholesale related or cellular related, and non-vaccine related is basically because of better diagnostics, better surveillance, and the change in the pathogen mutation. I'm going to discuss these two vaccines one after the other. For antigenic contents that they have, mutation of this particular organism, waning of immunity, efficacy and effectiveness, difference in the immunological reactions. So coming to this first one, let's understand what is difference between wholesale and cellular. In wholesale vaccine, a whole tumor cell is being used, while in a cellular vaccine, only a cellular material which has some antigenic properties are being used. So here wholesale is used, here some components, antigenic components are being used. So this is where the difference between these two lies. See, if you use a whole cell, you have n number of antigens in the cell, intracellular antigens, you have extracellular antigens, you have surface antigens, you have capsular antigens. So there are more than 3,000 different antigens. And what we are using in our cellular vaccines is either one component, two component, three component, four or five component. So compare about five component vaccines and more than 3,000 component vaccines. So this is what the difference lies. And probably that is the reason why wholesale vaccine is little more reactogenic than the cellular vaccines. Because if you have that much of burden, if you have that much of responsibility to fight against these many antigens, you definitely going to have a pain for it, feel pain for it. So that's where multiple virulence factors are responsible for pertussis pathogens. See, these are the common 5 components which are there in the pertussis cellular vaccine, and these many are left out, which are equally important. And that's the reason why, if you compare antigenic component wise these two vaccines, wholesale vaccine is far and better, far ahead of cellular vaccines. Now another thing is happening. See, now in case of DPT vaccines, we have almost reached to 86 to 90% of coverage. So lot of vaccination pressure is happening on the pathogen itself. So we are almost on the verge of eradicating these bacteria, but that doesn't happen. The way humans want to live, your pathogens also want to live in this world. So they start changing. Now the divergence of your molecules, bacterial molecules, the change in the antigenic change in their structure, the genetic change in the structure, which is called as mutation, which either could be genetic mutation or it could be environmental. Environmental is because of excessive vaccination pressure. What is happening is these vaccine strains which are there in cellular vaccines are not there in the circulating strains. So there is a divergence between circulating strain and the vaccine strain. If your vaccine do not have that kind of strain to combat with the circulating strain, I do not think your vaccine is going to really give a better immunological response. So genetic adaptation occurring through allelic changes of surface proteins, upregulation of expression of toxins and allelic changes leading to divergence. And this is what is called as mismatch. And this particular mismatch is hampering our cellular vaccines. And I'm not just saying it, the evidence shows there is pertactin deficient Bordetella pertussis isolates, which was 14% in 2010, has gone up to 85% in 2012. While beta Bordetella pertussis is not expressing these 3 other components reported in France, Sweden, and US. And this all has started after when we started giving cellular vaccines. So dear friends, mind it well that this particular organism is changing, it's mutating against these antigens which are there in the cellular component vaccines. Now, priming with wholesale and priming with cellular vaccines. See, this is a wonderful data which compares both of them. Wholesale vaccine conferred better protection when wholesale vaccines were used in primary series rather than cellular. It's a world-known. Baboon study has been a marvelous kind of example to tell us that yes, if wholesale vaccines were used in primary and a cellular vaccine given on the top of the vaccination as boosters, it induced IgG1 kind of IgG, one kind of antibody response, which in fact had better opsonization, better phagocytic activity, better complement mediator killing, and all of them really conferred a better immunological response. Whereas cellular vaccine given in primary series, cellular vaccine given in the booster series induced IgG4 kind, which was very less shortened. So we have two different aspects. One is if you are going to use a cellular, you're going to have a shorter memory. If you're going to use a cellular, you're going to have a less immunological strength or the memory to the child. So that's where. Now, another thing, the protection, how long lasting it is. See, if we compare vaccination on two aspects, degree of protection and duration of protections, perhaps natural infection gives you the best kind of protection and best long-term immunity. That's the first thing. After natural immunity, what comes into picture is probably the WP vaccines. And it is in the tunes which is as comparable to the natural infection. So almost more than 12 to 15 years, to say categorically, maybe at 7 to 12 years, WP vaccine still stands second in the race, and then comes the AP vaccine in both degree of protection and duration of protection. Now, coming to the efficacy and effectiveness, it has proved beyond doubt, because over a century, wholesale DPT has given its best kind of effectiveness and reduced the disease burden to more than 90%. So I do not have to talk about effectiveness. If I have to talk about efficacy, as Dr. Khadke sir has said, yes, there is some kind of variable kind of efficacy, but that is seen in developing countries where we all know there are a lot of cold chain problems. Our peripheries are not equipped with cold chain, our health infrastructure, cold chain infrastructure is not so good. So I do not really blame wholesale vaccine for variable kind of efficacy, but when it is compared with one component, two component, three component, five component, still wholesale stands higher in terms of efficacy. So let it be a efficacy, let it be a effectiveness, let it be a long-term protection, let it be a better immunological response, wholesale still stands very well. Now, what is the ego? Ego is, see, we all are humans. I must be driving a lot of times. If I drive from one square to another, I find a better road, I take that road. But once I start on that road, and if I feel that this road is not correct, I don't go back and change my road. I try to explore the goal point, the end point, going on the same route. That is what is happening with the developed countries. Now, they have been into this action that they have found a cellular vaccine just for the sake of reactogenicity, and they do not want to fall back to WP because they think that it's against their ego. So that's one thing. Now, another wonderful thing that is better with WP vaccine is natural infection and wholesale vaccine creates lipopolysaccharide kind of memory, induces immunological memories, and this PAMPs, these are called as associated memories, which induce TH17. Sir has very well said, baboon model has really given us this advantage that yes, wholesale induces TH17. TH17 means better opsonization, better phagocytic activity, better complement mediated killing, and TH17 induces robust kind of immunological memory and a long-term memory, whereas a cellular does not have PMPs, so they just rely on adjuvants. So when it comes to pneumococcal vaccine, we say direct protection is better than the cross protections. But here, your vaccine is giving better protection against and giving TH17 response, but you are trying to add on adjuvant which wants to give better TH17 response. So you are taking this theory of mouse model and you are ignoring the baboon model, which directly tells us, yes, wholesale has a better advantage than. Now, another thing, as I said, wholesale priming with a cellular booster has IgG1 response and better protection. DTAP priming with a cellular booster giving a poorer response. Even it has been said and found correctly in a study that even if you use one WP vaccine in primary series and rest a cellular vaccine, your long-term protection and better immunological response is going to be assured of. So what do you want? You want suboptimal efficacy, you want shorter duration of protection, less priming, poor quality of immunological response, do not protect against antigenic components, fail to generate effective immunological memory, and fail to induce appropriate cellular immune response versus little kind of reactogenicity that and India has been using DPT for so long. How many in your clinical practice years you have come across grave kind of reactogenicity because of wholesale? We are using it in and out, day in and day out. So the reactogenicity is a Goliath being created by developed countries. They don't even want a slightest kind of thing happening against their wish and will. So what does WHO position paper says? It says protection against severe pertussis in infants. You can use primary series as WP or AP. They are going to say, because they are parent body, they have a parent will not differentiate between their kids. So WHO is also not going to. Then a switch from WP to AP primary infant immunization should only be considered if you are going to give periodic boosters. So if you are going to give AP, you have to ensure about periodic boosters, which is very less in developing countries like India, way below 70%. And national programs which are currently using AP vaccine may continue, but those programs which are currently using WP should continue to use WP like we in India. Now, what does our IAP say? IAP says primary series should be completed with 3 doses of either WP or either AP. WP vaccine is definitely superior to AP in terms of immunogenicity and duration of protection, but little more reactogenic. Waning of immunity has been reported with both, but wholesale has a longer protection. After the first year, immunity wanes more rapidly with cellular vaccines, and the impact on transmission by AP vaccine is also inferior to WP vaccine. The duration of protection for both AP and WP after 3 primary doses and booster dose at least varies from 6 to 12 years. Dear friends, in fact, we people are also to be blamed. And why? Because primary immunization confers a wonderful protection to the infants. Booster immunization prolongs, stretches this immunological protection to a longer time. But if we fail to give additional immunity boosters, additional boosters, which will cause waning of immunity, this will make our adolescents and our adults susceptible. They will become the reservoir. They are the ones who are in close contact with our infants. And that's the reason why our infants will start getting the disease again. So we need to use any kind of vaccine, whether you use wholesale, whether you use a cellular, I don't mind for that. But you have to keep on giving boosters regularly. Now, how do we really improve this scenario? Either if you have the same set of vaccines, you keep on giving repeated boosters every 10 yearly. That's how you can improve your protection. Second is you can do a maternal vaccination. Third is you can have a cocooning effect, a cocooning strategy. But there are something more which is coming up, which is bringing new vaccines into scenario. Now, what would be the best new vaccine? Something less reactogenic like a cellular, but more immunogenic like your wholesale vaccine. So if you have a combination of wholesale and a cellular together, where you have a virtue of less reactogenicity of a cellular and better immunogenicity and long-term protection of wholesale, it would be a novel vaccine. And that is what they are doing. Novel adjuvant to boost TH17 to improve the response in a cellular last minute, and non-reactogenic wholesale flow vaccine. So now this new concept has come into picture, which is a flow vaccine. Flow vaccine is a wholesale vaccine from which chemical extraction, lipo-oligopolysaccharide has been taken out, which is supposed to be the most virulent for reactogenic things. It creates a lot of endotoxicity. So that has been taken out. And they are trying to use live attenuated beta pertussis strains. So dear friends, vaccines do not save lives, but vaccinations do. You use anything, you use wholesale, you use a cellular, but do vaccinate, give boosters timely. Thank you so much, friends.
Thank you, Dr. Ganesh. Very nicely elaborated about the wholesale vaccine and the cellular vaccines. Very nicely explained to clear all the doubts. I think there are the questions have been, there are no questions, I think, in the chat box.
Already Khadke sir has already answered everything.
Yeah.
Thank you so much.
Yeah. Thank you, Ganesh.
Okay, thank you everybody. Thank you Ganesh sir, and thank you chairpersons. We move towards the we move forward to next session, and that is by Dr. Silpa Hazare. Rajiv Mohta sir, and it is all about flu. And the chairpersons are Dr. Bagde sir and Dr. Bhupesh sir. Dr. Bagde sir is consultant pediatrician since last 30 years in Nagpur, and also the past secretary and past president of IAP Nagpur, and also a joint secretary of prestigious organization Comhead. Sir, we welcome you. Dr. Bhupesh is a consultant pediatrician and director of Parijat Hospital Amravati, and is also currently president IAP Amravati. Sir, we welcome you also. Over to chairpersons.
Archana. Good evening, everyone, and welcome to NAPCON 2020. At the outset, let me thank our President, Secretary, and Scientific Committee for giving me this opportunity to chair this session. Today's our esteemed speaker is Dr. Rajiv Mohta, who is a senior pediatrician of Nagpur, practicing as a consultant pediatrician and consultant in adolescent health since last many years. He is also a secretary of IIP Nagpur, ex-secretary of IIP Nagpur, and general secretary of Adolescent Health Academy of Central Academy. He is a faculty and a trainer of various adolescent health programs at the Central IP level and also in National Adolescent Health Academy. As we are lagging behind the schedule, let me invite Dr. Rajiv Mohta to deliver his lecture on all about flu vaccine. Over to Dr. Rajiv Mohta, sir.
Thank you, Dr. Suchit. Thank you, Dr. Bone. Am I audible?
Yes, very well.
Can you see the slides?
Yes, not your face. Here it is darkened, not light on your face.
Yeah, because there was a MSCB line has gone, so I'm not able to put across all the things around me. So let me remain in dark, but let the science come in forefront.
Yes, you can go.
The slides not visible.
I'll just make it. Let's say. Is it visible now?
Yes. No, slides are not visible.
Not sir.
No.
No.
Okay, just a moment. Is it visible now?
Not yet.
Oh, I'll check. I'm just trying in a minute. Yeah.
Yes.
You can see your slides.
Okay.
Full screen now?
Yeah, I'll do that.
We have 20 minutes, 3:14, 3:15 we can say now. Just kindly start, Raju.
Yes, sir. I'm thankful to Dr. Shubhda Khirwadkar, Dr. Mustafa Ali for giving me the opportunity to be a part of this great conference which we have been facing since attending since last so many years. I'm thankful to Dr. Archana and Anju Kadu for coordinating with me. And I'm thankful to the chairperson, Dr. Suchit and Dr. Bone for chairing this session. Basically, if we talk of all about flu, there are so many things about flu which we are knowing about it and about the vaccination as well. But there are very many new things which I am talking about, and new things are related to the old things which we all are aware about. Just an highlight about what had happened in the past is 1918, 1957 Asian flu, and 1968. With the COVID around, probably we are talking about 1918 Spanish flu, quoting it everywhere. But we have forgotten the 1957, 1968, and 2009 pandemic which occurred. And these pandemics have created flutter and fear amongst all of us. And probably the fear is related to the COVID as well as we talk about it today. We will be coming to the vaccine a little later part of this presentation, but the pandemic which is being created is really difficult to handle and difficult to manage. If we talk of the statistics of 1980 pandemic, global mortality was 20 to 50 million, and Indian mortality was 50% of the global mortality was from India. This is the statistics which have been proven and has been published in a journal in BMJ, 2014. Now, what is influenza by definition? You all know. Probably it is the most intimate friend which we know about it. It was the mention about this influenza-like, flu-like symptoms have been mentioned in 400 BC by Socrates. And we all are aware about it. But then remaining together, we need to understand that what is the global scenario which we go across. If we talk of global scenario, the affection from 90 million to 500 million cases per year. Leave apart that there would be 1 minute, one death every minute. This is what the statistics of influenza is, that dreadful the disease is, and we are focusing probably somewhere else other than the focus which we think about it. The focus remains in children because they are the spreaders amongst the family, the surrounding, the people, the school, and everywhere around life. More than that, what happens is probably we are responsible for something about it, and the responsibility is because there are a lot of things involved with the influenza. As a common cold walks into our chamber, we cannot diagnose common cold because we need to go ahead with the investigation and finding out RT-PCR about influenza. What we do is usually, according to the signs and symptoms, we give the treatment, and it has been postulated by CDC and WHO that 10 to 30% of times we give antibiotic which are not required in the viral infections. And influenza is one of the viral infections which we are talking about. Now, influenza, COVID, how it correlates to. If we talk about COVID, probably we all know what is the prevention measure we are taking and what are the preventive measures which have been advocated by various authorities all over the world. Now, if we talk about the viruses are almost same. They are RNA virus, both are RNA virus, both are encapsulated, both have single-stranded RNA inside them, both have lipid envelopes, both have protein envelopes inside, and both have spikes around. So it almost mimics, the COVID almost mimics influenza. The only difference is influenza is 100 nanometers and the COVID is 125 nanometers. The only difference is that. Now, influenza virus, what are the types of viruses? The viruses is orthomyxoviridae virus. We all know about it, the type A, type B, and type C. And very important is type A is the major problem creator because antigenic shift and antigenic drift. Drift is a minor change which occurs and which creates every now and then. And that is why we need to update the vaccine every year. And this every year vaccine, which is being postulated by WHO and the authorities, will be manufactured by the companies and supplied to us. That is the major change which comes in A. And antigenic shift we have seen in 2009 in our practice, and that was the pandemic of H1N1 swine flu. And that was because of the antigenic shift. The major shift occurred because the swine and the animal and the human influenza viruses mixed together, and the new virus which was created was the novel H1N1. Type V, there are mutants are slow, and type C not very relevant right now, but we don't know what will is kept in the basket. Signs and symptoms almost are same, so we are all going to get confused in the days to come, the months to come, where the epidemic of swine flu is going to walk in with us. The rainy season has gone, but the winter season in few areas is beginning, and probably there will be an overlap of all the symptoms along. And these symptoms would be really characteristics, and we will not be able to define from the symptoms what are the symptoms of COVID and what are the symptoms of flu. Almost looks similar: fever, cough, sore throat, running of nose, muscle, body ache, headache, fatigue, and all these are same, almost same. Then how long the symptoms appear? This is very important for us to know before we know about the vaccine. It is 1 to 4 days before the symptoms occur, and in COVID it is 5 days after being infected. Up to 14th day we make it get the symptoms may occur later. Then how long someone can spread the virus is from 1 day before till the symptoms have 3 to 4 days. And infants and young, the weak people, it may remain in the immune system and may spread for a longer period of time. COVID, we all know, it begins on 2 days before until 10 days after the investigations have been found out the positivity and the symptoms occur. How it spreads. The similarity is almost same. We all know about it, that it spreads from droplet, either directly or from the surfaces. And we have been talking about the prevention of COVID from 2000, the influenza from 2009, and similar has been continued in COVID. So we all know about it. The only difference in corona is the spread is very, very fast, and we are still not able to find out the speed of COVID, but it is spreading very quickly to people along and the countries along. People at high risk for severe illnesses almost are same: children, older adults, people with comorbidities, pregnant women, and infants and children with underlying medical conditions are the similarities. The difference is in COVID, what we see in children is the multisystem inflammatory syndrome in children can be seen, and we need to define and differentiate from the signs and symptoms apart from the investigations as well. Complications are almost similar complications from pneumonia to multisystem failure, and the only difference between COVID is the post-COVID syndrome we are talking about. Otherwise, almost everything remains same. So we all will be confused if we talk about the COVID and the influenza. Approved treatments are yet to be decided, but supportive medical care is to be given, and we are lucky enough in flu to have the antiviral drugs, and in COVID-19 a lot of research is happening wherein we need to find out, and the treatment are going to come. The vaccine, we are lucky that vaccine is being defined since last so many years about flu and influenza, and there are multiple vaccines which have been advocated and licensed by FDA. And COVID-19, we are currently waiting for the vaccine to come in. Now, influenza attack rate in children, meta-analysis done in 2014 by Jayasundra talks about the adult and the children natural attack rate. If we look at this, it is very important to know that overall attack rate in adults would be 3.5, and it is 5 times higher than 15%. If we talk about influenza A, it comes from 2.32 to almost 6 times, and influenza B from 0.59 to almost 10 times in children. So children are being attacked more according to the meta-analysis which was conducted, almost more than 30 studies all over the world around. Then we talk about the Lancet presentation. Again, this was meta-analysis conducted, and which this study was concluded in 2011, and up to 2008 and 10, they found out that 19 million cases of influenza occurred along children less than 5 years of age, 20 million cases of ALRI, and 1 million cases of severe acute lower respiratory tract infections, and almost these many deaths occurred because of the influenza. So influenza is not a simple disease. It's a dreadful disease, and particularly in developing countries, it is deadlier than the developed countries. Why? Because there are many theories about it. We all know about it, but what we should know is it's almost 3 times more influenza rate in the developing countries than the developed countries, and mortality rate is very high, almost like 15 times higher in the developing countries than the developed countries, the mortality I'm talking about. Then unvaccinated children have considerably higher exposure risk than the adults. We all know about it. Again, the percentage remains same. The same study I'm quoting is Jayasundra's study. Then influenza is underreported. Why underreported? Because we don't investigate. And how are we going to investigate? Investigations are very costly. Not every common cold patient who walks into our chamber with fever and myalgia, we're going to say, go and get the PCR done. RT-PCR is not being done in the COVID as well, even if you advise the patients, because of worry or because of money or whatever the psychology is involved. But very important here is to realize that the study which was conducted in 2006, 2 studies in 2006 which were published in New England Journal and Archives of Disease in Children talk about only 28% of hospitalization and 17% of outpatient visits children lab confirmed influenza had discharged from the diagnosis. Even hospitalized patient we don't investigate. Now with COVID around, we need to investigate and find out. Now, global burden of influenza include what? Now, this study was carried out in India as well, and the study talks about a lot of statistics. Why am I showing this statistics is very important. Annual influenza associated hospitalization in children below 5 years is almost 8.7 lakhs. Below less than 1 year is 3.74 lakhs hospitalization. I'm talking about the global burden we are talking about. The study was again a meta-analysis which was conducted. Almost like 30 studies have been postulated into it. And these studies are talking about the children less than 6 months old where we don't vaccinate with influenza vaccine. The mortality rate, the hospitalization rate is 2.28 lakhs. These many children less than 6 months are getting affected by pneumonia, and the investigated pneumonia are being hospitalized into various hospitals. Now, if this is the study, then what else remains in our basket? This is a study which was conducted and published by 2018 Indian Pediatrics, which all of have read. Bal Subramaniam's article in the Indian Pediatric, volume 55, 2018, talks about the study which was conducted in 2010 and 12. 3 years the study continued. Vallabhgarh study in Haryana and Wadu, Maharashtra. Why I'm talking about it again, we'll come to, because before we come to know about the vaccine, why we are giving vaccination, which types of vaccines are involved, we should be knowing about what is the change which is occurring in the influenza burden. The change which occurred in the influenza burden, Vallabhgarh, Haryana talks about the incidence is 3.4 to 5.4 children were positive in 10,000 cases studied. And in Wadu, Maharashtra, they were from 20 to 50. This was 2010, less than 1 year patients were highest number of patients. And if in 2011, same Vallabhgarh, Haryana, the number of patients much more there were more than 59 years of age and less in children. And in 2012, again, 1 to 4 years. If we go for Wadu, Maharashtra, the study talks about 1 to 4 years in 2010, less than 1 year in 2011, and 5 to 14 years 2012. Why? Why? This is what is happening in terms of influenza burden, which comes to us by various ways and means and presents to us in various rates and various A and B types. And that is why the consistency of vaccine changes, the content of the vaccine changes every year. And this change, if it is not being recorded properly, the vaccine efficacy would go down. As it is, we know the vaccine efficacy for influenza vaccine would not be more than 60%, considering a lot of differences in the vaccines, which are the differences in the viruses, a lot of mutations which are occurring, a lot of changes which are occurring in preparation, and a lot of seasons which we talk about, the southern hemisphere and the northern hemisphere. Vaccination is the most effective way to prevent influenza. We all know about it. Vaccination reduces almost from the upper respiratory tract infection to the acute otitis media to pneumonia to hospitalization from 33% to 41%. Again, this is very, very important to tell that almost like 30 to 40% change would occur in whatever symptoms we see in the influenza. And this talks about the herd immunity. We all know influenza induces herd immunity. Vaccine induces herd immunity. Now, this study is very pertinent to our country because this study was carried out in Japan when Asian flu pandemic occurred in 1957. Now, with this Asian flu pandemic, the mortality rate was very high. In Japan, what happened in next 5 years, they started with injecting the children with the inactivated swine flu vaccination, and the flu vaccination. With that influenza vaccination, 1962 program to vaccinate the school children with inactivated influenza vaccine begins. And as soon as the vaccination began, you can see the death rate, the mortality rate came down by 50%. Now, 1977, there is a legislation which came down, and with that government legislation, it was compulsory for all the schools and all the parents to give the vaccination. And every child, almost 85% of children and major adults were covered in this vaccination program. But in 1987, another legislation came where parents were told if they don't want to vaccinate, they should not, and they can refuse for the vaccination. And 1994, the vaccination got cancelled because of a lot of theories and a lot of postulations which came down. The vaccine is not effective, it is not working, it is not required, and blah, blah, blah. So many other things which happened. The vaccination, the death rate again increased to almost like 1962 rate where it began. So this study talks about the study in the Asia, and this is Asian study which talks about the mortality which came down because of vaccination, and the vaccination stopped and the mortality increased. Now, influenza vaccination, how the history begins. The first noted the virus was in 1933. And 1933, the monovalent vaccine was manufactured. It continued almost up to 58. B was diagnosed in 1940, and B and A were combined, and bivalent vaccine was manufactured in 1940. 1958, the H2N2 was isolated after 1957 Asian flu, and H2N2 was the responsible, and it replaced the H1N1. But the bivalent vaccine continued with H2N2 and the B combination. In 1968, after the 1960 Hong Kong 1964 flu pandemic, what happened was we diagnosed the another kind of H3N2, which led to this Hong Kong swine flu. That then it was involved. What was involved was the manufacturing of trivalent vaccine, which came down from the study started from 1968, and 1978 the trivalent study started. So H3N2 was involved instead of H2N2, and H3N2 and B was the bivalent vaccine. Then came the trivalent vaccine, and now we know we are having quadrivalent vaccines. Now, quadrivalent vaccine, if we talk about it, we will be talking about it. It contains H3N2, H1N1, and B type Victoria and the Yamagata. These are the true lineages of the B type of virus, the viruses which you know. Now, impact of trivalent vaccine, and it was mismatched due to the inaccurate predictions and co-circulation of both B types. Now, in trivalent, there was only one B involved, and A was involved as H3N2 and H1N1. With the addition of coming of B also, the study which talks about the percentage of A and B involved, the A was involved in 27%, A H3N2, A H1N1 was involved in almost 30%, B type was involved in almost 46%. So B was involved, and the B was almost like 2% if we define. 63% was B Yamagata, Victoria, and rest of the was Yamagata. So Yamagata was almost having an equal percentage, which was not there in the trivalent vaccine. And so the quadrivalent vaccine was manufactured. Now, how do we label the vaccine? Let me tell you this, because this is a common knowledge, but we need to revise it. We label this virus as this is the new virus. This is not the new virus. This is just an example. A is the virus type, geographic area where it was found, the strain number which have been labeled, the year it was isolated at the geographic area, and the virus subtype. This is what the nomenclature of the flu vaccine would be, and we'll be coming back that which vaccine has been advocated by the WHO right now. Now, if we talk about how does it come in? Now, it comes in because of the GISRS, Global Influenza Surveillance and the Response System, which has been...
2 more minutes only.
Okay, yeah. So it was been defined by WHO, and WHO advocates every 6 months. They meet 6 months before the season of influenza comes in, and they advocate that this is the content, this should be the content of the vaccine, the manufacturers manufacture and supply. This is the way it is being done. And 2020 Southern Zone Hemisphere and 2020-21 Northern Zone Hemisphere, these are the vaccines which we are giving it right now. And they would be changing from Jan to March somewhere down the line in 2021. We may get a change if at all the advocacy changes from WHO, or we may continue. It happened in past in few years that the same virus continued. So we don't know what is going to happen tomorrow, but let's vaccinate our children. Let's vaccinate ourselves. Let me ask each one of you a question. How many of you vaccinated yourself? The study says doctors, healthcare workers have vaccinated up to 85%. What about the rest 15%? I'll leave apart that. How many of you have vaccinated your own family members? Your own staff who has been in touch with you, all nurses and people around, have you vaccinated them? Have they been vaccinated with influenza vaccination? No, then adult vaccination is also required as per the advocacy of WHO. Now, protection for flu vaccination, we know the antibodies, we must know the percentage, the level of antibodies, 40, more than 40. Now, which are the Inactive influenza vaccines, which we are talking about, wholesale vaccine has been disapproved by now because of the lot of complications. Now split virus vaccines and subunit vaccines. Now split virus vaccines we know is a much better vaccine, giving a lot of efficacy and safety as well. Now, split virus vaccine contains surface antigens and internal antigens, and subunit vaccines contains only surface antigens. If we look at the statistics which have been studied at various hospitals, at various studies which have been published in 2013 to 2020, these subunit vaccines are with split vaccines, subunit vaccines and split vaccines. We can see the split vaccines have a lot of safety measures and giving us the protection more than that. ACVIP recommendation that quadrivalent and trivalent inactivated vaccine should be routinely offered annually to all children between 6 months to 5 years of age. Latest available influenza vaccine can be administered after 6 months of age, 2 to 4 weeks prior to influenza season, 2 doses of interval of 1 month in the first year when the first dose has been given, and then annually again. If the child is less than 3 years, 0.025, 3 to 9 years, then 0.5, 2 doses, and more than 9 years, only 1 dose to be given. Vaccines do not save lives, vaccinations do. Thank you so much.
Thank you, sir. Wait, hello.
Yeah.
Thank you, sir. Very nice and elaborate talk. We directly go to the questions. There is one question from Dr. Chetan Shinde, sir. Prescribing the currently available flu vaccine versus waiting for the appropriate latest strain to be made available. What do you do in your office practice if you face such scenario?
Thank you, Dr. Chetan, for asking this question. You are one of the pioneers in vaccines in the IAP, I know. But this problem we all are facing. But what we say is as much protection we can give, we should give, because the protection begins after 2 weeks. We cannot wait for the new vaccine to come in. So advocate and give vaccine right now. And that would give a protection till the new vaccine comes in. This is what I do in my office practice.
Okay,
Raju, there is a question for you from Dr. Patel. He asked, can we give the vaccine to the post-COVID patient and when we can?
See, there are no advocacies about the post-COVID patient, but they say that post-COVID patients, we should wait for some time, and the sometime has not been defined by WHO and CDC yet. But there are studies which say that 4 to 6 weeks after the post-COVID, probably we should be able to give. Why probably? Because no advocacy has been given by all the authorities, including the national CDC, which is based at Delhi. So I think we should wait for some more time to let the advocacy come in from the authorities.
Can we wait more than 3 months? Because antibodies will be there for more than 3 months.
We should not, because they say, the antibodies which are there, they say it will not remain for more than 90 days. So as has been said by Dr. Suchit Bagde, probably after 3 months we should be able to give. If we just generally have a common consensus amongst our own group, probably we can think about it like that.
One more question, sir. Can we administer the vaccine all the year round?
Yes. The advocacy is in India. We are probably into southern zone and the Kashmir part of it and some part of Delhi where the winter is a prolonged winter. It is in the northern hemisphere, southern hemisphere and northern hemisphere. So all the year along in India, we do see 3% of the influenza patients. And if it is happening all the year along, we can give, because that definitely gives a protection. Percentage wise, we will not be able to define, but there is a common content between the southern zone and northern zone hemisphere, and that definitely gives protection to our children when we vaccinate.
Thank you, Raju, for your informative talk. And
question.
Thank you.
Question? We will move to Dr. Archana, madam. We are having shortage of time.
Yes. Thank you, Dr. Rajiv Mohta, sir. It was indeed a lucid presentation. Thank you, chairpersons. And now we, I hand over the mic for the next session, Dr. Rohini. Thank you very much, everyone.
Thank you, madam.
Thank you, one and all. Thank you so much.
Thank you.
Thank you, ma'am. A warm good afternoon to all. I welcome all of you for the most awaited session that is all about COVID. For this session, our chairpersons are Dr. Dipti Jain, ma'am. She is professor and head of Pediatric Department at Government Medical College, Nagpur. She is also a nodal officer for sickle cell disease. She has been a consultant for WHO, USAID, ICMR, and Government of India. Our second chairperson is Dr. Girish Subramaniam sir. He is consultant pediatrician and consultant rheumatologist with many years of experience at Colors Children Hospital, Nagpur. I request our chairpersons to carry further proceedings. Over to chairpersons.
Thank you, Dr. Rohini. Welcome, Dr. Tanu Singhal. Dr. Tanu will speak all about COVID, not just limited to pediatric COVID. She'll be enlightening us even about adult COVID. Thank you, Dr. Tanu, for accepting our invitation, and apologies for some delay in our part. You can start your lecture now.
Thank you, Dr. Subramaniam. Thank you for inviting me. I'm just trying to share my screen here. Can you see my screen?
Yeah, clear.
And I'm just starting my video also. Okay, you can see me as well, isn't it?
Yes.
Yeah. So, basically, I'm going to try and make this a very, very practical lecture. And as Dr. Subramaniam said, I'm also going to be talking about management of adults and elderly. Because, COVID-19 is center stage now, and it affects our patients, ourselves, and the family. And the other important thing is that the treatment guidelines are rapidly evolving. So my objective is to tell the audience about management protocols across all ages. Because even though while we are pediatricians, if somebody in our family falls sick, they ask us for advice. And we also need to know how we would be managed in case we fall sick. And whatever I'm going to talk about now is based on published information, guidelines, as well as personal experience. Because, in our hospital, we have treated about 1,500 patients with COVID-19 and almost 600 with severe disease. And therefore, I'm going to discuss this whole issue through an illustrative case, or rather a family of cases. So let us just come to this family of cases. And this is just a hypothetical situation to try and tell you how to manage each person in that family. So we have a family of 6 people, and there's an elderly couple who aged 65 and 63 years respectively with diabetes and hypertension. So obviously they are the kind of people who, if they catch COVID, will have a problem. Then you have a adult couple, basically the son and the daughter-in-law, who are aged 38 and 35 with no comorbidities, except that the male is overweight. So here, basically the male may have a problem, has to be watched for complications. And then you have 2 children, aged 10 and 1, a boy and girl, who are otherwise previously healthy. Now, both parents develop symptoms of fever, sore throat, and malaise, and they test positive for COVID-19 by RT-PCR. And Dr. Rodrigues is going to talk about diagnosis of COVID later, so I'm not touching upon that. And soon after that, the elderly male and the older 10-year-old child also have symptoms, and they test positive. The elderly female and the 1-year-old is asymptomatic. So what we are going to do now is discuss the management of each patient, how it should be done as per the current guidelines. Now, because we are pediatricians and we are most concerned with the children, I'll talk about the children first. So this 10-year-old is basically having low-grade fever, mild cough and body ache, and that is how most pediatric COVID presents. Very mild symptoms, fever, even if it comes, it goes away in a day's time. And this child actually does not need any investigations. There is no need to do a CBC, D-dimer, CRP or chest X-ray or even CT scan. And only symptomatic therapy with paracetamol is needed. And if cough is bothersome, you can give dextromethorphan for the cough. There is no role absolutely of giving azithromycin, hydroxychloroquine, ivermectin, doxycycline, or even favipiravir, because we'll talk about favipiravir later because it's approved age above 18. So none of these other drugs which are commonly used in the management of COVID have found to be of any benefit in whatever clinical trials that are available till now. And this child should be monitored for fever and saturation. And the important thing is that investigation should be done only if this child has high fever. Why I'm saying so is that if you have a child who is COVID RT-PCR positive in the throat swab and is running 102, 103 fever, you should be careful that we are not missing anything else, because these children, COVID normally does not cause high fever. So we've often seen patients who are RT-PCR positive in the throat, but actually have fever due to something else. So if this child starts running fever, which does not get better in a couple of days, then we should also investigate for malaria, dengue, typhoid, because these can also come at this time. And the other important thing is that, many of our many of our patients know about pediatric multisystem inflammatory syndrome, which is going to be talked about later. So they often ask, when we tell them, okay, nothing is going to happen to your child, he'll recover. And they ask you that, what about later? So you say that PIMS can happen, but the individual risk is extremely low because nobody knows what that risk is. Now, what about the asymptomatic 1-year-old? And the parents are most concerned about this child because they feel that a younger child may have a problem. So here in this case, testing is optional because she is asymptomatic, and the child should be isolated with the parents because you know that even if the child gets COVID, she's not going to really have a she's not going to have a problem, and you can't send this child to be taken care of by anybody else because she could be asymptomatically carrying COVID. Even if her COVID RT-PCR in the throat is negative, she can become positive a few days later. So she can't be sent anywhere. She has to be isolated with the parents. Definitely, she should not be sent to the maternal grandparent who is asymptomatic. And this baby also has to be monitored for symptoms. And if she develops symptoms, you can treat with symptomatic medication. And testing again is optional because, if this baby of 1 year where parents are having COVID is getting cold, cough, and little bit of fever, you know that this is COVID and nothing else. And while amongst children, the ones who are aged less than 1 year have a higher chance of complications, but still the risk is very, very low. And there is again no medication which you can give this child to prevent her from catching COVID now. There is no rule of any kind of post-exposure prophylaxis. And that was earlier thought of in adults, we would give HCQ, but in now there is no rule of post-exposure prophylaxis with either azithromycin, HCQ, ivermectin or doxycycline. Now, let us come to a little bit about management of the adults because we need to know about this. So, right now, all the adults that we were discussing about, the 3 adults are having mild COVID symptoms. So, you can actually treat them at home if facilities for isolation exist. And all the infected can be cohorted together. Don't need to wear masks if in the same area. So this is a very common question which is asked by people that if I have COVID and I have mild symptoms and the other person has COVID and has severe symptoms and is coughing, will they actually infect us more? The answer is no. And will I be exposed to a higher viral load? The answer is no. So they can all be together. They don't need to wear masks. The only person who actually needs to be isolated is the elderly asymptomatic female because we should make all efforts to protect her because if she catches COVID, then she will have a bad outcome. And again, all these adults, you have to monitor their temperature and saturation after a 6-minute walk, and you have to tell them very carefully how to monitor the saturations and make sure that the pulse oximeter is working properly, and tell them that if the saturation is below 95%, then it is abnormal. And you have to also tell them that if your saturation was 98 or 99 in the first few days of the illness and then it falls to 95, 96, that also is alarming. Symptomatic therapy with paracetamol can be given, and zinc and vitamins can be given, but there is no data to say that they actually protect against COVID or they protect against severe COVID. So, the question, I didn't deal with that question when treatment of the children was concerned, but you can give them zinc and vitamin C, but that will be just like a placebo. Similarly, there is no data to suggest that drinking warm water, taking kada, taking homeopathic medicine, or taking steam inhalation will be of any value in treatment of the COVID or protecting against COVID. Also, these adults, if they are having very mild symptoms, then again, baseline investigations like a CBC, CRP, D-dimer, IL-6, etc. is not needed. And even a CT scan is not needed because many times it happens that all adults, even if they have mild COVID, a CT scan is done and the CT scan shows some changes, and then again everybody becomes very, very panicky. We must understand that you can have an asymptomatic person with COVID, and if you do a CT scan, you'll pick 1 or 2 GGOs, and that actually does not change your management. Again, as far as treatment of adult COVID is concerned, there is no role of azithromycin, hydroxychloroquine, ivermectin, or doxycycline. And also, steroid should not be given to non-hypoxic patients, because after the recovery trial data came in, which we'll be discussing a little bit later, many times, patients were started on low doses of methylprednisolone or dexamethasone at home, even on day 3 or day 4 of fever. And that actually may be counterproductive, because what it will do is it will interfere with your body's own immunity in fighting against COVID. Similarly, there is no role of prescribing anticoagulation at home, either in the form of aspirin or low molecular weight heparin, if these patients have mild symptoms. Then the question comes about favipiravir, because amongst all the antivirals which are currently available for managing COVID, favipiravir is the one which has come into the forefront. So it acts by inhibiting RNA-dependent RNA polymerase. In that respect, its action is same as that of remdesivir. And it is broad spectrum drug. It works against many viruses, including influenza. And there is data about favipiravir from China, Russia, India, and Japan. And whatever these little few trials which are available show that there is some reduction in clinical symptoms and early viral clearance, but there is no data on prevention of progression to severe disease. And also the pill burden is very high. You have to give 800 milligram twice daily on day 1, and then 800 milligram twice daily for 7 to 14 days. And it definitely should not be given in pregnant women or women who can become pregnant, because it is embryotoxic, and hyperuricemia is a side effect. Should not be given to patients who have pre-existing liver or renal dysfunction. So what I wanted to say is that at the moment, the only antiviral drug for which there is some data available is favipiravir, but again, the data is not very, very robust. So this is just an algorithm which you can follow for managing mild COVID disease, whether it is in adults or whether it is in children. So if it is mild COVID, that means the person does not have any evidence of lower respiratory tract involvement or hypoxia, and there are no risk factors for severe disease, and the fever is very mild or has gone away in 1 or 2 days, these patients actually don't need any medication. You just give them vitamins, because something you have to give them to keep them happy. You give paracetamol SOS, you monitor temperature and saturation after a 6-minute walk. On the other hand, if you have a patient with mild COVID, where the fever is either persisting, that means it's not gone away after the first 2 or 3 days, or there is a person who has a febrile illness and has risk factors for severe disease, like you have an elderly person who's running fever, then you can start favipiravir, you give paracetamol, and you monitor such a patient. If the patient improves, the fever resolves, you can give favipiravir for 7 to 10 days. If the patient is not better by day 5 or day 7, that is the time when you should actually start worrying in mild COVID, because any patient who is running fever for more than 7 days is at risk for complications, and such patients should actually undergo investigations like a CBC, CRP, T-dimer, and plus minus CT chest, and they should be admission should be considered. They should not be given steroids at home. And then if the patient develops hypoxia, that patient has to be immediately admitted to hospital and treated as a case of severe COVID. And similarly, if you have fever which develops in a patient after the first 3-4 days, you have to follow the same pathway. Now, so again, we come back to this family. Now, this elderly grandfather actually has a stormy course. His fever persisted. He was started on favipiravir, but by day 7, the fever rose and he became breathless and saturation dropped to 93%. So this kind of patient should definitely be admitted to a hospital, and no role of actually giving him dexamethasone and oxygen at home, because these patients can worsen very fast. However, if there is time is, you are taking time to arrange for a hospital bed, you can start the steroid at home, and you can ask the patient to lie prone till a bed is available. And that is why it is very important that if people feel that a patient is becoming sick and may need hospital admission, they should try for arranging a bed early on rather than wait till the last minute. Now, how should severe COVID be managed? So, severe COVID is defined as those who have tachypnea and hypoxia. That means the saturation is less than 94%, and the mortality in severe COVID ranges from 20 to 30%. So, what is non-controversial about management of severe COVID. The non-controversial aspects are oxygen, which is the cornerstone of treatment, and all units follow the same policy that they first put the patient on nasal prongs. Then if the patient needs more oxygen beyond 4-5 liters per minute, then they are put on a face mask. Then they go on to high flow nasal cannula, and then finally intubation and ventilation. And awake proning is very helpful, and it should be followed in all phases. So even intubated patients are put in prone position. What is very standard for management of severe COVID is low molecular weight heparin. Whether prophylactic or therapeutic dose depends on the severity of disease, D-dimers, etc. And basically, the current consensus is to avoid antibiotics unless secondary infections are suspected, because most patients who come with COVID in the early phase don't have a secondary infection. They get secondary infections later when they are in the hospital for a long time. And steroids have also now become standard of care in management of severe COVID after the recovery trial. What is controversial, and we'll discuss these things: remdesivir, tocilizumab, and convalescent plasma. So let us discuss each of these things one by one as to what does evidence say. So as far as steroids is concerned in COVID-19, the main trial was the recovery trial, where they used 6 milligrams dexamethasone daily for 10 days or till discharge. And basically, they found that there was a reduction in mortality, and this reduction in mortality was higher in ventilated patients as compared to those patients who were just on oxygen. And they also, the recovery trial found that if patients were put on steroids in the early 5 to 7 days of illness when they were non-hypoxic, the mortality was higher. And that is why we have to be very, very careful about using steroids in patients who are not hypoxic. After the recovery trial, there are many other trials which came from France, global trials, and Brazil. And all these trials also showed that, there was some benefit with the use of steroids in COVID. But the problem was that these trials were terminated early because the recovery trial information had come out, and therefore it was not ethical to continue with the placebo arm. And all these trials have used different steroids like hydrocortisone, methylprednisolone, and dexamethasone in variable doses and duration. And therefore, there is still a little bit of controversy, though it is agreed that steroid should be used, but which steroid should be used, how long should it be given for, should it be given for just 5 days and stopped, should it be continued for longer? And therefore, most of us who are managing severe COVID actually use steroids on an individualized basis. Now, that means some patients who are taking time to improve, you tend to give it for a longer time. But the most important thing, what we are seeing nowadays, is a lot of post-steroid infections in patients with COVID, and therefore an effort should be made to limit the use of steroids and try and stop them as soon as possible, not to use them in the first week of illness and not in hypoxic patients who are non-hypoxic. And however, there is a small subgroup of patients with COVID, mild COVID, who continue to run fever after 7 to 10 days. They don't become hypoxic, but they continue to have high fever. They continue to have high CRP, high IL-6, high D-dimers. And some of these patients may actually benefit from the use of small doses of steroids for a short duration. Now, what about remdesivir? Because remdesivir is the drug which is in the news at this point in time. Remdesivir was a drug which was first developed for Ebola, and where it showed that there was some benefit. Of course, the Ebola pandemic went away, and therefore they tried to repurpose it and use it for COVID-19. So there was this ACT trial which was published in NEJM, where there were around 1,000 patients who were randomized into two groups. One got remdesivir, the other got placebo, and the trial showed that the recovery was faster in the remdesivir group, 11 days versus 15 days in the placebo group. The trial also showed that the mortality in the remdesivir group was 7% as against 12% in the placebo group, but it was not statistically significant. And there were no major adverse effects. So following this trial, remdesivir got emergency use authorization in the US, and also it has now received full approval in the US. Then you had a simple trial which showed that 5 days is as good as 10 days. And then you had a simple 2 trial which showed that when remdesivir was given to patients with mild COVID, it didn't bring about any benefit. And then came the Solidarity trial, which was recently published by the WHO, where they gave 2,000 patients remdesivir as against 4,000 who were given just placebo, and they did not find any change in mortality or recovery in the patients who got remdesivir. So following this, there was this kind of controversy about whether remdesivir should be given or not. So the question is, what should we do? So we have a trial supporting remdesivir. We have a trial which has not yet been peer reviewed, which does not support remdesivir. So in our hospital, our experience with remdesivir has been good. And our mortality before remdesivir was available was 48% in patients with severe COVID, which has dropped to 15%. However, there may be other factors which are responsible for this fall in mortality. We don't know that. But we are continuing to use it despite the Solidarity trial results, and many other centers are continuing to use it. And it is indicated for patients who have COVID-19 and hypoxia. And in adults, the loading dose is 200, followed by 100 daily for 4 days. And in children, it is approved for use in all children weighing above 3.5 kg, where you give a 5 mg per kg loading on day 1 and 2.5 mg per kg daily. And you can't use it in patients who have renal failure or have high liver enzymes. And there is also, apart from using remdesivir in patients who have hypoxia, we have also used it in patients who are at high risk for progression to severe disease, but that is off-label use. So you have a child with leukemia who develops COVID and he has just mild fever, we would use remdesivir in such a child because these patients can progress to severe disease. What about convalescent plasma? Convalescent plasma was used since the early pandemic because there was experience about using it in Ebola and other viral infections. And whatever case series came out, they reported good outcomes with use of convalescent plasma. However, the randomized control trials which came out from China, Netherlands, and India did not show any benefit. And I think I want to talk about the Indian trial, which was conducted by the ICMR, the PLACID trial, where they took about 400 patients with moderate COVID and they randomized them into groups which received convalescent plasma and who didn't get, and they didn't find any benefit with convalescent plasma. But what is important to note is that 80% of the patients who received convalescent plasma already had antibodies against COVID. And actually, the antibody titers in the recipients were higher than the antibody titers in the donor. So therefore, you obviously could not see any benefit. And therefore, there is always, before anybody plans to give convalescent plasma, you have to check the antibodies in the recipient. And if they are negative, only then think of giving convalescent plasma. And finally, what about tocilizumab? Because we know that COVID-19 has a cytokine storm and is associated with high IL-6 levels, tocilizumab is an anti-IL-6 drug. And therefore, early on in the pandemic, they started using tocilizumab. And, there were a lot of observational studies which showed that tocilizumab reduced mortality. But the recent randomized control trials which have come out with tocilizumab, including the COVACTA trial, the IMPACTA trial, and other trials, have not shown any benefit. And even in our center, for the past 2 months, we have cut down the use of tocilizumab after these RCT evidence came in. And because we did not see any, we were seeing a lot of infections. So it is a paradox indeed, isn't it? Because despite the trial in remdesivir, we didn't stop using it. And after the trial results for tocilizumab, we stopped using it because I think it was governed a lot by what your personal experience is in managing COVID. So as far as severe COVID in children is concerned, it is a rarity and usually it is seen in infants and children with comorbidities. And these children are usually tachypnic, hypoxic. They have to be admitted to a critical care unit and they have to be treated as per adult protocols since pediatric data about severe COVID is very, very scarce. And therefore, you again would treat these children in the same way with oxygen, low molecular weight heparin, steroids, and remdesivir. So, just finally closing on, when we come back to this family again, the adults and the 10-year-old improved over the next 3 to 4 days. So they can be de-isolated and they don't need a negative test. This is very important because the tests can remain positive for a long time. Sometimes the patients ask, should we do an antibody test after 2 to 3 weeks to see if we have got antibodies? The answer is you can do it, but you cannot tell them about future protection based on these antibody tests. If they don't have antibodies also, they may be protected, and if they have antibodies, they may still remain they may still get reinfection, though reinfections are rare. As far as the grandmother and the 1-year-old is concerned who remained asymptomatic, you don't really need to test them. They can be de-isolated, and later you can check them for antibodies to see if they had actually got exposed and infected. But again, there may be patients who have got asymptomatically infected who may not mount an antibody response. And for the elderly male who comes back home after 3 weeks of ICU stay, this actually person needs a lot of care because you have to monitor for infections, you have to watch them for lung fibrosis and thrombotic events. And there was a question in the previous session about influenza vaccine. So such people should be given influenza vaccination because you want to protect them from any other infection because they have a chronic lung disease now. So you should give them influenza and pneumococcal vaccination as they recover from COVID. So finally, to summarize, so the current approach for COVID management actually begins with aggressive testing and interpretation of the report in light of the clinical situation. So do not hesitate to test because many people hesitate to test themselves thinking that the municipal corporation will come and seal their house and all that. But the correct treatment can start only with testing, and we must remember that 30% of patients with COVID will test negative. Isolation is the key, and we need to take rational decisions about investigations and medication in patients with mild COVID. Most of these patients actually need no investigations and they don't need any specific treatment. But when you have a sick patient, these have to be hospitalized early, and the center which is taking care of these patients should follow their own protocols. But usually the protocol for management of severe COVID includes oxygen, awake proning, steroids, heparin, plus minus remdesivir. And care of these patients with severe COVID continues into the later, and that is important. And as far as children are concerned, they have a mild course and they just need symptomatic therapy. They don't need any investigations. And of course, we have to watch out for PIMS, and that will be discussed later. Thank you.
Thank you, Dr. Tanu. Your talk can be rightly re-christened as from irrationality to rationality. I'm sure there will be quite a few questions, but the question session is, I think, at the end of the entire session. Will you wait till then or you would like to take the questions now?
If I can take the questions now because I have some OPD patients waiting, if I can. Are there any? Or if you want, I can join again when that is over. Will that be better?
Okay.
Yeah.
Another 40 minutes from now. 40 minutes from now.
Okay, fine.
Thank you very much.
Okay.
So we go to the next session now. It's a talk, a very, again, a very important talk on lab diagnosis in COVID. We have a speaker who is well known to all of us, pediatrician, Dr. Camilla Rodriguez. She is a consultant microbiologist at Hinduja Hospital, Mumbai. She is also a fellow member of European Society of Infectious Disease. Over to Dr. Camilla, please.
Good afternoon. Good afternoon, friends.
Just a moment, madam. Shubha, sorry to interrupt. Dr. Ramanan has to leave in another 45 minutes. Should we take his as the first lecture now? Is it possible for Dr. Camilla to wait?
I'll finish very fast because I have to go for another talk at 4:45.
We are sorry for the delay, madam. Sorry.
Okay, sure. I'll go really fast. Don't worry. Okay, friends. I don't have to tell you. Can you see my slides?
Yes.
Yeah, fine. So given the scale of this global crisis of our times, this has actually warranted for decisive and visionary strategies. And we've actually turned crisis into opportunity. Can you imagine? We actually had a RT-PCR ready in 15 days after the disease was actually described. That's absolutely unprecedented. And this is our world. We have almost 45 million cases and more than 1 million deaths. This is the 7th human infecting coronavirus identified to date. And it's a single standard positive sense RNA virus. And why are we so worried about this particular virus? I think because of its unprecedented transmission. It is easily and efficiently transmitted. And it is transmitted from our friends and foes, even our parents, even our colleagues, people you least suspect, our kids, can actually transmit this. And most importantly, asymptomatics and pre-symptomatics also transmit. So as we put this Pogo slide, we have met the enemy and he is us because we are the culprits in this. So it's all about the timing. And I'm not going into the details because Tanu has described this, but there are 3 escalating phases: early stage, pulmonary, and the hyperinflammatory stage. And if you look at the diagnostics, we have detection of the virus that can be done with a molecular method or antigen, and we have detection of the antibody that can be done from the serum. The most important step actually is specimen collection. And you have to be very careful that you use a flocked synthetic swab on a nylon handle. You simply cannot use what we normally use for microbiology, and we send off cultures. We can't use calcium alginate or a cotton swab, and wooden shafts are absolutely a no-no. The samples we take are nasopharyngeal, oropharyngeal, and later on, later in the illness, you can use sputum. We don't advocate bronchoalveolar lavages because of the aerosol, just for a diagnosis, and a nasopharyngeal is adequate. So when you actually collect it, be it a child or an adult, nasopharyngeal swab has to be done with tilting the head back and moving this thin swab to the back of through the nose till it touches the back of the pharynx. It's about 3 centimeters, 3 to 4 centimeters. Once you reach there, you twirl the swab twice or thrice, wait for 10 seconds, and then move it back. We actually also do nasopharyngeal and oropharyngeal, and that when you know you've done a good sample, when your patient actually starts gagging. So you hit the posterior pharyngeal wall, and that is what you do for an oropharyngeal sample. And we do this because though BAL is the best sample, nasopharyngeal actually has a 63% positive report, and oropharyngeal has a 32%. So we actually take both. We all know the multiple challenges with the current methods. It has low sensitivity, we've just discussed, less than 70%. Specialized swabs are required. VTM, that is viral transport medium, needs to be available. And it's a risk to the healthcare workers. Also, the patients grumble a lot and say, nahi, abhi phir se nahi karna, the usual. And in kids, it's even more difficult. Saliva is minimally invasive. And today we're looking at, sputum cups where the patient just sort of twirls a little bit of saline into his mouth and spits into the cup. Seems to have comparative sensitivity, but I don't have any experience with this. And these are the kits that are now being available, not yet in India, maybe in a couple of weeks, for the SARS-CoV-2 directly from saliva. So to keep it simple, how do we look at the virus versus the antibody? Here you have the virus. And I'm going to just now talk for the next few minutes on the molecular NAT from the respiratory tract. You have the real-time RT-PCR. And let's face it, the NAT, nucleic acid amplification tests, have really surpassed viral cultures as the gold standard. They have wider application, higher sensitivity, rapid performance, ability for field deployment. And the antigens we look for are the N, S, E, and M. They are parts of the virus, as you can see. And when you decide what targets you're using, you basically have to use an ORF, that's here. You have to use an RNA-dependent RDRP and the spike protein. You can also use E, M, and N. Actually, N is what the US uses. And this is how Europe was the first. The Charité in Berlin was the first to describe this test for RT-PCR, and they use E and RDRP. The US is completely N-based, as per the CDC, and China advocates the ORF with N. But you must use a conserved region and a specific region. When we look at the next group, that's the rapid RT-PCRs. These are really convenient, but they're expensive today. And you have the Gene Expert, which takes about 45 minutes. You don't need to worry about any fancy extraction. You just push your sample into the Gene Expert, and you get a reading like this, which we say anybody can actually do it. Even the 12 standard pass can actually do this. Similarly, we have our own Indian TrueNAT beta COV, which is again got the E gene and a confirmatory RDRP gene. Easy to do, slightly a little bit more cumbersome than Gene Expert, but it's pretty good. And if you look at the advantages of Gene Expert versus TrueNAT, basically one is battery operated, you don't need AC rooms, one is chip based, one is cartridge based. And this is a two-step procedure. The limit of detection is about less than 500 copies for TrueNAT, and here it's less than 250 copies for Gene Expert. These are two other methods for rapid detection, and they're actually just coming into the Indian market. The Abbott ID now takes just 15 minutes. And we've actually made one of our technicians' children do it. It's so easy to do. So an 8th standard pass can do this. And if you look at this, because if we deploy it, we need to look at who will be able to run these tests. The test takes about 15 minutes and the lamp takes about 20 minutes. This is the latest technology. I know you had a talk on CRISPR, but in Delhi, the CISR has actually developed this CRISPR technology. It's known as Feluda. And it has a very easy extraction, a routine PCR, and detection finally of the PCR products is done as a lateral flow or an ICT. That's an immunochromatographic test, easily done. So comparison of these major molecular methods is basically the limit of detection. The real-time one is about 0.15 to 100. Molecular are about the same. CRISPR is also about the same. And you look at the clinical sensitivity and specificity, they're all pretty good. But the real-time takes much more time than the others. I actually want to talk about usual, this is what we see every day practically. This person with a fever and cough for 3 days, an adult, presented with increasing dyspnea. He became seriously ill, collapsed, and was intubated in the ER. X-ray showed non-specific abnormalities. The nasopharyngeal swab showed that SARS was detected. He was admitted in ICU and received, as Tanu said, the usual DEXA, Remdes, and low molecular weight heparin. He improved over time. The nasopharyngeal swab was still positive at 18 days. The issue now is, how do you handle this patient? He's much better. He's sitting up. His oxygen requirement has come down. And the RT-PCR continues to be positive. So there's one drawback that we need to consider when we use these RT-PCRs. One is they fail to determine the viral infectivity, and their specificity for detecting replicating virus is poor. So if you look at this was a sick patient. These patients tend to be positive for much longer. In fact, we need a patient to be PCR negative before we move them out of the ICU. These patients should be checked usually at 15 days, but this patient, even at 18 days, was positive. And this comes into point, the CT. The CT is the cycle threshold, which is basically the point of intersection between the amplification curve and the fluorescent threshold. This is it here. Basically, it's just simply put, it's a number of replicating cycles required to produce a fluorescent signal. And contrary to what normally is intuitive, a lower CT represents a higher viral load. So is there any correlation between CT value and disease severity? Apparently not. The reason is a high CT generally means a lower viral load. It's a poorly collected swab. It could usually present at late stage or on very rare occasions, maybe early stage. And it actually comes, a high CT is when the patient is presenting with severe disease, sometimes with cytokine storm. So why is the CT not to be regarded as the viral load? One is specimen collections vary. The technique, the type, the storage and transport may influence this. CT values vary for a specimen with different kits. I mean, I may give you a CT value of 24 and another kit may give of 32. Primers also differ, and baseline threshold values also differ in the same kit with different runs. Also, we are actually not doing a quantitative PCR. We are actually doing, we call it a qPCR, but we are not using known standards. And these are really not truly quantitative. So there was a really nice study that showed that when you actually correlation between successful isolation of the virus in cell culture and the CT value using the E gene suggested that a CT above 33, 34 would mean that the patient is not contagious and can be safely discharged or moved to another ward in the main hospital. So, but we need to remember when we use this 33, 34 CT, it's actually been really tested only for the E gene. The other thing is, how long do these patients remain infectious? Remember, PCR positive will continue up to several weeks, especially in the sick patients, 98% in the first week, almost 32% in the fourth week of illness. And at that point, we need to think that the estimated likelihood of the recovering replication competent virus actually approaches 0 by 10 days. And that's the premise on which most of our guidelines in Mumbai and across the country are. The patient is doing okay. He's in the ward. If he's asymptomatic for 3 days before 10 days, he can go home and quarantine himself for a further 7 days. The infectious virus has not been reliably cultured from urine or feces. though the stool may contain the virus. And this NEJM article really puts this graph into perspective very nicely. So actually the PCR is where this whole graph is going on. And we are actually looking a lot at this post-infectious positivity by the PCR. This has been lost by about the 10th day in usual patients. There's a teeny weeny pre-infectious positivity here, but this is the long tail of RNA positivity, and many people whose infections are detected using tests with high analytical sensitivity, such as PCR, may not be infectious. Usually the CTs in the mid to upper 30s is what is indicative of this. On the other hand, let's take another case. This was a patient who had fever and diarrhea for 2 days, both subsided. 6 days later, he developed a dry cough with slight breathlessness on exertion. The nasopharyngeal swab was not detected. SARS was not detected. But the chest X-ray, the CT chest that was done showed a CORADS 4 or 5. The repeat nasopharyngeal swab, because they said, no, how this has to be COVID, again was not detected. The CRP and the D-dimer were elevated, and the question that the clinician kept asking is, could this be COVID-19? And this chart puts it into perspective. Now look at it. Look at this chart. The patient is almost 10 days into illness. And look at the nasopharyngeal swab. This is here. Usually, I agree it would be positive. This is what we usually say. But something we need to vary is that there's an estimated variation over time in diagnostic tests that's relative to the symptom onset. Let's look at his sputum. The sputum in this next chart will describe the temporal development in different sites over time. So this light green one shows how the nasopharyngeal swab, this area, will be positive up to about 10, 15, and the tail goes on here. But look at sputum in the second week. This is the lower respiratory tract. Here, this can be looked at, and that's what we did. We actually asked the patient to give a sputum for SARS-CoV, and it was detected. So why false negative? One, as we said, is inappropriate timing of collection in relation to symptom onset. Sampling types and collection techniques depends from where and from how, and how. Testing errors, and of course, reactivation or reinfection. What about antigen testing? I have one slide on this, what they can do and what they can't do. Direct detection of viral proteins using this rapid antigen detection test. It's specific, but it's substantially less sensitive than the RT-PCR. And the kit that India is using currently, the SD BioLine, is about 50% sensitive. That means, though the results are available in less than 30 minutes, and though it's really cheap to do, it should be done for patients who are really symptomatic. And all negative antigens need to be confirmed with an RT-PCR. You should never leave the patient, oh, he's negative on the RDT test or the RAT test as it's known as. You must, especially if he's symptomatic, repeat it, or the same sample can actually go for a RT-PCR. And this again is what we're all talking about across the world, low performance of rapid antigen detection tests as frontline detection tests for COVID. And this particular assay is actually just 30% sensitive. Finally, what about detection of antibody? I think it's important that as doctors, you need to know what are the type of antibodies we are detecting. The current kits that are available, the conventional detect, either they are CLIA, that is chemiluminescent, or ELISA. They detect an IgG or an IgM or an IgA. Incidentally, IgA is the first to come. Or they are also now looking at lateral flow assays like the antigen. Not good. Don't waste your time and money on this LFA. If you do a CLIA and it's positive, all it means is that you've got these binding antibodies. So this is the Indian Kavach ELISA, that is a fairly good test as well. So remember, this is the CLIA, this is an ELISA, and this is a rapid test. There are two types of these binding antibodies. One are targeted against the nucleocapsid antigen, and one are these S1. Each word is important here. The S1 receptor binding domain antibodies. It's preferred that when you're looking at these, you target the S1 RBD antibodies. And this shows, this is a heat map which shows you these antibodies generally come up. This is when it's almost 100% by about 13, 14, 15 days. But what do these antibodies actually tell us? This is again the same thing, shows that weeks 1, 2, 3, 4, by about the third week, you're usually positive. But remember that these antibodies, the ones that we are detecting with CLIA and ELISA currently and unavailable in the Indian market, actually fall pretty fast. This shows the asymptomatics may fall. Not everybody is the same in COVID, as we are learning, but the positive rate of viral RNA versus the duration of viral shedding. Look at this. The antibodies actually really may fall within 30 days, and in symptomatic patients, they may even fall within 60 days. So what we have to actually look at is the neutralizing antibodies. These are the blocking antibodies, and these actually target. These are what we would say when you have herd immunity. We're looking at herd immunity against the neutralizing antibodies, because these are completely specific to the S1 domain. And these are the so-called immunity passports. If you want to know whether you're immune from SARS, not if you have been exposed to SARS, if you're immune from SARS, this would apply for your immunity passport. Today, neutralizing antibodies are being used for therapy validation. And much more important, as we get into vaccine, hopefully early next year, we'll be able to assess their efficacy with a neutralizing antibody. And these are done by a specific test known as the surrogate viral neutralizing test, the SVNT, that is now being marketed in India as GeneScript. They're terribly expensive. I think the cost of this is 2,000-3,000 rupees. But this is the one you need to do if you need to know whether you have neutralizing antibodies present or not. The good news is that sometimes when you do your total antibodies, they may have a percentage that are neutralizing within them, but you don't know what is that percentage. And because we're not looking specifically for these absolutely RBD binding to the ACE2 receptor antibodies. And really the disease is a complex interplay of infection, immunity, and reinfection. So finally, sample nasopharyngeal swab, blood, hazardous, PCR is hazardous, its sensitivity depends on the time. Antibodies are fine. Again, which antibodies? Not the neutralizing, the ones that we are detecting as at now in India. PCR is confirmatory, and this may help if you really want to see if the patient is negative PCR, even sputum after 20 days. Radiology, last slide, is basically, as you can see, this is Dr. Soman's slide, bilateral, basal, subpleural, ground glass opacities. It's really obvious here in this slide. You have interlobular septal thickening, fibrous septa compared to a non-COVID patient. So friends, the challenges in diagnosis, the symptoms are minimal and non-specific, especially in children, hugely skill dependent. The rapid RT-PCR is convenient, but it's expensive. The rapid antigen tests are specific but non-sensitive. The routine serology only tells you that yes, you've had COVID. It doesn't tell you that you've been protected. You need neutralizing antibodies to assess that. And radiology is useful for screening, but not confirmation. So Corona is reshaping our world, let's face it. And as the waves of contagion come and go, we will continue to suffer till a vaccine is found, we hope. But as members of the medical profession, I think we need to continue to re-emphasize the Kavach mantra, which is mask up and social distancing at all opportunities. I think this will go on even after the vaccine is given. Thank you.
Thank you, madam, for that wonderful presentation. We have the next talk now by Dr. Camilla. You'll be waiting till the end of the session for the question answer session, or you'll come back and join us?
I will take it from my car because I'm driving home for another. Okay, I'll take it from the car.
Thank you. Thank you very much. Well, friends, about a month or so after Corona entered our lexicon, a group of very perceptive physicians, clinicians in the UK and USA realized that there was a specific syndrome in children, multisystem inflammatory syndrome, which was related temporarily to SARS-CoV. Dr. Ramanan is one of those clinicians who picked up this syndrome in its very early stage, and he belongs to that group of physicians who came up with the first guideline on how to manage that. We have Dr. Ramanan here for the next lecture on multisystem inflammatory syndrome in children, which in the UK is known as pediatric inflammatory multisystem syndrome. In the pediatric rheumatology circles, Dr. Ramanan has the reputation of a rock star. Why? You'll know that in the next 20 minutes. Dr. Ramanan, the stage is entirely yours. And sorry for this delay. And for this delay, it is truly unpardonable on our part.
No, my apologies that I couldn't stay longer, but what I listened to was fascinating. So let me get the screen on and let me know if it's showing up.
Yeah, you're able to see that.
Thank you very much for that kind introduction, Girish. And I know you for a long time, and it's a real pleasure. I've never been to Nagpur in person, but someday, hopefully, I will come in flesh. I'm a pediatric rheumatologist, but also a pediatrician, and do trials. I'm a clinical trialist. In fact, I listened to snippets of the talk before this one about the different therapies in adult COVID. In fact, I'm doing trials of, we've just completed a trial of tocilizumab in India, which I'm in the steering committee of, and we hope to publish that results in the next couple of months, a randomized controlled trial of tocilizumab in India, and I'm running trials of other agents such as baricitinib. But coming back to this, you've heard a lot about COVID. So to set the scene, we know it's fairly benign in children, but for this rare feature. So sometime in April, when COVID hit the shores of UK, our initial impression was that it was fairly safe in children, until in London, we started seeing a series of kids presenting quite unwell. So the college put together a small group of experts, of which I was one. And we produced this alert, which wasn't really a published document, but it was really on the college website, so the IAP equivalent, where we called it pediatric multi-system inflammatory syndrome. And obviously the Americans came after us and immediately called it by a different name a month later, saying multi-system inflammatory syndrome. We were cautious, as we always are, saying it's temporarily associated with COVID-19, because in April, we weren't sure that we wanted to say things which weren't factually correct, that we couldn't prove. And that's why the word temporal came into being. It is an unfortunate acronym because PIMS is actually an alcoholic drink which is had in the summer. And it called as PIMS probably because people were very fond of it. So what we knew then was it shares features with Kawasaki disease. It also shares clinical features with staphylococcal and streptococcal toxic shock syndrome. My talk over the next 10, 15 minutes is really going to be clinical. I'm not going to go into too much science, but if someone wants to, I can certainly go into it. And we knew it also shared features with sepsis, and we were very keen that we didn't come out with something which made pediatricians difficult to discriminate or wrongly label sepsis as a multi-system inflammatory syndrome. So this was in April, and we haven't redefined it, although we're going to do it. And I'll come back to how we're going to do it. We said if you see a child while we have the pandemic raging with persistent fever, with high neutrophils, a low lymphocyte count, and an elevated CRP, with or without organ dysfunction, and even if they fulfill Kawasaki, do consider this diagnostic entity as a possibility. But you certainly need to exclude bacterial sepsis, which is very important in the settings you practice in. Having said that, we noticed with lockdown in the months of April and May, bacterial and viral infections were at an all-time low because the social distancing and masking was really reducing the number of children getting ill. And we felt that other viral and bacterial infections should not be excluded even when we have this pandemic going on. And that most importantly, PCR testing is more likely to be negative than positive in these kids, and we'll come to why that is. So they will have persistent fever, minimal pulmonary involvement, so they will present with shock and hypotension, but rarely needing oxygen. And abdominal pain of all of these other features listed is probably the key feature in patients. And it's in the labs you're going to see a lot of distinction. You're going to see a very high CRP, but you're going to see a low lymphocyte count. And if you check the D dimers or the LDH, you will notice that they are very high. The ferritin isn't extraordinarily high. It'll only be in a few hundred or a maximum 1,000.
In the car. It's too irritating.
Sorry, can you hear me okay?
Yes, can hear you.
You can hear me fine?
Yeah, absolutely.
Yeah.
No issue.
Sorry, I thought someone couldn't hear me. My apologies. So the echo, if you were to do one.
Fed up of all this stupid. It's taking too long.
Dr. Kamila, you have to mute yourself. Thank you.
You would see some evidence of myocarditis. The chest X-ray is really going to be normal. What we noticed in the months of April and May was a series of kids who actually landed up having appendicectomy for acute abdominal pain when they didn't have appendicitis, but they had features. And they were, in fact, MIS-C or PIMS-TS patients. It happened at our center and happened in London. And actually, the surgeons in Great Ormond Street published a series of about 11 cases and produced some distinguishing features between when appendicitis should be suspected, when it's actually the hyperinflammatory syndrome. So we'll touch on the management later, but really it's very much like Kawasaki or with toxic shock syndrome. No, very soon after us, as I said, the WHO published its own set of guidance and case definition, as did the CDC, and they're all similar with some mild differences. So this was the first manuscript which came out, or in fact, the Italians published one, and I'll touch on. So this was our British experience, which we published in JAMA of 58 kids. And the key features, and I'm only going to highlight this, is that compared to Kawasaki, these children are older. And in UK, at least, we found a preponderance in African descent and in Asian kids, mainly from India, Pakistan, and Bangladesh. But not all of this might be genetic. It might be more due to socioeconomic variables. It might be that they were living in cramped housing, multi-generational housing, having a high viral load exposure. So it is hard for us to say it is down to genetics, and it's probably more down to socioeconomic variables. And as I pointed out, just if you look at the ones which I focused, abdominal pain is a key presenting feature in these children who tend to be slightly older, between 8 to 15. The other symptoms are not really standing out, although they can have a host of neurological and other non-specific systemic symptoms. Some of them, and in fact 1 in 5, will develop acute kidney injury, and almost half of them needed inotropic support. So these were children who were presenting sick with warm shock or hypotension with persistent fever, but making usually a dramatic recovery. Small numbers needed ECMO, and almost half needed intubation and ventilation. So these were needing high dependency or pediatric intensive care admission. So the bulk of the kids got IVIG. We don't know what the evidence base for that is, but because we're used to giving it in Kawasaki, and because this condition has similarities with Kawasaki, and because it's a drug most of us are familiar with, we landed up giving IVIG, corticosteroids as well. And I really don't think we can make a strong mechanistic explanation for why IVIG works, but it seems to work. Steroids we probably can understand better. A small proportion had coronary aneurysms, and in our cohort, which we published first, there was only 1 death. Since then, we are doing a surveillance project, and I've picked up 250 cases across UK over the 3 months of April, May, June, and we are collating that data, and I'll touch on that later. But the most important feature, which most of you are now aware, is these kids are antibody positive, illustrating this as a post-infectious phenomena, unlike the classic COVID in adults, which is an acute infectious phenomena. So it's probably usually seen in the community a few weeks after the adult peak in seroprevalence. So when you have a spate of adult cases, you expect to see these children 3, 4, 5 weeks afterwards, and they are more likely to be PCR negative and antibody positive, although there are, I'll come to some Indian experience, which shows they can be PCR positive as well. Low lymphocyte count is really a hallmark feature, and that's what I'm illustrating in this slide. A very high CRP much higher than what we would see in Kawasaki or other viral conditions, although similar to some sepsis. And the LDH is elevated, but I don't think this is something you can hang your hat on. So it's not a dramatic elevation. If you do the LDH, you'll notice it to be elevated. We never used to do troponin and pro-BNP, but we suddenly started doing it and started seeing elevations. I really can't understand whether this is more than what we would see in Kawasaki and in sepsis, because we don't do them usually. D-dimers we are more used to doing, and that's much more helpful because I don't think we see this higher D-dimer elevation in Kawasaki or in sepsis. It's a marker of vascular endothelial activation. It's not a marker of a risk of thromboembolic manifestation. So D-dimer is usually a marker of vascular endothelial activation. So how do you discriminate between Kawasaki and PIMS-TS? Really, these are older children. Kawasaki is unusual over the age of 5, not impossible. And the same is true for Kawasaki shock or toxic shock syndrome. So your multi-system inflammatory syndrome patients tend to be much older. The lymphocyte count reduction is much more extreme in PIMS-TS than it is with Kawasaki or with toxic shock syndrome. And the CRP elevation is much higher. So really, I'm building a picture of a patient who's between the ages of 7 to 15, who has high CRP, low lymphocyte count, and will present with mainly features of fever, abdominal pain, and if it's a slightly delayed presentation, with warm shock, hypotension, and sometimes needing intubation and ventilation. Within a few weeks, the Americans published their own series in the NEJM. And again, what I'm illustrating here is whichever states in America had a high adult cases were the ones which saw, and theirs was similar to ours, mainly antibody positive. Again, socioeconomic variables play a huge role in African Americans being involved, abdominal pain being a key feature. So I'm just illustrating that there's no difference. And they again make the discriminating features of how the older children had more gastrointestinal features or abdominal pain compared to the younger children. Hypotension was a key feature, again, the warm shock, which I'm showing. And they also saw low lymphocyte count and high pro-BNP. So essentially, the picture across the pond, the Atlantic in US and UK was very similar, but a high proportion of the American kids needing intensive care admission, suggesting there was probably a slightly more delayed presentation and a lot more need for intensive care intervention. And that's shown in the proportion needing either CPAP or mechanical ventilation or even ECMO. And the therapies were very similar to us. Most of them got IVIG and steroids in that order. This was the first one a week before the British one, and this was from Bergamo in Italy, which was the epicenter of the original European outbreak. And they saw similar to us, and this is across the Italian border in France. And the messages from them were similar, a lot of myocarditis and what they called as myocardial stunning, and need for circulatory and respiratory assistance. But reassuringly, in all these series, most of these kids did extremely well with the immunoglobulin and steroids. And this is a pictorial description, but the ones in the red is what you need to watch out for. Myocarditis, presentation with fever and gastrointestinal symptoms, mimicking an acute abdomen, and sometimes even being thought of as acute appendicitis. I'm just showcasing my colleague, Dr. Balasubramanian's Child Trust experience of the first 19 kids. And in the Indian series, in this small series, the children were slightly younger than the Western series. They probably had similar RT-PCR positive, slightly lower serological positivity, but probably this was early days. And their cohort, 2/3 needed intensive care admission, as they defined it, with hypotension being the key cardiovascular manifestation. And most of the kids were managed with immunoglobulin and steroids. So no different to the Western series, except that these kids were slightly younger. Elevated CRP was seen in all of them, but they also saw low sodium, which is more a feature of Kawasaki, a poor prognostic sign in our hands. We didn't see that much of a low sodium, but it seemed to be seen in half of the Chennai kids. High ferritin, but not significantly elevated, was seen. And deranged clotting, which is not something we saw that much, in the form of prolonged PT on INR. And when I say deranged coagulation, I don't mean elevated D-dimer, but I mean prolonged PT or high INR was seen in 2/3 of these Chennai kids, and I don't understand why that is the difference. But let me speculate in the last 5 minutes of what's happening. This is what happens in adult COVID. You get the SARS-CoV-2 exposure, it goes through the ACE2 receptor, isolates in the alveoli. You have this type 1 interferon, which is a key antiviral cytokine. And I'll showcase some beautiful data, which has just been published a week ago, which shows that the adults who get severe COVID are the ones who have anti-interferon antibodies. And then you stimulate the macrophages, the monocytes, and the B cells. And some of them, you produce a pro-inflammatory cytokine drive. And the ones who do badly are those who have anti-interferon antibodies in adults, or a suppression of the interferon response. And we know, and we talked about tocilizumab, we know that IL-6 is a key cytokine driver. Why then are the trials showing what they are? There is a sweet spot between when you get ill and who gets a high cytokine drive. The problem with some of the randomized controlled trials, particularly in the pandemic, is probably case selection. Although we will wait and see what the Indian data shows, that might show something more interesting. But this is the putative theory behind a cytokine storm and the interleukin-6 driven process. And it's only putative, it's not proven. But this is hot off the press, only a few days or week old. And this is a beautiful paper from the French, led by Jean-Louis Casanova, showing that the adults who get severe COVID are the ones who have autoantibodies to type 1 interferon. We are increasingly recognizing the type 1 interferon is probably the crucial factor in viral responses. And for those who are very interested in this, you should follow this and read it. But just to give you an anecdote, and it's only an anecdote, early in the days of the PIMS-TS in Chennai, we had a patient who, if you look at this graph, presented with a very high CRP, but immediately after IVIG did well, but not well enough to completely control the inflammation. And we tried giving 8 milligrams per kilogram of tocilizumab. And it's an anecdote, but with a dramatic effect, which we, as I illustrated, published in Indian Pediatrics. So where are we with getting good quality scientific data? I'll touch about the recovery trial. I'm in the steering committee of the recovery trial for children and what we are trying to do to get proper evidence. I'm also a part of a group called the British Pediatric Surveillance Group, led by Shamaz Ladani. We've got 262 kids with PIMS-TS, where we are carefully analyzing the data, and hopefully over the next 8 to 12 weeks, we'll publish showing what are the key features in a much larger cohort. And Mike Levine's leading some biomarker work through a diamond study, trying to understand what is it that happens in the underlying cellular level in these kids. So when we started recovery, we did exactly the same agents as the adult recovery guys, which was lepanov, ritonavir, prednisone, which you've already heard works, hydroxychloroquine, and azithromycin. And then you get randomized to a second arm, which was tocilizumab. Then very soon we realized none of these agents are really suited for kids. One, because classic COVID, like adult COVID in children, is extremely rare. And the COVID manifestation in children that was needing hospitalization was primarily PIMS-TS. So, and the real question we need to answer is, immunoglobulin is expensive, it's a blood product. Can we get away with using IV methylprednisolone? It's the question which has dogged us for 3 decades. Why is it that all vascular disease are treated with steroids except Kawasaki? That question could never be answered because it was unethical to randomly allocate a Kawasaki patient to IVIG versus steroids, since you can't do that in the Western context when you have to give every patient the standard of care. But this presented was a beautiful opportunity. So we're running this as we speak. We hope if the second wave, which is rampaging through UK, will result in more PIMS-TS, then we'll try and address this question to some extent. So we randomly allocate patients to standard of care, which is nothing, or IV methylpred or IVIG. Azithromycin will come off this very quickly when the adult recovery data shows what it will show. We also then randomly allocate patients, depending on physician preference, if they don't respond to either of these 2 agents, and this can be done immediately, sequentially after the first, you don't have to wait for 24 hours, to tocilizumab versus standard of care. Random allocation, but open label, not blinded. For those who are very interested in what the UK process is, we've just published this in Lancet Child and Adolescent Health on what is our consensus management pathway. Consensus, not really driven by eminence rather than evidence, because we don't have much of that. Again, I highlight you to that. So what are the key messages? There is this new syndrome, most of you are now aware, which is called either PIMS-TS in UK or multi-system inflammatory syndrome in US, which is really seen in communities where there's an adult COVID prevalence. It can present as acute abdomen. When you do simple laboratory tests, you don't need to do complex things like IL-6. You will see high CRP, low lymphocyte count, high D-dimer. Please don't waste anyone's money by doing IL-6. CRP is a far better marker of IL-6 than IL-6 itself. These patients will be negative for SARS-CoV-2 PCR and will be positive for serology if you can check serology. The first line management is IVIG and aspirin, as you do in Kawasaki. If for some reason you can't access IVIG or contraindicated, then IV methylprednisolone is as good an agent. And I would give 3 days of IV methylpred pulse dosing followed by a short course of oral steroids. You can, in units which have the expertise in refractory patients, consider anecdotal case-by-case use of tocilizumab. It's always worth and very important to save serum sample before you give IVIG if you have a setting where you can't test for the antibody immediately, so that you can test later. Once you give IVIG, you can't test for the antibody with any degree of certainty because you wouldn't know if the antibody is positive because you've given IVIG. I'll stop there and take any questions. Thank you very much, everyone. And someday I'll see you all in flesh and blood in Nagpur, if I'm invited.
Thank you, Dr. Ram. We'll definitely invite you as and when the time arises. Thank you very much. We have a few questions for you. You have the time to answer these questions or in a rush to leave?
No, I'll take the questions.
Some time ago, I read somewhere that the war against COVID has to be led by immunologists, not by epidemiologists. Now I understand why. I think it has to be led by immunologists. Now, the one question that we have, one major problem that we face in India is, as you rightly said, it is seen more common older children. Many of them are on the heavier side. Giving IV gamma globulin is a very expensive proposition.
Yes.
Is it ethical to say that you can get away without IVIG if the patient responds to IV methylpreds?
Absolutely. It is absolutely ethical, and it's so ethical that we are running a randomized control trial, which is the pediatric recovery or the recovery trial, where we think it's perfectly appropriate for patients to be randomized to either IVIG or IV methylprednisolone.
If they have a KD phenotype, then it becomes mandatory to give IVIG?
If they have a KD phenotype, then you call them KD, then it is less ethical to not give IVIG. So the question is, I don't want to sound like a lawyer, but if you have PIMS TS with a KD phenotype, it's ethical. But if you have KD with features of PIMS TS, it's unethical.
Which brings me to one of the questions in the chat box. How do you distinguish KD from PIMS TS in children under 5 years?
Oh, that's a difficult one. But if you, so the way we resolved this in our trial, because you can imagine in 6 months, we have faced so many hassles from so many pediatricians. I think our eventual consensus was under 5, you must have a good reason to call somebody PIMS TS. Over 5, you must have a good reason to call somebody KD. So the statistical odds are that under 5, it's more likely to be Kawasaki, and over 5, it's more likely to be PIMS TS. But if you have a kid presenting with abdominal pain, high CRP, low lymphocyte count, aged 4, and then with this antibody positivity, if you're able to get that, then I perhaps would say that's more likely to be a PIMS TS. Whereas if you have a 2-year-old, who's presenting with features of persistent fever, high CRP, even if there is a low lymphocyte count, some cutaneous features, then that patient is more likely to be a Kawasaki or should be treated like a Kawasaki.
Most of these patients have very high D-dimer. We have seen quite a few patients of MISC now in Nagpur also. Many of my colleagues are also seen, and most of them have a very high D-dimer value. So does this automatically indicate that the patient should be on anticoagulants?
No. D-dimer is a marker of vascular endothelial activation. If you go around doing D-dimer in lots of kids with sepsis and severe vascular endothelial activation, you might see elevation. It's a marker that the PIMS TS or MIS-C is a form of vasculitis. In fact, we have a manuscript in Nature Reviews Rheumatology speculating on the differences between vascular endothelial activation in children as opposed to the pulmonary endothelial activation leading to thromboembolic manifestations in the adults. If you are an adult and you get a D-dimer, it's almost always means it's a thromboembolic manifestation and you get anticoagulated. That isn't the case in children. There are multiple other conditions which give very high D-dimer. So early appropriate treatment with IVIG or steroids, depending on access and affordability and other issues, is probably more important than anticoagulation.
What about ecosprin? Ecosprin is the standard of care in PIMS.
Ecosprin is aspirin?
Yeah, aspirin is the standard of care in MISC, PIMS?
Low dose aspirin, yes. Not necessarily. We don't use high dose aspirin. Antiplatelet dose of aspirin, which is 5 per kilo.
And if these children have thrombocytopenia, at what level of platelet would you start aspirin?
I don't think low platelet count necessarily worries us about giving low dose aspirin. But if you have a low platelet count, you'll have to ask yourself, why do you even need antiplatelet dose of aspirin? The whole idea of giving an antiplatelet dose of aspirin is to avoid the platelets aggregation and leading to a potential risk of thromboembolism. So I don't think there's any need to give low dose aspirin. Let me point out to you, this is a common misconception. Aspirin's role in Kawasaki is very minimal. Why are we giving aspirin in Kawasaki? Because in 1970s, the only drug we used to give was aspirin. And then when we did the IVIG trial, it was standard of care plus IVIG. So it was aspirin plus IVIG. The first randomized control trial of IVIG in Kawasaki was 5 days. So when we went to the second trial, we had to do standard of care, which was aspirin plus 5 days of IVIG versus single dose of IVIG, 2 grams per kilogram. And it's more down to the historical context and ethics. So if I had a kid who had raised LFTs from Kawasaki, it's not aspirin I'm worried about not giving. It's IVIG I'm worried about not giving. So it's IVIG which makes a difference in Kawasaki, not aspirin.
Thank you. Any more questions?
Yes, actually, we have been seeing more of a different clinical presentation in the sense we have hypocellular marrow. We get myocarditis, we do have abdominal symptoms, but then I think 50% of our children, they are mainly above 5 years, are have hypocellular marrow.
Okay,
is that
which is interesting. we don't know what our marrow looks like because we haven't done any.
Because they come with severe anemia and the peripheral smear shows. So
Sure.
we do marrow and
it's very difficult for us to get marrow.
Methylprednisolone. We cannot give IV immunoglobulins to all, but they improve with other treatment. Yeah.
I think that's a very important point you make, and I want to the point Dr. Subramaniam makes is also important. There is this: if these children are heavy and they are underprivileged and they can't afford the cost of IVIG, there is virtually no reason not to give IV methylpred. And given that there is a randomized controlled trial running, that means there is equipoise between the two agents. So if you're sure it's Miss C, then I think it's perfectly legitimate and appropriate to give IV steroids as a first-line therapy rather than IVIG. It depends on the context of affordability and so on, but where there is issues, it's perfectly appropriate because there is equipoise.
Thank you. Any other question?
I see a few in the Q&A, but you. I see someone asking if we have children on chemotherapy presenting with PIMS, and how do you discriminate between MAS? We've only had a few kids who we had features of MAS, but because in the first wave in UK, people thought everything was associated with COVID, and so we landed up treating some of these kids as PIMS-TS or MIS-C, but they landed up being other things like MAS from other conditions. And so, if anything, what was happening was there was this overinterpretation of everything that walks into the door as COVID associated, when actually other things are also happening, leukemias and lymphomas and JIAs. So this over-reliance and over-focus on PIMS, the only advantage when you're not sure of what it is with IVIG is less likely to interfere with underlying disease process. If you were to give IV methylpred to somebody who's a leukemic with MAS or macrophage activation or hemophagocytic syndrome, you're more likely to upset the underlying disease process than you are with immunoglobulin.
Thank you. And there are quite a few questions for Dr. Tanu. Is she there?
Yes, I'm there. Yes.
Your experience of serious secondary bacterial infections in kids receiving steroids? Remdesivir in pediatric COVID?
So to that first is we've hardly seen children with severe COVID. All our children who have come are the PIMS children, and we've not really seen any secondary infections in them. But we have seen a lot of secondary infections in adults who have been treated with steroids plus minus tocilizumab, including bacterial, including fungal.
And your experience of remdesivir in pediatric COVID, if any?
Again, I would just like to say that in pediatric COVID, we mostly see PIMS, and there is no role of remdesivir. We have used remdesivir only in one infant who had, post-cardiac surgery got COVID. That's it. But, most of the patients, but from colleagues who have treated pediatric COVID and severe pediatric COVID pneumonia, children have tolerated the remdesivir pretty well. So even in adults, we don't see any side effects with use of remdesivir.
Another question which both of you can take up. Tocilizumab is considered a treatment in severe PIMS-TS, which is refractory to IVIG. Why has there been such poor evidence to tocilizumab in adult COVID? Dr. Ramanan first, followed by Dr. Tanu.
Sure. As I said, we have to wait and see. We believe, and that's only we believe, that there may be a subset of patients with adult COVID who might benefit from cytokine blocking therapies. But it's identifying that subset, what we call as personalized medicine or stratified medicine. For example, in the recovery trial, we said that you will go on tocilizumab if you're an adult with COVID who has a CRP of more than 75 because it's a surrogate marker of IL-6. Most of the studies like COVACTA and IMPACTA add that. What I would urge you to wait and watch for is the study which I've been closely involved with, which is the tocilizumab randomized control trial, which was done in India across 15 hospitals. The last patient last visit was in September, and hopefully in a couple of months you'll have the data. We're also doing trials of other agents such as baricitinib, ruxolitinib, which are all JAK kinase inhibitors. So it might be that the disease stratification was inappropriate. That's one explanation. And we don't have evidence for tocilizumab in PIMS. I just want to make it clear, it's only anecdotal experience. We have to wait and see if we recruit enough cases in our recovery trial for PIMS TS, which is appropriately powered to try and answer that question.
Dr. Tanu would like to add to this?
Yeah, so I mean, I don't agree with the statement that there is little evidence for tocilizumab. I think there's so many publications, so many observational studies, etc. The only problem is, as was said earlier, that we don't have evidence from randomized controlled trials supporting tocilizumab. They have all been negative, but it could be because the patient selection criteria was not appropriate. So yes, I agree with that. There is an element of personalization in all patients with COVID, and as I mentioned in my presentation, also that steroids also you have to sometimes your use has to be dependent on the patient. So yes, especially for us, if we have a patient who is having very high inflammatory markers and is not responding adequately to methylprednisolone, we might consider the use of tocilizumab. But clearly, indiscriminate use has come down after the results of the RCTs.
But indiscriminate use of IL-6 as a measurement has not come down. Every Tom,
Yeah,
Dick,
so
and
it is
Harry
absolutely, I mean, it is absolutely not needed. Even patients with mild COVID here in India are undergoing IL-6 levels and getting panicky. There is no role at all. So CRP is a best marker actually. And what is happening is that people are testing for IL-6 levels after tocilizumab has been given, and those levels become very high. Then these patients, poor patients, get extra doses of tocilizumab or other anti-inflammatory drugs. So, it is no role at all of monitoring for IL-6 in patients with mild COVID at least, or in any patient with COVID after IL-6 blockers have been used.
And just to add to that, as someone who does laboratory science, measuring cytokine levels is not easy. So there's a huge variability. It depends on the time of collection, the mode of transport, the type of sample that's received in the lab. So you can have a similar sample collected and sent to 3 different labs, different variable levels of IL-6 because of the measurement errors. So cytokine measurement is not as simple or standardized as CRP measurement, which is much more homogeneous. And that's the problem. It's unless you have very good faith in the way the sample was collected and how it was transported and how it was measured, measuring IL-6 levels is prone to multiple other errors, and it doesn't add any value. We haven't done it in any of our UK adult patients. I'm involved in quite a few of the adult trials. We just don't do it. We do it in the industry studies because we can, and that's always centralized. But we don't do it in any of, for example, in recovery or in UK standard of care, nobody gets IL-6 measured. Nobody, no matter how ill you are.
We have progressed. Everyone gets it now. Yeah. Dr. Tanu, a couple of questions for you.
Yes.
How long isolation after the patient has recovered from COVID? And the second question about Feluda test.
So I mentioned that. So if the person, as we go by the government of India guidelines and the CDC guidelines, which say that in patients with mild COVID, they can be de-isolated 10 days after the onset of the symptoms, and 3 days have elapsed from resolution of fever. Whereas if you look at severe disease, there is a little bit of difference. If you look at the Indian guidelines, they say you document a negative test before de-isolating them, which we don't follow practically because many of these patients are test positive for a long time. So if you look at the CDC guidelines, they say 20 days is the time after onset of symptoms in a patient who has severe disease that you can de-isolate them. But we must all understand that the transmission of COVID mainly happens before the onset of symptoms, over 3 to 4 days after the symptoms have started. In fact, there are studies which have shown that there's hardly any transmission after 5 days from the onset of symptoms. So I think over time, this duration of isolation will actually get cut down even further, to the point that there are people saying you follow the same thing as flu, that 24 hours after your fever goes away, your infectivity has dropped.
Another question about Feluda test.
I don't know about the Feluda test. This is the first time I've heard about it.
This is Camilla. Can I just chime in here? Basically, the Feluda is the CRISPR for India. and it's been developed by CSIR. It's going to be marketed on the 9th of November. It seems to be a much easier test than the conventional, the real-time RT-PCR. It should be done in a lab that has a small machine. You don't need the ABI fancy machines. So it should be a good test.
Final two questions. One is, has IVIG been in adults in severe COVID?
So I just wanted to say, one thing is we are seeing multi-system inflammatory syndrome in adults now, and we have seen 7 cases so far in the past 3 weeks. So that is a situation where clearly we had 3 patients where we couldn't give IVIG because of cost issues, and I mean they all succumbed, whereas 2 we were able to use them. So that would be an indication. And the second would be possibly myocarditis. There is some role whether, if you have COVID associated myocarditis, there would be a role. But doctor, maybe you can add to that. Yeah.
We considered IVIG as a therapeutic arm in recovery trial. The reason we didn't go for it is, one, it's the cost, and also we had convalescent plasma as one of the arms in recovery. So that might be, they are fairly doing similar things, because if in adult severe COVID you're considering IVIG, you're probably thinking of some antibodies from those who are recovered. So we went with the convalescent plasma route. And also, you have to take therapies which are going to be feasible in terms of cost implications. To give 70 kilo adults 2 grams per kilogram of IVIG, and in recovery we recruit 2,000 adults per arm, you can imagine it's enormously expensive. More than the expense, it's short supply as well. And we have huge issues with new variant CJD, so we only use non-British donors for our IVIG. So there are multiple issues, for which reason I don't think it's even worth getting into a trial with.
I think the last question for Dr. Tanu, if you were to look into the future, Nagpur itself is seeing a very low number of cases. Do you anticipate a second wave?
I don't know the answer. I'm sorry.
Girish, I have a question for Dr. Tanu. Can you share your experience about COVID positive newborns?
Not too much of experience, because we don't run a maternity center which delivers COVID positive women, but whatever deliveries we have had in our hospital, we tested the newborns and they were negative and they remained fine. Because one more thing I would like to say is that many of the pregnant women who actually deliver and who are COVID positive are asymptomatic COVID positive, because they just it's a routine to test COVID for all women before they deliver, and we find that they're COVID positive but they have no symptoms, and these women, when they deliver, the babies are fine, and we kind of room them with their mothers and just do one test and then send them along with the moms. So haven't seen anything really bad happening here.
There is an ongoing study which should come out very soon from, I've just put it in the link to all the panelists, which is neonatal complications of coronavirus. The College of Pediatrics.
Yes, we are seeing, yeah.
The College of Pediatrics is doing a detailed analysis of every neonate who's been tested and turned out positive, but I suspect it will be fine, and most of them will be incidental.
Okay, thank you.
I think Dr. Shubha, I think we'll call it a day now. Thank you, Dr. Kamila, Dr. Tanu, and Dr. Ramanan for an outstanding experience.
Thank you so much.
Thank you.
Once Corona leaves us, you will all be traveling to Nagpur for the next year or the year after that.
Yes. Hope to go to Tadoba.
Open invitation to all of you.
Yes. Thank you.
Thank you, our speakers, for such a wonderful session, and our chairpersons for chairing the session. I would like to hand over to our next session in charge, Dr. Alka and Dr. Sanjay. Over to Dr. Alka and Dr. Sanjay.
Dr. Rohini, this is Dr. Sonia. I will be handling this session.
Okay, fine.
Yeah. Good evening, everybody. This is Dr. Sonia Arora. Let us begin with our session, My Child. First session starts with My Child Has a White Patch. Our speaker is Dr. Vikrant Sahuji, sir. He is a consultant dermatologist at Nagpur, a visiting professor, JNMC Wardha, undergraduate and postgraduate teacher, ex-president IADVL Maharashtra, have 30 publications, and our chairperson for the session is Dr. Kush Junjunwala sir. Sir is practicing pediatrician at Gandhi Bagh, Nagpur. Sir, please.
Hello, Dr. Sonia. I don't see Dr. Kush.
Ma'am, I told him about the timings. Sir,
Okay,
ma'am.
it's fine. We can go ahead. Yes, over to you, Dr. Savji.
Yeah, I think good evening, and I think with all your interesting COVID discussion, now we will be dealing with more common, relatively severe but a common problem. I'm going to talk on child with a. Okay, yes, I'm. Yes, can you see my screen?
Yes,
Yeah,
please go
okay.
ahead.
So, yeah, so I'm going to talk about a child with a white patch, and we all know skin color is because of the pigment produced, that is melanin, produced by the melanocytes, which are derived from neural crest cells, which are ectodermal derivatives. And these melanocytes are present in the dermis, basal layer of the dermis. And when we are talking about white patch, there are two concepts. One is hypopigmentation, hypopigmented patch, that is pigment is little less. So it is light brown color patch, and the depigmentation, that is totally white, totally devoid of pigmentation. And I will be dealing with some of the common problems we all encounter in your practice. So one is this vitiligo, a more serious, though benign looking lesion, but has extremely high psychological impact. So this is characterized by milky white or depigmented patch with an otherwise normal skin texture. And this white patch is produced because of the destruction of melanocyte by the autoimmune process. So melanocytes are destroyed, so no melanin is produced, and that's why the patches look white. And these are a typical clinical presentation of vitiligo. They show white, uniformly white lesion with a very clear-cut border and a normal skin texture. They are asymptomatic lesion. You may get white lesions, white hairs, or you may not get. And what is more important, 40% of the patient onset is before the age of 20. So this is a very classical clinical presentation of vitiligo, a well-defined white patch with a normal skin texture. This vitiligo can be focal, where you have only few lesions here and there, or it can be segmental, involving one segment which is restricted to one side of the body, or it can be generalized. Now, being an autoimmune process, it may be associated with thyroid dysfunction or other autoimmune disease, but thyroid is very common. So many people investigate thyroid function and thyroid antibodies in vitiligo patients. So this is the type of segmental vitiligo. You can see strictly on one side of the body. It can involve any body areas, including genital areas. Very classical book picture of vitiligo, a well-defined lesion. And treatment, it's an autoimmune process. So first, control the autoimmunity by using immunosuppressant like steroid, and nowadays we're using azathioprine also. And to repigment those depigmented lesions, we use phototherapy. So with this, nowadays we get good result in many of our patients. Now, similar is post-burn leukoderma. Now, many people use this term leukoderma and vitiligo as synonymous. But the difference is vitiligo is a primary condition without any known cause, supposed to be autoimmune, leukoderma is secondary. So any post-inflammatory patch many times produces depigmentation. You all must have seen post-burn lesion to be depigmented. It is because of the destruction of the melanocyte. And this has a much better prognosis than vitiligo. Then nevus. Nevus are developmental errors occurring during the embryogenesis. So in nevus, there is a normal tissue component in an abnormal proportion. So the proportion is abnormal, but the tissue is normal. There is no atypia of the tissue. So nevus is also called as birthmark because majority of them are present at birth or appear very shortly after birth. But there are nevus which appear later also. Nevus represent clones of genetically altered cells. And many times, this is what we call mosaicism. They have altered cells of nevus and the normal cells. So that is what we call mosaic. And then this altered cell, they spread along the line of Blaschko during embryogenesis. What is the line of Blaschko? It is the path of cell migration during embryogenesis. So usually the path is little zigzag or whorl pattern. That's how you get the nevus in that pattern. So abnormal clone arising at very early stage, you will have widespread lesion, and you may also get involvement of the other body organs. Or the abnormal clone arising late during embryogenesis, you may have a single or localized lesion. This is the very classical lesion. Nevus can involve any tissues. When it involves melanocyte, we call it melanocytic nevus. It can be hyper or it can be hypopigmentation. So today's topic is hypopigmentation. So this is a very typical nevus acromicus or depigmentosus. So you can see the zigzag border here. So it has a zigzag border, appears very early in life, remains stationary throughout the life, and it is usually asymptomatic. And mostly no treatment is required, is just what you need is a camouflage. So this is the difference between the two. You can see here, this is a nevus, and you can see the irregular zigzag border. This is very characteristic of nevus, appearing very early in the life, remains stationary, asymptomatic, and you have a zigzag border. And this is a vitiligo which appears late. You see a very regular border, and it may progress or it may subside also with treatment. Another case of nevus acromicus, you can see the zigzag irregular border of nevus. This is a type of nevus where the abnormality occurs very early in the embryogenesis, so you can have a more extensive lesion, and you can see sharp cutoff in the midline. Same thing, you can see the sharp cutoff in the midline. So zigzag border, irregular surface, and you can see sharp midline cut. So this is the type of nevus acromicus where the abnormality occurs early during embryogenesis. So what is the characteristic feature? It appears very early. It is a localized area of depigmentation, sometimes may be more severe. It is present since birth or early onset. It remains asymptomatic, remains stable. And when you have a more widespread nevus, maybe there's a possibility of other systemic involvement. So you must look for other deformities. Another common problem you all people must be coming across is pityriasis alba, which is characterized by one or more round hypopigmented patches on the face. And you can see the borders are not very sharp, unlike vitiligo. So they are not very scales. And there is a lot of misconception, but one thing is very sure, it has nothing to do with worm infestation or vitamin deficiency. It's just an eczema. It's a mild type of eczema. It may be a manifestation of atopy, and it's very common. Around 5% of the pediatric population may have this lesion. Because it's a mild eczema, many times it is self-limiting. You need not treat it very aggressively. Many people don't treat it also. If you want to treat, you can use mild topical steroid or tacrolimus, which has got a steroid-like action. And sometimes only moisturizer also helps. But it has a tendency of recurrence. So don't worry, it's a mild disease. So the very classical pityriasis alba. Another important, more serious is leprosy, which causes you can get other systemic involvement also. Depending on the immunity, is classified into paucibacillary, where disease is mild, or a multibacillary leprosy. Paucibacillary leprosy is associated with a hypopigmented patch, and the multibacillary, usually the hypopigmentation is not very prominent. So paucibacillary leprosy includes tuberculous leprosy or borderline tuberculous leprosy. They show a hypopigmented patch, which is not flat, usually raised, slightly raised. They show fairly well-defined border with a significant sensory loss and nerve thickening. And it shows a very dry surface because of the destruction of the sweat gland and sebaceous gland. The hairs are also destroyed by the granulomatous process. So you can, if you are careful, you can see the sparseness or absence of hair in the lesion. I told you it is basically hypopigmented patches seen in paucibacillary leprosy, and multibacillary lesions are much more diffuse and less hypopigmented and little difficult to appreciate. But this hypopigmented patch of leprosy is very classical. You can see fairly well-defined lesion with a chronic patch, hypopigmented patch, rough surface. It's a raised lesion. And you can see, if you can see very carefully, you can see the hairs are relatively lacking in this patch. So this is very typical of borderline tuberculosis. See the hairs. Another important lesion which may be of importance to pediatrician is tuberous sclerosis. It's a neurocutaneous disorder. It's an autosomally dominant disorder which has got a lot of manifestation. But the most important is Ashliff's macula or Ashliff's spot. They are hypopigmented diamond-shaped lesion patch, which like the nevoid lesion has little serrated borders. So this is the of all this manifestation of tuberous sclerosis. It is one of the earliest manifestation. And many times this macule, they are usually multiple. They are present at birth. But in 80% of the patient, if it is not present at birth, it will appear by first year of life. So it has a diagnostic clue. So if you have a child with convulsions and there is no other clue for the etiology, look at this patch, and if you can find, yes, your diagnosis becomes clear. So this is a good diagnostic clue. It's a tuberous sclerosis. You can see a different lesion of tuberous sclerosis. It may be small, it may be large, but another case of Ashleaf macule. And these patients, they also have small adenomas sebaceum. They're small pigmented papules. Many times can be mistaken as acne. So these are tuberous sclerosis. Another thing is tinea versicolor. This is a lipophilic fungal infection. It is a lipophilic. It requires oil for fat for its survival. So sebum is an important source of oil for this fungus to survive. And the sebaceous secretion start only after puberty. It requires sex hormone. So either you can get in infants because of the maternal active hormones, or you can get after puberty. So they are asymptomatic, superficial, hypopigmented macule associated with fine scales. And the treatment is usually antifungal. So you can see this is recently, I've seen a 8 months child, and the mother also had tinea versicolor. So you can do KO smear and you can demonstrate the fungus. It responds very well to the treatment. Now, not all the time the diagnosis of hypopigmented patch is very clear. This is the child which presented with this multiple hypopigmented lesion. The sensation is normal. There's no granulomatous look. The nerves are not thickened. So it was not Hansen's. For vitiligo, it is not that depigmented. So there's a diagnostic dilemma. It can be non-specific eczema, or it may be parasoriasis. So it is not possible for every time to put diagnosis for a hypopigmented patch. Sometimes you need to observe this patient, keep the patient under observation, and with time the diagnosis become obvious, whether it is a vitiligo, whether it is parasoriasis, or whether it is something else. So wait and watch. Observe the patient. Every time you cannot just see the patient and tell the diagnosis of a hypopigmented patch. Thank you. And this is all about the common hypopigmented lesion we see in our practice.
Thank you, sir. Thank you, sir, for a very lucid and pictorial lecture. I think the question answers will be taken at the end of the session.
Okay, thank you.
Thank you. So over to Dr. Sonia, please.
Thank you, sir. Very nice session. Our next session will be by My Child is Not Walking Properly by Dr. Viraj Hingade, sir. And the chairperson is Dr. Praveen Lad, sir. Sir is a senior pediatrician practicing at Chakadhara, Nagpur. Dr. Viraj Hingade, sir.
Hello. Hello.
Yes, sir, you are audible, sir.
Am I audible?
Yes, sir. Yes, sir, you are audible, sir.
So the next session is by Dr. Viraj Hingade. This topic is My Child is Not Walking Properly. Basically, properly is the main, not walking properly. And this is the today's discussion, topic of today's discussion by Dr. Viraj Hingade. Basically, it doesn't need any introduction, but as a matter of protocol, I must introduce him. He is a pediatric orthopedic surgeon and director of Pravira Hospital, that is a Children Orthopedic Care Institute. He is a recipient of many national level research awards for his successful surgeries for clubfoot, cerebral palsy, and congenital radio. He has to his credit around 24 international publications and was guest speaker at around 73 international conferences in US, Japan, and various countries for his innovative surgical techniques. He is president of Nagai Narayan Memorial Foundation as an NGO, and the NGO is working for rehabilitation of various children with a disability, and he is conducting surgical free camps wherein around 4,000 children per year get benefit. He provides them free food, free indoor facilities, and free surgeries. And that is not the only the thing. physiotherapy is also provided free of charge. So he's doing a great work, and I wish him all the best. And may I request Dr. Viraj Shingade to start his lecture.
Hello, am I audible?
Yes, sir, you are.
Hello? Yeah. So thank you, Lard sir, for that kind introduction. I'm really thankful to Dr. Kirwadkar madam, Dr. Mustafa, and all scientific committee chairman, Dr. Dua, and team IP. So we are going to discuss today that when a parent comes with a lot of apprehension that my child is not walking properly. So we all know that trauma is one of the commonest cause for child is not getting properly or not walking properly. But we are not going to discuss the trauma part because there are much more important points or much more important causes what are required by a pediatrician to be known, right? So we'll discuss more common causes. So let's watch this gait. So the child comes, when the parents come, Doctor Saab, bachcha kuch theek nahi chal raha hai, kuch to pair tede lag rahe hai, right? And when you see that the ankle are touching, there is a huge gap in between the two knee joints, right? So when the ankle are touching and there is a big gap in between the two knees, this is the commonest presentation of the what we call as a genu varum, or what we call as a bowing of the legs or bow legs, right? You just take the X-ray to just rule out that there are no other metabolic pathologies which are there. So simply this is the genu varum, and usually these children they have the spontaneous resolution and they are to be assisted by certain exercises and sometimes very rarely some splints, right? So this child, when he presented like this, see 1 year, 2 year, and then 3 years, the deformity is completely corrected, right? So this is a simple genu varum. Now let's look at the other child. The similar looking child walking with a similar gait, but if you see carefully, there is a widening at the ankle or at the malleoli. There is a widening at the wrist, right? So, and if you take the X-ray, that gives you the clear picture that there is something wrong. So this is a classical rickets. And when you give them the vitamin D therapy, you can see there is immediate effect. The healing started, and this is how at 1.5 years, the deformity is getting corrected. So they take little more time. So one should not assume that the deformity is going to get corrected immediately. They take little longer time. So the counseling has to be there by the pediatrician that, look, the child is going to take little more time for the deformity getting corrected. Now, opposite to this deformity, this is another problem for which the parents usually come with the child. Now here the knees are touching, right? Everybody is appreciating, right? So their knees are touching and now there is a gap in between two ankle. So this is a classical genu valgum. So another common is developmental problem. Now this is a genu valgum. Again, there is a possibility of spontaneous resolution in most of the cases, and sometimes they may be assisted by some kind of the exercises protocol. Like this child, when he presented, there was a severe genu valgum, and subsequently see with 1, 2, and 3 years, the deformity is completely corrected. Sometimes they may require some kind of splintage also for the deformity correction. But it is not like that every child, the deformity will be corrected. You may get the progression of the deformity to worsen like this. And at this stage, they require a surgical correction where we have to correct the femur as well as the tibial component of the deformity.
20 मिनट लेट चल रहा है.
Hello?
Hello?
So now this is how the deformity is completely corrected. Okay. So this is the in the area where you need a surgical intervention. But what are the newer advances? There are newer advances where if you detect these deformities later earlier and you can prevent them progressing to worsen and you can prevent a major surgical intervention. What do you do? We just, why there is genu valgum? Because the medial aspect of the tibia as well as the lower end of the femur are growing faster as compared to the lateral aspect. So we stop the growth on the medial aspect. This is a very mini-invasive procedure in which the child is walking, a very simple procedure, not very mutilating, and this kind of deformity, you can see there the intermalleolar distance is almost 17 centimeters. When the child has a severe deformity like that, within a span of 1 year, the deformity is completely corrected. Okay, and why it is important, particularly in girls, when they start the menses, before that has to be the surgical intervention has to be done, because Once their maturity is completed and the growth plate is fused, this kind of surgical intervention is not possible. And that is why you have to detect this deformity a little earlier. And this is how the child who was walking like this now is walking almost normally. Okay, so this is another common developmental problem. Now let's see the third commonest developmental problem. When the child comes to you and present with this, you can see the foot progression angle. See how the child is walking. Parents बोलते हैं डॉक्टर साहब पैर अंदर की तरफ घुमा के चलता है. And if you see, usually they have a tendency to sit in a W position. So there is a gross intorsion in the femur. This problem can be again solved by just simply ask them to change the posture. So the child is asked to change the posture, and certain exercises protocol the parent has to follow. This is 1 year and this is after 3 years. So these children, if you see, gradually the torsion is getting corrected. At 3 years, the deformity is completely corrected now. Okay. So they take also some time. It is not that immediately the deformity will be corrected. Now, from the developmental problem, we'll come to little more serious issues. This is a girl. See the way she's walking. So when a child is walking without the pain, and there is the child has a difficulty in walking. So the first and a very important thing what we have to suspect is a septic arthritis. This girl had a septic arthritis, and don't rely too much on the antibiotics. The parents refused the surgical intervention, and she received just antibiotics. And this is how now this is a permanent disability what she has. If you see now, the head and the neck of the femur is completely missing, right? So this girl has completely, her femoral head and neck has completely gone, which could have been even ideally would have been prevented if there would have been surgical intervention at the earlier stage. Why I'm telling this or why I'm stressing this? Because you see the most of the septic arthritis coming in the neonatal age group, where the baby stop moving the limb. So this, if you see the right limb, the baby is not moving. So when the baby stops moving the limb, the first and a very important suspicion should be about the infection. You can do, and most of the time the diagnosis is clinical. You can do simply X-ray or the sonography, and that comes with the diagnosis. MRI is very rarely required in neonates, but it is very helpful in infants and children. If you have doubt, never bother and just go ahead and do the MRI, right? And of course, this has to be supported by the blood investigation. Why it is important? Because this neonate, when diagnosed, you can see there is a gross femoral destruction and as well as a dislocation. The infection, what does infection does? It pushes the head outside. So at this stage, if you just keep on pushing the antibiotics, the antibiotic won't reach at the infection site. So you have to take the surgeon's opinion where the toxic enzymes has been, we take out the toxic enzymes by giving thorough wash to the joint. It helps in penetration of the antibiotics to the infection site, and you can get the culture also. So just don't rely too much on the antibiotics. Just take a surgeon's opinion. And now there are very mini invasive procedures which are available. So we don't need to give the very major incisions by which we can give wash to the joint and infection can be brought under control. They require some kind of splintage and the protocol so that the hip will go inside, right? And is there any role of oral antibiotics? The answer is no. The antibiotics has to be IV, and they should be at least minimum 3 to 4 weeks of the period of the time. Why I'm telling this in detail? Because you see the head, which was looking like a dislocated and completely destroyed. See, within 2 months of the span, it is going in now. And this is a follow-up of the same child, right? You can see both the femoral head now. The femoral head is appearing very well. And now it has appeared as good as normal on the other side. And this is a 5-year follow-up of the same girl. You can see now both the femoral are developing very well, and this is 9-year follow-up. So the girl in which there is a septic arthritis, when she presents in the neonatal age group, now she's absolutely normal. She's doing all the activities, right? And you compare the other girl in which she has received only antibiotics and this has caused. Okay, so this is a permanent disability what the child has, which could have been easily prevented if the surgical intervention would have been done at an early stage, right? And this is our job. Now, does that mean that every child is going to have the pain and septic arthritis and fever? The answer is no. Many times you see the children, they walk with this, there is a lurch. If you can watch this video again, there is a lurch, but not much pain, and there is no fever. If you take the X-ray, it is not infection, it is just a simple synovitis. It could be just a reactive synovitis with resolve in a period of short span of time at 12 days, and this is at 3 weeks, the same girl, right? So don't be in hurry of starting the antibiotics, right? If you start antibiotics with orally, then you may mask the infection, it will flare and it will go on moving to other part of the body also, right? So don't make any hasty. Another example of the painless symptom is the Perthes disease. See the gait in this child. He is walking with the limb, he is walking with the lurch, see on the left side, but there is no pain. And if you see the X-ray, the head is collapsed. It is a stoppage of the blood supply of the femoral head. That is called as a Perthes disease. It required the surgical intervention, and you see the gait, you can compare. Now he's almost walking normally, right? So this is another disease which, if you diagnose earlier, many times the complications can be prevented. If there are multiple involvement of the joint, see the gait in this child, and he has a very difficult in walking. You see the swelling at multiple joints. This is classical, nothing but a multiple joint involvement is a JIA, right? This is a idiopathic arthrosis. Don't forget the tuberculosis. This girl, see the way she is walking. This is a classical flexion and abduction contracture. So tuberculosis is still very, very common in our country. So never forget that there could be the tuberculosis of the joint. Now let's see some common congenital problems with which the children present. This is a boy who presented with this deformity. The foot is turned inwards. Very, very common congenital problem, and anybody can diagnose this is a club foot, right? So what are the solution for these late presenting children? In the literature, they mention about to do the Elizaro, all the Russian techniques, all they are very, very expensive. They require lakhs and lakhs of rupees, which our patients are not affording. So we devise our own technique for this kind of deformities for these children, and now it is very widely accepted in most of the part of the world, and then many of these neglected children are getting benefited by this surgical technique, right? So this is a follow-up of the same child. The deformity is completely corrected. Another girl, she presented, she has been operated twice elsewhere, but the deformity could not be corrected. And with our technique now, see the way, see the function. This is a 7-year follow-up of the same girl after surgical correction. Now there is a good function as well as a normal gait. Usually then they present at the neonatal age group, and then you have to start with the just simply plasters. So don't wait too much. Simply plaster and simple, a very, very small surgery, and thus the deformity is completely corrected. So the club foot, when the neonate present to you, the treatment should be started immediately. Now let's consider another common, very common congenital condition. This is a child who presented in the walking age to the pediatrician, and he is walking with the short limb gait as well as there is a lurch. If you take the X-ray, the hip joint is dislocated. So this is a congenital dislocation of the hip joint. So do we need to wait till this stage? The answer is no. If you have the first female baby with breast presentation and abnormal thyroid, you can definitely suspect. It is only the 2 minutes which the pediatrician, when he goes for the obstetrician call after delivery, it has to spend only 2 minutes by doing the simple 2 tests. One is the test where you simply hold the limb and abduct. So the hip which was dislocated, it will go in. Now the hip is dislocated. It will just go in, and you can feel the clump by your hands. This is an autoline test, and the Barlow's maneuver where you apply the pressure along the long axis of the femur. See, this is a Barlow. So hip which is dislocatable, it will dislocate. So these are the simple 2 tests which the pediatrician can perform. Why it is important again to diagnose at this stage? Because this baby, when diagnosed at the earliest age group, this hip, see the hip was completely out. And simply with the pelvic harness belt, which may not cost more than 500 rupees, and you can see the hip is completely safe and both the hips are equal. On the other hand, when the child present at this age group, when there is a lurch, there is shortening, they require a major surgical intervention where we have to reconstruct the complete acetabulum as well as we have to put the hip inside. And this boy, this is after surgical correction, you see, he's walking now normal. And this is a further follow-up. You can see that there is a good reconstruction of the acetabulum. And this is a further follow-up, 6-year follow-up of the same child. We have to keep the children under regular follow-up. And this is almost a 12-year follow-up where both hips are equal now and the child is doing functionally everything. Okay. So this major surgical intervention would have been prevented if the child would have been diagnosed earlier. So what happened? This is another example I will show you. This is a very, very important example. This is an 8-year female child. She presented with this gait. See the way she is walking. She has a completely reverse knee. We have the flexion. We bend our knee forward, backward. She is bending the knee forward. And she was walking just like an animal. And she never went to school because of the other children were scared that what kind of creature has come to school. And the parents are not comfortable. And see that this is nothing but a neglected knee dislocation. She has been to many institutes and she was refused surgeries. We took the challenge and performed the surgeries for the first lower limb first, and then second limb. Almost so she has almost undergone 6 surgeries, and now we could be able to make her stand and walk, and now she is going to school also, right? So the girl, who was walking and she could not go to school, now she's walking like this. Of course, I'm not saying this is normal, but we could took the challenge and we can make the girl independent for her day-to-day life. On why I'm again telling you, because the neonate, when present with this knee dislocation like this, simply the plasters, which we are not really expensive, if you go at serial interval and the deformity is completely corrected. So the previous girl would have, if you would have diagnosed at that stage and gone through this, she could have been out of all this major surgical intervention. A few word about a neuromuscular problem. We know that when the children they present at the little developmental, they have a developmental delay. This is and spasticity in the lower limb. So this is a classical cerebral palsy or the cerebral palsy. You can see. So again, cerebral palsy, they require a team approach. When the child is walking like this, requiring some support, if you work as a team, and this is after surgical correction, and see now you can make them independent. You can't make them normal, but you can make them independent. I'm blessed that I have most of good pediatric specialists, therapy specialists, including the physiotherapists, occupational therapists, speech therapists, developmental pediatrician, and all the team, pediatric neurologists, right? They're working day and night at our center, including the orthopedist unit, and we could make most of these children independent for their life. This is the equinus deformity, which we correct. When they walk with the equinus, we can correct deformity. They require tendon transfer also. See, this is a hemiplegic child. See the upper limb and lower limb. She's walking with the inward turn foot. So after doing the tendon transfer, now she's walking almost like a normal child, right? So many of these spastic, diplegic, and quadriplegic, they can be made independent for their gait or for their life. At least you can make them independent for their life, right? So it is always a teamwork. I hope I'm not exceeding the time. So friend, it is not because things are difficult that we do not dare. It is because we do not dare that the thing becomes difficult. So good results are still possible in most of the pediatric orthopedic problems. So whenever you see the child, don't suspect that it has an infection or it is. You have to see a plethora. You have to see the whole horizon of the diagnosis, which can be say when the child is entering your chamber, you can diagnose most of the conditions by just simply observing the gait of the child. So if you work as a team, nothing is impossible. I thank you again, Team IIP, for giving me this opportunity. Thank you. Thank you very much.
Thank you, Dr. Shingade. There is nothing like walking with our own limbs, own legs. They are more important. And you are making all these disabled children, all these with multiple deformities to walk with their own limbs. They are really grateful. And we as IIP members and all from IIP AOP Nagpur, we thank you very much. It was a very lucid talk. And I don't think there are any questions. Are there any questions? I don't see anything in the chat box.
Yes, sir. Thank you, Dr. Shingade. Let's move on to the next session.
Yes, ma'am. Next session is by Dr. Meenakshi Girish, ma'am. Topic: My child is not talking. And the chairperson is Dr. Sandeep Dankhede. He's from Amravati. He was President IIP Amravati 2017, Chief Editor for Maha IIP Bulletin 2020, and Chief Organizing Secretary for Mahapedicon 2019.
Thank you, Dr. Sonia. Can you hear me?
Yes, sir.
Yes.
Yes. After that wonderful talk by Dr. Virat on walking, now is the time to talk about talking. And our next session is My Child is Not Talking. And we are lucky enough to have a speaker, none other than Dr. Meenakshi Girish Madam. Dr. Meenakshi Girish Madam is a professor and head of the Department of Pediatrics of the prestigious Institute of All India Institute of Medical Sciences, Nagpur. And she is a wonderful orator and a well-known academician. So without wasting much of a time, I hand over the mic to Dr. Meenakshi Girish Madam. Over to you, Meenakshi ma'am. Meenakshi ma'am, you can start. Are you there, Meenakshi ma'am? Or you can take the next session if madam is not there.
I'll share screen again. I lost connection for a brief period of time.
Okay, ma'am. Yes, here we can see you, ma'am.
So the topic given to me is my child does not talk, and in the next 10 minutes, I'll try to do justice to this very complex topic. So I want all listeners to imagine that a parent has walked into your OPD, not aware that most developmental milestones have a wide range of normal attainment. Unfortunately, language has the widest range of normalcy. So this is the most difficult issue for the pediatrician. And before, I would like to say, before the pediatrician assures the parent saying that this could be just a developmental delay, there are a few things that you need to do in your OPD within the resources that you have. And when a child walks in with a complaint that the child does not talk, obviously the first thing everybody should do is to consider hearing defect. Now here I want to emphasize that don't be fooled by the parents' assurance, quick assurance that my child can hear well. In fact, he turns his head to the sound of a pressure cooker. Please remember, there is a reason why the Western world has come out with a universal screening program for hearing for all babies, not just preterm or high risk, but for all babies. And also remember that mild hearing defects can present just with delayed talking. So before you assure the parent that everything is going to be all right, we must advise a hearing test. The second thing that you should do immediately when you have this complaint is to rule out dysarthria. It's not very difficult to rule out dysarthria. Dysarthria occurs secondary to brain injury, and usually you'll get a very typical clue in history or in a good neurologic examination. The other thing that you can consider is speech dyspraxia, which is a very rare condition, but it is a condition to be considered because this condition exists in an apparently normal child with speech delay. And dyspraxia occurs because of an inability to execute oromotor functions, functions of the oromotor muscles. So dyspraxia is actually the inability to use the oromotor muscles to speech. And a very good clue to dyspraxia would be you would suspect this condition. As I told you, when there is no history of brain injury in the developmental period. Also, since the same oromotor apparatus is used for eating and feeding as well, such children will have significant difficulty in chewing and swallowing and sucking. So in such children, ask history of feeding difficulty. These children will also have a lot of drooling because, as I told you, there will be a problem with swallowing. So right away, when a child walks in with a history of not talking well, you rule out these conditions. It doesn't take much time. When you rule out these conditions, what you are left with is three important causes of not talking on time: intellectual disability, autism spectrum disorders, and language disorders. Intellectual disability is easy to pick up when it is in the severe variety, but mild intellectual disability may present only with delayed talking, and it's very difficult to pick up, particularly in a pre-verbal age where IQ test cannot be done. So I would like all pediatricians to remember that in the developmental milestones, there are some milestones which are listed under cognitive function. So pay attention to these particular milestones. Ask parents questions about these to pick up mild intellectual disability. Once you feel that this is not likely to be a case of mild intellectual disability, you move on to considering the possibility of autism spectrum disorder. Now, considering the frequency with which autism spectrum disorder is suspected in our regular OPDs, one would think that this is a very uncommon condition. We pediatricians tend to identify Down syndrome more frequently than autism spectrum. And let me tell you that Down syndrome incidence prevalence is 1 in 300. And And the prevalence of autism in India also is given as 1 in 50. So more pediatricians should be diagnosing autism spectrum disorder. Now, the reason why many of us do not identify ASD is because it is a spectrum. A very simple questions to ask the parent who comes to you with the complaint that the child is not talking are some of these. I've listed the commonest 5 here. Does your child respond to name? You've ruled out hearing defect, and if he still doesn't respond to name, you consider ASD. Does your child ever use its index finger to show something? Does your child ever bring a toy over to you to show you? Does your child pretend to talk on mobile? Or does the child engage in imaginative play like feeding a doll? Or does your child prefer to play alone? These are some of the questions which will help you point towards the possibility of autism spectrum. What about language in ASD? There is a spectrum of language development in children with ASD. Some children have no language development at all. Some have delayed language, while some develop language and then have regression of spoken language. When they do develop language, there is a monotone or a sing-song way of speaking, and there is plenty of echolalia. These children also have a lot of non-speech vocalizing, like they squeal a lot intermittently. Now, also these children tend to communicate physically, and then also they communicate only for their needs. So they will take the hand of the adult to go to the pot of water rather than asking for water. And this they will do without any eye contact or spoken language. Now, both these, all that I have told you about ASD may exist. All these symptoms may exist without having autism spectrum disorder. What is required compulsorily, in addition to what I've told you, is the presence of restricted repetitive behavior. If this is present in addition to all that I've told you, then it is more likely to be autism spectrum disorder. These children have repetitive actions as I have listed here. And of course, there are very simple, freely available, downloadable tools to screen for autism spectrum. And of course, diagnostic tools are also available, which are validated for Indian children. Now, if you have considered and ruled out the possibility of autism spectrum, what remains as a major consideration in all these children is language disorders. The DSM-5 says that you should consider language disorder as an etiology only when you have ruled out cognitive, intellectual disability and autism spectrum disorder. Now, language disorder, as I've given here in this chart, is also known as specific language impairment or SLI. When do you suspect SLI in a child? As I told you, the child would be apparently normal, would not have any significant birth history. The child will not have intellectual disability. The non-verbal cognitive level of the child would be very good, and the child will not have any features of autism spectrum disorder. So how do you suspect language disorder? This would be in a child who speaks, but when he speaks, he's not able to use grammar well. Now, we know what grammar is. Grammar is use of putting words in the logical sequence so that meaning is conveyed. So you have a subject, you have a verb, and then you have object. Now, children with language disorders have a problem, syntax problem. That means they cannot use speech in the right grammatical sequence. So they are largely unintelligible. They know what they want to say, but what comes out is unintelligible. They also have what is known as phonological disorders. When they use words, there are a lot of errors of commission and omission. For example, instead of banana, they'll say nana. Instead of elephant, they'll say ambitan. Now, they mean elephant. Only the parents will know that when they say ambitan, it means elephant. So there are errors like this in their expression. There are errors in syntax. And also some children have inappropriate language, like socially inappropriate. They use language in a socially inappropriate way. So this constitutes SLI. When you have a child with this kind of language, suspect SLI. Now, most children who have language disorder are late talkers, but this does not mean that most late talkers will have language disorders. We have to carefully use the differentiate between language delay and language disorders. So I finally come to the most common cause of not talking, and that is developmental language. After you have ruled out all other conditions that I have told you, usually there is a family history of you, not all the time. Sometimes there's a family history of language delay, and there is
मास्क
a
लगा के बात कर रहे तो क्यों चुप चुप बोल रहे?
suspect language. This is my last slide, so I think second last slide. What is important to to consider maturational delay is to remember the upper limit of language acquirement. And how do you know that the child has reached 75% of the expected? There's a very simple rule of thumb. When a child skill expected in 18 months is not achieved in 24 months, you do 18 by 24, it is 75% of expected. You know that this is not language delay, but this is disorder. If these you have evidence of these points, then you can assure the parents that your child's language delay will quickly get resolved on its own without intervention. I am not going to go into this. This is a very good way of remembering language milestones, but because of lack of time, I am not going to go into it. To summarize, a child walks into your OPD with delayed talking, and you find no abnormal history, no specific findings on physical examination or neurologic examination. Suspect these 5 conditions. Just one word about hearing loss. Children, even with severe hearing loss, they have normal pre-verbal vocalization till 6 months. They will babble, but it will beyond 6 months, they start becoming quieter and quieter. Then you suspect hearing loss. In all other conditions, I have already given to you. Thank you very much.
Okay, can you hear me? Thank you, Meenakshi Madam, for that wonderful and lucid presentation. You really did a justice with that practical problem, and I think most of us too got the answers of most of our questions. I think you have given a very clear-cut message that we must do the hearing screening in specifically all the NICU graduates and small babies. Then we should look after many other conditions also without before saying that it is a maturational language delay. And how to suspect for the autistic spectrum disorders. I think that also you have very wonderfully explained. So I don't think there are any questions anymore. Any questions? Any questions? So there are no questions in the chat box also. So I thank you. I thank Dr. Meenakshi Madam for that wonderful presentation, and hand over the mic and hand over the session for the next speak. Next week.
Thank you, sir. Thank you, ma'am, for the informative session. Next session, a topic for the next session is My Child Has Allergy by Dr. Rajkumar Kiratkar, sir. And the chairperson for the session, Dr. Yogesh Papde, sir. He is a senior pediatrician from Nagpur and consultant in Shortech Hospital. Sir.
Good afternoon, everybody. Am I audible?
Yes, sir.
Yeah. Good afternoon, everybody. First of all, thanks to AOP for giving me this opportunity. I introduce Dr. Rajkumar Kiratkar. He is working as a pediatrician, neonatologist, allergy and immunology in Kingsway Hospital, Nagpur. He was also past secretary of our IIP Nagpur, and also is a teacher in IGMC. Kiratkar sir, please start your lecture. Kiratkar sir.
Yes. Okay. Good evening, everyone. Thank you, Yogesh sir, for your kind words. Let me thank Dr. Shubhada Madam and Mustafa, Secretary of IIP, for giving me this opportunity. I will try to finish it up in a given timeline. It is just overview of your allergy. That is, my child is allergic. So, As a parent, as allergy is a chronic non-infectious disease, they may have multiple consultations with their pediatricians, general practitioner, and from everywhere they are listening that this is allergy and ये तो ऐसे ही रहने वाला है. Most of the time, it is the answer they are hearing. So I will try to sort out some of the queries of the parents. That is, what is allergy? Is it curable? Outdoor and indoor allergens, something about that. And what are the spectrum of allergic diseases in children? Our diagnostic tests are available in Nagpur. What is SPT, that is skin prick test? Can I do spirometry of my child, that is impulse oscillometry? Yes.
Pardon me, sir. Sorry to interfere. Please make your presentation full screen.
Okay.
Yes. Right, sir. Go ahead.
Okay, thank you. So, what is atopy and what is allergy? Atopy is increased tendency to produce specific IgE to common environmental allergens in genetically predisposed persons. And allergy is clinical expression of exaggerated immune response, which is IgE mediated in a previously sensitized patients. So, what is the spectrum of allergic diseases? This is allergic rhinitis, rhinoconjunctivitis, allergic asthma, urticaria and angioedema, atopic dermatitis, food allergy. They may have some drug allergy. As burden of the allergic diseases in immense globally as well as in India. What is allergic march? This is nothing but the natural history of atopic manifestations. That is, it is characterized by a typical sequence of Ig antibody responses and clinical symptoms. It appears early in life, persists over years, and often remits spontaneously with age. These are the typical examples of atopic march. That is eczema, which is manifesting early in life. That is within 5 years, 90% of the eczema they manifest. By the adolescent, 75% they have spontaneous remissions and 25% they remain persistent. Allergic rhinitis, they manifest little bit later in life, that is in childhood, and peaks in adolescent age group, and it remains persistent. Asthma, depending on the phenotypic presentations and high risk factors, sometimes they spontaneously resolve by 7 to 8 years old, sometimes they resolve by adolescents, and some atopic conditions with high risk factors, they persist for life. So again, food allergy manifests early in life, that is in first year of life, persists till 5 years of age. Most of the food allergy they remit, but like peanut allergy and prawns and some other allergies, they do persist for life, and there is a high chances of they are getting anaphylaxis because of food allergy. So what is seasonal and perennial? Dust mites, cockroaches, fungi, and animal dander, these are the indoor allergens, generally manifest as perennial symptoms. And grass pollen, tree pollen, wheat pollen, and fungi, they are generally seasonal and they are outdoor allergens. So what is how will you diagnose it? For diagnosis, you should take the history properly, including the geographical or the location of that patient from where he has come, and any pets in his house, eating habits, make the diary of food of that child, physical examinations and investigations. So what are the diagnostic tests for allergy? There are two types of tests. One is in vivo testing and another is in vitro testing. In vivo testing, that is skin prick test, intradermal test, prick to prick test, atopic patch test, and certain challenge tests which are done in the research laboratory. In vitro testing, that is absolute eosinophil count, total serum Ig level, allergen specific Ig level, component resolved diagnosis, and oscillometric PFT in case of asthma. Why allergy testing or SPT, that is skin prick test? This is to define or to avoid the specific allergen for specific allergy treatment, that is pharmacotherapy, to plan specific immunotherapy, and for early identification of infants and increased risk of developing allergic diseases in later life. So skin prick test, it is performed by introducing small quantity of specific allergen in epidermis by pricking. This results in binding of allergen to the specific IgE on mast cells and release of chemical mediators leading to wheal and flare. Positive skin prick tests document sensitization but do not always indicate clinical allergy. It doesn't mean that the child is allergic to that particular allergen. It is rapid in onset, reaching peak in 20 minutes and resolving over next 20 to 30 minutes. These are the indications, that is allergic spectrum, whole allergic spectrum is indications for the skin prick test. Contraindication, you should not do it after recent anaphylaxis or whenever there is a severe eczema, as skin is not available, healthy skin is not available to do that. That is dermatographism, because you will get false positive tests for all the allergens. Patient who respond to negative control, that is if the normal saline control we are using, if the patient is responding to that, it means that there will be more chances of false skin prick test. And poor patient cooperation, that is in infants, basically 1 to 2 years old child is very irritable and you won't allow. In that patient, you should, this is a relative contraindication. And patient on beta blocker. So age is no bar, that can be done at any age. Positive skin tests are smaller in infants and children than adults. Again, that the positivity declines after 50 years of age. This is grading system according to the Scandinavian Society of Allergy. Wheal size induced by the histamine is taken as positive and by normal saline as negative. So as wheal size of histamine, if that matches with your allergen, that means the test is positive. Or if it is more than 10 mm with pseudopodia, or if it is more than 15 mm, it can be taken as positive. Advantages of SPT, that is greater sensitivity, wider selection of antigen, results are immediately available, and it is cost effective as compared to the in vitro testing. So oral food challenge test, suspected for food allergy, and whether you have to add the food or eliminate the food for that purpose. Again, for those food incriminated by the history and results of SPT or in vitro testing. In that case, you have to do the oral food challenge test. It involves the ingestion of gradually increasing amounts of suspected food at set time intervals until the patient has symptoms or tolerate normal portion of food openly. Because of potential risk of allergic reactions involved in oral food challenge, it should be done in a hospital setting where all the facility for resuscitation are available. So in vitro testing, for the namesake, it is absolute eosinophil count, measurement of total IgE, specific IgE. What are the advantages? There is no anaphylaxis. As in SPT, you may get anaphylaxis or you may get certain adverse reactions. Here, you don't have that risk of anaphylaxis, or results are not affected by any drugs, because in SPT, you have to withhold the antihistaminics for 7 to 10 days. It is unaffected by conditions of the skin, that is in severe eczema, you can do the in vitro testing. Special expertise is not required, as it is a highly skilled procedure, that is skin prick test. For food allergy, specificity is very high, can be done in non-cooperative patients and in patients with non-hemolytic transfusion reactions. So disadvantages is less sensitive than SPT, and it is a greater cost, because single allergen, it costs around 1600 to 1700. If you do the specific IgE test for 30 allergen, remember the cost will be more than 60-70,000, and what we are charging for SPT is 4,000 to 5,000. So what is the treatment? That is allergen avoidance, pharmacotherapy, and immunotherapy. Immunotherapy, what are the indications? You know all the that is pharmacotherapy for that. But immunotherapy, it is very newer approach to in our central India. That is to whom we should do the immunotherapy. That is poor response to allergen avoidance or pharmacotherapy. These are the candidates for immunotherapy. Unacceptable adverse effects of medication, because allergic rhinitis, asthma, or urticaria, they may have a long-term medications, and you may have certain that is the adverse effects. Or in allergic rhinitis, you may have eustachian tube blockade, there is sleepless night, school performance is delayed, quality of life is decreased. In that situation, you may think of immunotherapy. That is desire to avoid long-term pharmacotherapy, reduce the cost of medications, coexisting allergic rhinitis and asthma, and prevention of further sensitization. So the question is allergy curable? It's not really, but we can achieve what? We can control it very effectively. We can even reverse the disease manifestations. We can stop the progression of the disease process. We can halt the allergic march, and we can prevent new sensitization. So it's as good as cure, but you can't label it as it's curable. So what are the take-home message? That is, diagnostic testing is helpful in confirming the allergy basis. Total IgE testing should not be used as a diagnostic tool. Skin prick test is cheaper and highly sensitive than radioallergosorbent test. Contraindications of SPT are the indications for blood testing. Intradermal test should be used only when SPT is negative and history is highly suggestive of allergy. That is, patch skin testing is helpful in diagnosis of allergic contact dermatitis. Therapy for allergic diseases is available. It needs proper selection of patients and standardized antigen should be used. And patients' compliance is needed. The whole gamut of allergic testing and immunotherapy is now available in your city. Thank you very much.
Thank you, Kiratka sir. You have explained it very nicely. Also, you explained the difference between atopy and allergy, how to pick up early patients who are having allergy, how to diagnose, what are the different modalities of diagnostic test, and how to treat the patient. I think due to lack of time, questions, only one question you can answer. At what age skin prick test can be done? At what minimum age?
1 year.
Okay.
After 1 year, you can do the skin test.
Thank you, sir. You have given nice lecture. Very, very thank you. Thank you, sir.
Thank you very much.
Thank you, sir. Our next session will be by Dr. Hari Mangtani, sir. The topic will be My Child is Obese, and the chairperson for the session, Dr. Shripad Jagidar, sir. Sir is the director at Hope Hospital, Amravati, and Mahapedicon 2019 organizing secretary. Please,
Good morning, good evening. It gives me immense pleasure to introduce very dynamic endocrinologist from our own area, Dr. Hari Mangtani. Dr. Hari Mangtani is authority in pediatric endocrinology across the India. He has got many credentials in his academic achievements. To name few, recently 1 year back he has completed fellowship in pediatric endocrinology from Liverpool, United Kingdom, and he has also completed a course on clinical genetics from SGPJ Institute, Lucknow. So let's hear directly from Dr. Hari Mangtani about My Child is Obese, pediatric endocrinologist par excellence and authority across the India. Welcome, Dr. Hari Mangtani. Please start your topic.
Thank you so much, Dr. Shripad, for that wonderful introduction. Actually, I am not the authority basically, but that is a big thing to hear. Now, I would like to thank AOP Nagpur for giving me this opportunity, and without wasting time, I'll just go through the presentation of My Child is Obese. Now, this question actually does not come from parents, and what I believe is this patient, this is coming from a pediatrician, because parents, they never believe that their kid is obese. So what are the pertinent questions one should ask? Now, can you see my screen and can you hear me?
Yes, sir.
And screen also is visible because this is not moving.
Yes, sir.
I just have to, some technical glitch, no? This always happens, I don't know. And happens, yes. So what are the most pertinent question when we encounter obesity? There, why obesity is a concern, why we should be concerned about obese child, when to label a child as obese, and how to diagnose and discern the cause of obesity if we diagnose it, and what should be done for the management of obese child. So why obesity is a concern? We know obesity is a risk factor for later heart disease and other chronic condition, and they contribute to mortality, morbidity, and poor quality of life. So what are the comorbidities and complications we observe in patients with obesity? The most important are insulin resistance, metabolic syndrome, and type 2 diabetes. Most commonly, they come with hyperlipidemia, like hypercholesterolemia or hypertriglyceridemia. There can be hypertension and early atherosclerosis. They may suffer from orthopedic or musculoskeletal complications. And PCO is very commonly seen nowadays with insulin resistance in girls of pubertal age group. Now, NAFLD, that is non-alcoholic steatohepatitis, is also a very common thing and often missed in during investigations, and rarely we can get cholecystitis and pancreatitis. So what is the burden of obesity? Now, India is a fast-growing economy, believe it or not. So we are undergoing a major epidemiological, nutritional, and demographic transitions. And these transitions, they promote obesity in all age groups, in fact, at all the areas, including the urban and the rural kids. The prevalence has been variably reported to be 6 to 22% for overweight and 3 to 14% obese. But the most important thing to know here is overweight and obesity rates in children and adolescents are increasing. And this childhood obesity and related comorbidities, they can track up to adulthood. So when to label a child as obese? Coming to the definition of obesity, in 1998, WHO gave a definition of obesity as a condition with excessive body fat to an extent that health and is being adversely affected. So it actually comes down to 20 to 25% fat in males and 30% of fat in females, which suggests obesity. Now, central obesity or visceral fat or intra-abdominal fat is more pathogenic, and thus we as South Indians, South Asian Indians have a special status. I'll come to that in subsequent slides. Now, percentage of body fat, that is adiposity, is dependent on weight, height, age, sex, and pubertal status. Now, what are the methods to determine adiposity? They can be, that is determining exact percent fat is, they can be costly like CT, MRI, DEXA, or air displacement plethysmography. They have poor reproducibility like waist-hip ratio, and they lack extensive normative data in children, that is bioelectrical impedance. So the ideal definition of obesity when we are considering based on percent fat is impracticable in the clinical and epidemiological use. So there is a surrogate marker or surrogate measure of body fat percentage, that is BMI, which is calculated at kilogram divided by the height in meter square. A few points about BMI. It is an elevated BMI is indicator of overweight, then over fatness, and it does not differentiate between the fat and the fat-free mass. It gives no idea about the distribution of fat also. So whether the person has got central or a peripheral obesity, it does not give any idea, but it is easy to use in the clinical practice. So we use BMI as a surrogate for diagnosing or defining obesity. Now, what are the cutoffs? So for under 5 kids, IAP and Government of India adopted the WHO MGRS standards, which were published in 2006. And for children between 5 to 18 years, WHO stated that it won't be possible to have a prescriptive standards, and thus we require a country-specific charts. So for the BMI, using the International Obesity Task Force approach, IAP along with Dr. Kadilkar, they produced a BMI chart, and these percentile lines like 3rd, 5th, 10th, 25th, and 50th percentile charts were produced. And in addition, there are two cutoff lines for 23 adult equivalent, that is overweight cutoff, and 27 adult equivalent obesity cutoff were also designed. And these are under the recommendation from WHO and IOTF for Asian Indian overweight and obesity cutoffs. Now, these are the charts which we see, the WHO 2006 chart for 0 to 5 years, and they've got cutoff for obesity. For girls is pink, and boys it is blue. And these are IAP BMI charts, which is from 5 to 18 years. Now we can actually see the orange cutoff here, that is 23 adult equivalent for overweight and 27 adult equivalent for obese. And Asians, because they are more prone for adiposity and central obesity at lower BMI, that's why the cutoff has been reduced from 25 and 30 in international recommendations to 27 and 23 respectively. Now, how to diagnose and discern the cause of obesity? So we have to measure the height and weight of a child accurately by a calibrated, well-maintained instruments. We have to calculate BMI, that is kilogram per meter square, plot on appropriate charts, less than 5 years WHO charts and 5 to 18 years IAP charts, and classify as normal, overweight, obese based on the position of the chart. Now, after we have diagnosed them as overweight and obese, we have to evaluate and confirm further. Remember that WHO has given you the two definitions. I mean, one definition which has got two components, whether it is obesity and it is causing, it has a propensity or potential to cause affection of the or causing comorbidities. So we have to evaluate and confirm the presence of metabolic derangements as well as comorbidities once we have seen the BMI and clinical evaluation. So how do we evaluate an obese child? Now, metabolic syndrome is constellation of metabolic abnormalities that confirm the increased risk of cardiovascular disease and diabetes mellitus. And BMI we know is weight dependent, and thus we require additional parameters besides BMI to diagnose metabolic syndrome. So International Diabetes Federation criteria for metabolic syndrome is abdominal obesity, which is central to the criteria, which is essential criteria to diagnose metabolic syndrome, that is waist circumference more than 90th percentile for age, gender, and ethnicity, plus 2 or more of the following, that is triglyceride more than 150 milligram per deciliter, HDL less than 40, blood pressure more than 95th percentile adjusted for height, age, and gender, fasting glucose which is more than equal to 100, or type 2 diabetes mellitus. Remember that metabolic syndrome should not be diagnosed in kids less than 10 years of age. Now, coming to the etiology of obesity, we have got two major etiologies, exogenous and endogenous. Now, exogenous obesity happens because of chronic imbalance between energy intake and expenditure, which is the commonest variety of obesity we see. Happens because of sedentary lifestyle, lack of physical activity, consumption of calorie dense and sugary food. Few medications like glucocorticoid, antipsychotics, antiepileptics, they can cause obesity, and there are adverse metabolic programming which happens in kids who are born SGA, small for gestational age or large for gestational age. These are the major causes of exogenous obesity. Coming to causes of endogenous obesity, it can be monogenetic disorders like leptin deficiency or leptin receptor deficiency, MC3 or MC4 are mutations. They can be syndromic like Prader-Willi, Biddle-Barrett syndrome, Edstrom syndrome, Cohen syndrome, or Carpenter syndrome. It can be classical endocrine disorder, but the most important, short stature and growth failure is a prominent feature than obesity and happens in hypothyroidism, Cushing syndrome, growth hormone deficiency. We can get insulin dynamic disorders, which are classified as hypothalamic obesity or insulin resistance or leptin resistance, and other rare disorders like Rohat syndrome can be the cause of endogenous obesity. Now, endogenous obesity constitutes around 10% of the causes of obesity. Remaining 90% of the causes are because of the lifestyle. It's a lifestyle disorder. So what are the pointers in history that point towards the underlying etiology? If it is early onset, it can be monogenic or syndromic, and it is rarely endocrine to cause if we see obesity less than 5 years. Now, hyperphagia and food for aging behavior can be seen in Prader-Willi syndrome or monogenic syndromes, and syndromic also obesity is also pointed by dysmorphism, intellectual impairment, and significant behavioral problems. A history of low birth weight, hypotonia, and feeding difficulties in the neonatal period point towards presence of Prader-Willi syndrome, and dry skin, constipation, cold intolerance can point towards hypothyroidism. We have to also take history of comorbidities like polycystic ovarian syndrome is suggested by hirsutism, irregular menses, polyuria, polydipsia, and type 2 diabetes point towards presence of type 2 diabetes. Unexplained headaches can be because of hypertension, and sleep apnea can be diagnosed by history of snoring, restless sleep, and morning headaches. The gastrointestinal discomfort, it points toward non-alcoholic fatty liver disease. So these are the comorbidities which we have to ask on history. What are the examination findings which point towards the cause and comorbidities is, if the obesity is there in a short child, then it is more common. It is more commonly because of endocrine disorder or syndromic disorder. Hypogonadism and buried pen is seen in syndromic or monogenic causes. Hypertension is seen in Cushing syndrome and exogenous obesity, and also Cushing syndrome will come with fat deposition over nape of neck and the purple or stria. Now, acanthosis, presence of acanthosis nigricans and skin tags point towards presence of insulin resistance. So this is the most important slide. How do we evaluate a kid who is for etiology and comorbidities? We have to check for hypothyroidism and do a free T4 TSH in all the kids who have come with obesity. Growth hormone deficiency, if suspected by auxology, we have to perform a growth hormone stimulation test. Blood and urine cortisol for Cushing's disease. If there is suspected CNS lesion, we have to do an MRI. Brain and pituitary. Genetic syndromes like PWS can be diagnosed by DNA methylation studies. Monogenic obesities require further genetic testing for MC4R gene and leptin levels. Hepatic steatosis as a comorbidity by SGPT levels and hepatic ultrasound. Type 2 diabetes as diagnosed as fasting glucose more than 125 or a 2-hour glucose more than 200 or HbA1c of more than 6.5. Dyslipidemia can be done by fasting lipid profile by triglyceride, cholesterol, LDL levels and HDL levels. So how do we manage once we have diagnosed the cause and diagnosed the presence of comorbidities? A combination of a diet modification, physical activity and behavioral therapy is required, because most of them, they have exogenous obesity and it's a lifestyle disorder. The family, school and community, they play a very important role and all should be involved. So what does the recommendation say? We have to involve the whole family. It should not happen that because the child is obese and he is suffering from metabolic syndrome, then he should be labeled or he should be told or directed to avoid certain things. It is the whole family, it is responsibility of the whole family that we have to educate them about the healthy eating habits. We have to tell them that they have to avoid calorie dense and nutrient poor foods and reduce unhealthy portions and in between meal snacking. There should be at least 20 minutes and optimally 60 minutes of vigorous physical activity for at least 5 days in a week. And we have to limit the non-academic screen timing, because screen timing now, most of the kids, they are sitting at home and attending the online classes. We have to limit the non-academic screen time for less than 2 hours per day. And the screen time is not recommended for any kid who is less than 2 years of age. What pharmacotherapy we can offer is the prerequisite should be BMI of more than 27 with comorbidities or BMI more than 30, and it is not improved on intense lifestyle modification. The safety and efficacy data of pharmacotherapy is limited, but metformin is the most commonly used drug for type 2 diabetes or insulin resistance. It is not given only for obesity, and the dose usually is 250 to 1000 milligram twice a day orally. Now, orlistat can be given after the age of 12 years at the dose of 120 milligram BD, but the adverse events are more of a concern, like flatters, fecal incontinence, oily or spotting of the undergarments, and vitamin malabsorption. Liraglutide is a recently used GLP-1 analog, and it has to be used in the research setting or under guidance of an endocrinologist. Pediatric surgery in adolescents who have crossed the Tanner stage of 4 and 5 and achieved a nearly target height qualify for undergoing bariatric surgery if they have got BMI of more than 40 or if it is more than 35 with significant comorbidities. Now they have continued, they are supposed to continue healthy diet and activity habits, and a multidisciplinary team is required, which involves surgeon, medical, nutrition and psychological experts. Now the procedures can be purely restrictive, which is most commonly performed, like reduce the stomach capacity to decrease the volume of food ingested, and it is laparoscopic adjustable gastric band and sleeve gastrectomy. Purely malabsorptive are not recommended now these days, and combination of Roux-en-Y gastric bypass is a difficult surgery to perform. Now, to summarize my talk, childhood obesity has its basis in genetic susceptibilities influenced by a permissive environment starting in utero and extending throughout childhood and adolescence. Endocrine etiologies are rare, usually accompanied by attenuated growth patterns, genetic screening, or of rare syndrome in presence of specific history or physical features of a underlying genetic cause. BMI is the simplest method to identify excess adiposity in the clinical setting, and waist circumference provide additional information about presence of a metabolic syndrome and underlying cardiovascular risk. So pediatric comorbidities, as they are common, and screening should be done for them for early identification before more serious complications result, and the prevention of pediatric obesity by promoting healthy diet, activity and environment is required. And it is the family should be involved, not only the kid. That is the most important thing, because most of the parents, they restrict the kids and they enjoy themselves. So that should not happen. That is the most important take home. Thank you so much for your patient listening, and for any questions, I'm happy to answer. Hello.
Very well described, Dr. Hari sir. It was really interesting to know various aspects of childhood obesity. And very importantly, you have mentioned that involvement of the family is very important for the man during the management of obesity. I think this should be the take-home message for all the parents. And while screening obesity, different aspects causes should be ruled out. Any questions from audience we can take, or otherwise we can shift to Dr. Sonia for next session. Thank you very much. Very good talk.
Thank you, sir.
Thank you so much.
Thank you, sir. Our next session, My Child Has Constipation by Dr. Anand Bhutra, sir. And chairperson for the session, Dr. Abhilasha Gaudare. She is a pediatrician at Chandrapur, Director, Chandrapur Critical Childcare. At present, she is Secretary of IIP, Chandrapur.
Yeah, it's a great pleasure to introduce stalwart in pediatrics, Dr. Anand Bhutra. Actually, he doesn't need any introduction, but it's complete the formality. I would like to introduce him. He's a consultant pediatrician, intensivist, and neonatologist in Nelson Mother and Child Care. He is he's a faculty, national faculty for NRP, BPIC, HOPE, pediatric stimulation, TIPS, NIV, FPICC, PICU, and NICU. He is author to many articles in few textbooks and even many publication in index journal. He has been writing in critical care in IIP textbook. He is secretary to PICC Nagpur 2016, 17, 18, 19, 20. He is NNF accreditation assessor and executive body member IIP Nagpur for 14, 15, 15, 16, 18, 19. So I like I welcome Dr. Bhutra sir, and please the dice is yours, sir.
Anand sir, unmute yourself.
Dr. Anand, please unmute yourself.
Now, hope I am audible now.
Yeah.
Yeah. So the constipation is a common problem, and we have now even a popular Bollywood movie on that. And the parents keep on saying, "Hui kya?" and the mother keeps on giving expression like this. So how big is the problem? The constipation is one of the most common chronic disorders of childhood, affecting almost 1 to 30% of children worldwide. The data collected from various publications, and it's responsible for nearly 3% of all primary care visits for children, even in India, and it amounts to almost 1/4 of the pediatric gastroenterology visits. 85% of this childhood constipation are functional, and good detailed history and examination is key in managing this problem. Causes of constipation in children are multiple, but as we have seen that functional constipation is most common. Other than that, there is a huge problem. First, motility related problems like Hirschsprung disease, some myopathies, congenital anomalies like anal stenosis, anteriorly located anus. These are the anomalies which must be picked up right at birth, if you miss that, a very careful examination may give us the clue. The spinal cord anomalies like meningomyelocele, myelomalacia, spina bifida, especially when they are occult, it's difficult to detect. Neurological problems like cerebral palsy, mental retardation, there are endocrine problems, especially thyroid, diabetic, hypercalcemia, or renal tubular acidosis causing hypokalemia. Multiple drugs are also associated with constipation in kids, especially opioids. How do we define constipation? There are multiple definitions for constipation, and the common one for the patient, the parents, they are subjective. The child is passing consistently hard stools, delayed stools, and it's a painful stools for them. That they believe that's constipated. The child is constipated, but then Rome-3 diagnostic criteria is universally accepted for a functional constipation in children. The definition differs from those who are less than 4 years and those who are more than 4 years. As far as the duration is concerned, that's for 1 month or more than 2 months, it should be 2 or less defecation per week, at least 1 episode of fecal incontinence per week, history of retentive posture of stools, withholding maneuver, history of painful to hard bowel movement, presence of large fecal mass in the rectum, or history of large diameter stools that may obstruct the toilet. That's also one of the criteria. History is very important and can give clues to many diseases, like getting component on history like frequency, consistency, and size of stools. If you have large hard stools, it suggests that signs of withholding behavior, and it could be functional constipation. If there are normal bowel movement frequency, but the frequency is increased, then it may suggest irritable bowel syndrome. Age at onset may also pick up. Like if someone is constipated in less than a month of age, then probably it's organic in origin. Pain or bleeding with passing stools, then it could be inflammatory bowel disease. Pain in abdomen may point to multiple disorders, including inflammatory bowel diseases. Passing first stool after birth, if it is delayed, then it may suggest Hirschsprung disease. Both during history as well as examination, I'm cutting short the presentation, we have to look at certain red flag signs. If there is onset before 1 month of age, it's very important when in OPD we are looking at. If there is failure to thrive, the first stool is passed more than 48 hours of age. There is abdominal distension significantly. There is history of intermittent diarrhea with explosive stools, blood in stools, or there is appearance of extraintestinal symptoms like fever, vomiting, ill appearance, and there is no history of withholding behavior. On examination, if we find empty rectum, there's tight anal sphincter or pilonidal dimple covered by the tuft of hair, a midline pigmentary abnormality over the lower spine, or an abnormal neurological examination, especially absent anal veins, then these are all red flag signs, and this must be evaluated. Should be thinking something other than functional constipation. If there is no response to treatment over 3 to 4 months, then again this can be considered as a red flag sign. How to manage these kids with constipation? The principle is that it has to be managed with multiple aspects, and parents must be trained, explained about what is normal, what is not normal, because passing few stools in a week may not be a constipation. So first we must define constipation. If it's there, explain them what needs to be done. For the kids who are beyond infancy, then the diet, increasing the liquid in diet, high fiber content in the diet, having regular physical activity, proper toilet training, and behavioral modification, especially
all this
must be taught behavioral
मुस्तफा सर मेरा
modification
थोड़ा ऑलमोस्ट डिस्चार्ज होने
and
जा रहा है। अगर मैं लैपटॉप से ट्राई की ज्वाइन होने
pharmacological
के लिए
therapy
नहीं हो पाई तो
should be considered
पंकज को बोल दीजिएगा
for
लास्ट
those
देखने के लिए।
who are having
हाँ
species
ठीक है सर, हाँ
impacted.
मैं कोशिश कर रही हूँ
First,
आपको
we
ज्वाइन
need
होने
to
की।
go for a de-impaction and unload the bowel first, mostly with oral therapy and sometimes with enema. If there is no impaction, then we can straightway go to the maintenance therapy. Maintenance therapy should last till the child is symptom-free for at least 2 months, and thereafter it should be gradually weaned. If there is no response, then we should go for the workup and refer the kid to the specialist. I'm not going to go into the depth of this flow chart, which is given by NAPCON, and for those who are less than 6 months and more than 6 months, it's basically thinking about disorders like Hirschsprung and other organic disorders in kids less than 6 months. Look for the red flag signs and treat accordingly. For those more than 6 months, again, careful history examination, look for the red flag sign and use of, if it's impacted stools, go for a de-impaction and thereafter maintenance doses of laxatives should continue. And all the time, the behavioral modification must continue along with dietary changes advised. These are the drugs which are commonly available, and the most preferred right now, the drug of choice is PEG, that is polyethylene glycol, for disinfection. The doses for disinfection and the maintenance are different for majority of these drugs. For PEG, it is 25 ml per kg per hour or 1 to 1.5 ml a gram per kg for 3 to 6 days. And once it's disinfected, the maintenance is 5 to 10 ml per kg per day or 0.4 to 0.8 gram per kg per day. And the doses are there for lactulose, which is the second in line, then Sena, Bisacodil, milk of magnesia, but then the other ones are less preferred and they have their own issues as well. What we call it as refractory constipation, if there is no response to optimal conventional treatment for at least 3 months, then they are called as refractory constipation, and these cases must be investigated thoroughly, and they may have the problems like motility disorders, endocrine disorders, sometimes functional disorders, or some anatomical disturbances. And it's right to appropriately refer such kids to the specialist like pediatric gastroenterologist or pediatric surgeon or a neurosurgeon. Thank you. We must continue to take caution even if the COVID cases in Nagpur have decreased and majority of us are back to our work. Thanks.
Thank you so much. Thank you so much, sir. You thoroughly described the all few concerns which are always should be taken care in very few minutes. Thank you so much.
Next speaker is Dr. Yogesh Tembekar. I will hand over the mic to Dr. Sandeep Gola. He is the next chairman. He is associate professor in Government Medical College. And I hand over the mic to Dr. Sandeep Gola, sir. Sandeep Gola,
hello, everyone. Am I audible? Hello, am I audible?
Yes, sir. Yes. Yes, sir.
Yes, sir. I introduce my next speaker, Dr. Yogesh Tembekar. He did his MBBS from GMCH from 96 batch and is an MD from Grand Medical College, Mumbai. He's a fellow in pediatric nephrology from Wadia Hospital, Mumbai. He has extensive clinical experience and research papers in international journal. He is working as a pediatrician, intensivist, and nephrologist at Health City Hospital. And he is going to deliver his topic, My Child Has Increased Frequency of Urine. Yogesh, over to you. Yogesh? Hello? Are you there?
Dr. Yogesh? Hello? Can you hear us, Dr. Yogesh? Hello?
Yogesh sir, we will present the slide from here.
Hello. I think he left. Please bear with us. We are trying to contact him.
There must be something wrong with his connection, Anand.
Hello.
Hi, Yogesh.
Hi, sir.
I have introduced you. Please go through your. Please speak about your topic.
Hello.
Hello, Yogesh.
Yes, sir. I can hear you, but some problem with presentation.
Yeah.
Let me check with it. So. Hello. Mustafa sir, can you run my presentation, please?
Yogesh,
Hello.
check your video. Your video is off. Just start your video from your screen.
Yes. Hello.
Yes, you are visible now. Okay, go ahead.
Can I have my presentation here? I can see my presentation over here. Hello. Hello. Hello.
Sir, we cannot hear you.
Sir, can you hear me now?
Here, his slides are not visible. He is audible now.
Hello. Ha, Mustafa sir.
Yes, sir. We are putting the slide from here.
Okay.
Yes.
Okay. Okay. Yes. Yes. Thank you. So good evening, everyone, and sorry for the disturbance. Actually, first of all, I will congratulate Team IIP for the all good, successful work done in the last 1 year, and I'm thanking to all of them to just give me chance for this presentation. Today, the topic which is given to me is the increased frequency of micturition or increased frequency of urination. It is one of the most common urinary symptom that the parents come with their kids in the OPD. And most of the times the parents as well as the kids are anxious just to know what is the cause behind the increased frequency of micturition. So not the bookish picture, but categorically, logically, there could be 3 to 4 important causes which causes increased frequency of micturition. First of all, any increase in production of urine will cause increased production of urination. That is very simple logical thing. So all the disease or illness which causes increased production of urine, like all DI, all diabetes insipidus, mellitus, will cause increased frequency of urination. That is important thing. Secondly, the decreased capacity of the bladder. Anything which decrease the capacity or alter the capacity of bladder will increase the frequency of micturiation. And third important thing is irritation of the bladder wall, bladder mucosa or urethra mucosa, like urinary tract infection or other things which can causes irritation of the mucosal thickening, which causes increased frequency of micturition. Apart from these categories, before moving further ahead onto the discussion, we should know what is normal frequency of micturition, and what is the abnormal frequency of micturition in a normal child. Can you run next slide, please? Okay. So any child, I will just start with some clinical approach to such patients. Mind you, even if you go through all the causes, in 50 to 60% of the cases, we can get the diagnosis with only clinical history and good clinical examination. And almost in all patients, we can lead to the diagnosis with our clinical examination and history. So history is very important in such patients. First of all, as I mentioned already, age is very important factor, because sometimes increased frequency of micturition may be up to 20-24 times, could be normal in a newborn child, but it could be abnormal in an older child. Older child frequency may be varied from 6 to 10, older elder 6 to 10. Okay. About the diurnal variation of the whether that the symptom the child is presented to you in OPD, we should ask, because with diurnal variation, anything which changes the diurnal variation will go more in favor of non-organic causes. Because anything which organic causes, they will not have a diurnal variation. There will be consistency throughout the day, and there won't be any change in hour-to-hour basis. So diurnal variation of the symptom is very important factor to be asked in the history. Second most important is whether this symptom of onset is a recent onset for few days, or it is a delayed onset. Especially, is it a continuation process of abnormal development of the bladder, activity of the bladder? That is very important. That will just guide us regarding the bladder capacity and all these things. Whether there are associated symptoms about a urination, is there any accidents, is there an urgency, is there an hesitancy? It is very important to ask about this child, because this again will pinpoint to our diagnosis to the functional bladder disorders. Again, important thing is whether this increased frequency is associated with pain or not associated with pain. Anything associated with pain is definitely an organic cause, mostly urinary tract infection or other crystal urea, which causes irritation of the bladder and they causes pain while micturition. And any other systemic that we can see on OPD examination that can be ruled out when we see the child, whether the child has lost weight recently or all these things we can see in addition to this clinical examination. Next slide, please. In a clinical examination, apart from testing vital, checking about genital organs, local examination is very important in such children. Why is that? Because if we won't do this, we can miss the diagnosis, especially like phimosis, a meatal irritation, meatal infection, or prepusal infection. And in older, in girl child, we can miss vaginal synechias, which is a very common cause of increased frequency of micturition. And sometimes even a patient with child abuse can come with the increased frequency of micturition with local irritation. So local examination of the patient is very important with due consent from the parents and in presence of the parents. It's very important. So it has to be done in each and every patient. And along with this, if you are suspecting some neurogenic bladder or dysfunctional voiding, we can again check for the spine. Next slide, please. So we'll discuss the reason one by one. Can you click one more time? Hello. So yes, norm. Before labeling this any child, whether it is abnormal or a normal, as I said before also, urinary frequency up to 20-24 times may be normal in newborn. So in that case, only reassurance is required. In older children, it could be up to 6 to 14 times. So that is not the issue with the most of the pediatrician. The second important cause is abnormal frequency in a normal child. This is the one of the most common cause for which the child is most of the times referred to me by a pediatrician with a cause with a symptoms of increased frequency of micturition. And most of the time, child has been worked up. Everything, urine routine has been done, urine culture has been done, sonography has been done. Everything is normal. But child is passing frequency quite frequently, maybe 2 to 3 times in an hour. So maybe 30-40 times in a day. Can you please click? Hello. So that we called as poikiluria. It is very well documented term and one of the common causes of increased frequency of micturition. Again, a non-organic cause means there is no obvious obvious organic cause, means there is no obvious infection, there is no urogenital abnormalities. Still, the child is passing frequency up to 30 to 40 times in a day. And how do you diagnose? It can be diagnosed only on history. This is most of the time it is recent onset history. Again, there there will be diurnal variation. As I said, diurnal variation is very, very important. In case of poikiluria, there will be diurnal variation in case of increased frequency of micturition. Suppose child is anxious, child is under stress, he will pass more and more urine, he will pass frequent urine. But child is relaxed, he is involved in some kind of activity, some like singing, play, or sleeping, the frequency will goes down. So diurnal variation, stressful child, diagnosis poikiluria, unless proved otherwise, if everything is normal. Again, this is a painful micturition. Child doesn't have any pain while micturition. And many times I notice when such kids they walk into the OPD, you can differentiate the facial expression from the child that he is some kind of stress. Something has happened to him in the recent past, maybe in the school, maybe at home. So this is very, very important diagnosis. We should not miss on OPD basis. Most of the times, reassurance of the parents only thing which is required, and just to find out what is the cause for stress is very, very important. Psychiatric evaluation will be required in very, very, very extremely rare cases. Next slide, please. Third important chunk of causes is irritation, local irritation. And this is the most common diagnosis made by pediatrician in the OPD. Any child with frequency with painful, and then they are very right. Most commonly, urinary tract infection, most common cause of increased frequency of irritation. But all irritation, all increased frequency, all painful micturition is not UTI. Many times, can you please click one more time? Hello. Yeah, one more time. Yes. All increased frequency with irritation maybe many times may be associated with some crystalluria, something like hypercalciuria, hyperoxaluria. Some crystals are going to the urinary tract, and the child is having pain as well as increased frequency of micturition. And mind you, in such children, even if you do urine routine, it will suggest there are many of pus cells and all this. Actually, they are leukocytes. They are not active infection. But clinically, you have to differentiate because child with fever will have toxic look. He will have fever. Child with hypercalcium, non-infectious irritational increased frequency of micturition will not have a toxic look. He will not have fever. He just have an increased painful micturition. Few common things which can cause increased frequency is just a bubble bath also, like in tub bath, especially in female children, can cause increased frequency of micturition because of local irritation as well. And as I said before, sexual abuse in kids can cause increased irritation with increased frequency with local irritation. Next slide, please. Now, third important chunk is increased production. Please click one more time. I won't. Hello. Yeah, please click one more time. One more time. Yes. So as I said before, also only logically increasing production of urine just cause increased frequency of urine. But I think this is not a topic of discussion for today. It requires more detailed evaluation. But all kind of DS, maybe a central diabetes insipidus or renal diabetes insipidus, maybe renal tubular acidosis, tubular damage, or diabetes mellitus or sickle cell disease. They can cause just increased frequency and increased production of urine. There will be associated systemic illnesses, systemic symptoms along with that. Child won't gain weight and everything will be there in such patient. Next slide, please. Hello. Next slide, please. Now coming to the last and important chunk of cause, that is decrease bowel capacity. Rather than decrease bladder capacity, I will say altered bladder capacity. A bladder is a special organ which is designed to store the urine under low pressure and to evacuate under whenever there is socially feasible circumstances arrive. So anything which disturb it may cause voiding disorders. It could be of two types. It could be a neurogenic one when there is an obvious defect in neuronal supply, maybe like in spina bifida, meningomyelocele, or it could be primary inbuilt bladder disorder that we call as a functional bladder disorder. And it is very important. Again, it is a very lengthy topic, but as a baseline, it is very important to differentiate this voiding disorder in two categories, whether it is a low pressure system or whether it is a high pressure system. Like urge syndrome, in which the detrusal, the bladder muscle will be overactive. There will be dyssynergia with a sphincter. So these children will have high pressure system. They are more prone for infection. There will be reflux also. In other one, the bladder will have low pressure. They are lazy bladder. They have high capacity to store under low pressure, but there will be overflow incontinence. So this is low pressure system. The treatment for the both the systems are different. So it is very difficult to differentiate between two systems. In this patient, there will be additional symptoms in addition to increased frequency of micturition, like they have recurring UTIs, they have urgency, they have hesitancy, and there will be accidents, and there will be some holding maneuvers, as you all know. Holding maneuvers, especially in girls, like Mincenty maneuvers, and there could associate incontinence in such children. Next slide. Rather than going for a lab investigation or urine investigation or urodynamic study, this is a simple voiding diary that can be practiced at home also. We can guide the parents, we can get it done from the parents. It is very, very helpful for the doctors to differentiate which kind of bladder the child is suffering from, what is the status of the bladder. If you could see first, can you give previous slide? First column is time. Now first part of the slide, that is A. Patient A, you can see urinary frequency. Child is passing small quantity of urine frequently. So what it suggests, the child has a small bladder, small capacity bladder, and along with this, there are intermittent episodes of accidents. The patient B, can you see urine volumes? The patient first pass almost large quantity of volume, 450 ml. Then he's passing small quantity of urine. Again, he's passing large quantity of urine. So what is that? Child is passing large quantity and there is small quantity of urine, which suggests there is overflow incontinence. And again, there is a capacity. So this simple exercise can differentiate which kind of bladder that we are dealing with. Again, these are investigation, but as I said, our history clinical examination will point us to go for which investigation and how to deal it further. But almost, as I said, 50 to 60% cases can be diagnosed on OPD basis. Next slide. This is over for me. This is short presentation about the increased frequency. I hope it will be useful for you. Thank you very much.
Thank you, Yogesh. This was a very crisp presentation. Because of lack of time, I'd like to hand over the mic to Dr. Changole Madam for further.
Thank you, Sandeep sir. Now this is the end of the session. I would like to thank everybody, and I would like to hand the mic to President Dr. Shubhda Khirvatkar Madam. Shubhda Madam.
So thank you everyone. Thank you Dr. Goller, Dr. Tembekar, and all the persons today who have made this first day of NAPCON 2020 a fantastic experience for all of us. All the chairpersons, session in charges, moderators, and the speakers have done a wonderful job. And I hope everyone enjoyed this academic feast to the fullest. So we conclude the first day of NAPCON here. I thank everyone for their presence. The audience rocked. You stayed with us till the very end of the day. Thank you so much.
Thank you.
Let me remind you to be present for a relaxing evening at our cultural night at 8:30 p.m. today. मिले सुर मेरा तुम्हारा. आप सबको वहाँ आना है जरूर. And it's going to be a rocking time for all of us with music. Thank you for being with us. See you tomorrow.